We all know that there are many kind of cardiomyopathies, untreatable heart diseases like the congenital heart diseases which requires transplants, and they are doing it very well all over the place. And we'll just have some kind of understanding regarding what is the magnitude of this problem, and understanding the magnitude of the problem, how we should try to sensitize ourselves so that we can probably save more lives by this innovative procedures and long-term therapy. So the basic agenda for today's discussion will be just a little bit about the whole burden of the heart failure. And when we talk about a heart failure, it is not a single disease entity, it is a spectrum of problem. Many diseases ultimately they lead to this particular condition, and we'll talk about the basic of those kind of definitions or the categories of heart failure. And once the heart failure is there for ages, but for the last couple of decades, maybe a 3 decade or 4, and particularly the last decade was actually a phenomenal growth in the heart failure treatment. Many researches has happened, many innovative compounds of the molecules have come for the rescue of these heart failure patients, and traditionally we have almost 2 to 3 decades of heart failure device therapies, whether it is a cardiac resynchronization therapy or the assist devices which has come for the rescue of such terminally ill patients. We'll talk a little bit about the indications of this device therapy, in which particular subset of patients they may be helpful, and following that we'll talk the basic about the heart transplant, what are the indication, contraindication, various kind of surgery that are performed, and what are the advantages and disadvantages of all those things, and the immediate post-operative immunosuppressions therapy. We will not talk about the long-term therapy and few other things that I have purposefully skipped because of the length of the whole discussion. So we all know that the heart failure is almost like a global phenomena. The discrepancy in the percentage of the heart failure patients in various subcontinents are purely and data acquisition problem. Like if you look at the two countries, the great countries of the world, that is the Indo-China, we are very good in statistics, so we have a data of 0.3% as compared to a global heart failure incidence of close to around 1 to 3% averagely. So we try to keep our data very, very safe and legitimate so that we look better, be it COVID, be it anything, illiteracy or whatever. So that is not the true incidence of heart failure in our country. Having millions of people in this tiny subcontinent, we expect a huge amount of heart failure patients. If it is not 2%, but definitely it will be 3 to 4%. So small sub studies have happened in southern India, like in Trivandrum. So they have got some kind of data, like it is close to around 2 to 3% of the population may be having heart failure of any spectrum. So the heart failure, the volume of the heart failure, why it has grown up so enormously in the last few decades is because of the improved longevity of the patients following a primary cardiac problem. Whether it is a coronary artery disease, because of the interventions, people are living longer with some kind of residual structural problem of the heart, like a poor LV dysfunction and so many other things. Similarly, the diabetes, hypertension and so many other cardiovascular comorbidities has gone enormously. So that may be the reason why there is an escalation in the heart failure population globally. Now when we talk about the heart failure definitions and the classification, we all know that the heart failure is a clinical syndrome, and primarily either there is a functional or a structural problem which actually decompensates the heart and causes the heart failure. So when I mean a decompensation means that doesn't mean that the LV ejection fraction has to be reduced. It can still have a normal ejection fraction, I mean the pumping function of the heart, but yet the patient can have a heart failure. So based on that, the classification of the heart failure has evolved in the recent 1 or 2 decades. So there is a component called heart failure with a reduced ejection fraction, where we diagnose the heart failure based on the echocardiographic assessment of the ejection fraction of the heart, primarily the left ventricular, also can be right ventricular. So this encompasses close to around 40 to 50% of the whole heart failure population. Now there is a subset of patient who doesn't fit into this heart failure with a reduced ejection fraction, thereby meaning the ejection fraction is above 40%. So when the person has an ejection fraction of 40 to 49%, what do we call them? They don't categorize in the heart failure with a reduced ejection fraction, so we call them a heart failure with a mid-range ejection fraction. So this heart failure with a mid-range ejection fraction again is a debatable topic, whether these are the heart failure who have actually a milder variant of the heart failure with a reduced ejection fraction, or the people who initially had a heart failure with a preserved ejection fraction, thereby meaning the ejection fraction was more initially, but as the disease has progressed, their ejection fraction has declined marginally. So whatever it is, because this is a gray zone, the treatment strategy in this population is slightly different. Then comes the heart failure with a preserved ejection fraction. Heart failure with a preserved ejection fraction are typically the group of people who has the heart failure symptoms, but they have an ejection fraction which is normal. So these are the very difficult subset of heart failure patients to be diagnosed until unless you have a thorough assessment of the baseline cardiac functions and the clinical assessment. There is a term called a heart failure with an improved ejection fraction. So as the name suggests, that improved ejection fraction means previously this patient had an ejection fraction which was lower, and by institution of the correct therapy, the patient's ejection fraction is improved. So these terms of a heart failure with a reduced ejection fraction, preserved ejection fraction, mid-range ejection fraction, improved ejection fraction, or a recovered ejection fraction doesn't mean something very, very significant, but they are very, very important so far as the chalking out the strategy for the therapy is concerned. Now when we talk about the heart failure, it all starts from the day one when you are born. Thereby meaning, if we have the risk factors for the heart failure, what are the risk factors for the heart failure? Like a hypertension, diabetes, obesity, and so many other things. So these patients, they do not have heart failure symptoms, but they are at a risk of having a heart failure. So what we typically call as a stage A of a heart failure. Then the patient decompensates and try to have the manifestation of the heart failure, what we call as a stage B, stage C, and stage D. So these stages are extremely important so far as the planning or the strategy of the heart failure treatment is concerned on a long term. There has been a loose term called a stable heart failure. The heart failure is just like malignancy. It doesn't get cured by anything. Whether you are transplanted a diseased heart, then also the risk of further decline in the heart function is still there. So heart failure is a dynamic process. Sometimes you might see that the patient is clinically stable. That doesn't mean the heart failure is stable. So just like a cancer, we can probably call it the remission of the heart failure. And once we stop the therapy at that particular time, then the patient will decompensate within couple of months or years, again back to the same square one. So this is the dynamic process of the heart failure evaluation. Now when we talk about heart failure, there are a couple of challenges. Initially in the past, when the patient used to come to the emergency room with some kind of breathlessness or features of acute heart failure, the physician or the cardiologists involved in the treatment of the heart failure, they used to dehydrate the patient so that the pulmonary congestion is relieved and the patient feels clinically better. And this process used to continue for a longer time because there was no other kind of additional therapy that was getting instituted. So, these patients, because of the dynamicity of the heart failure, they tend to come back again and again. So, when you are treating a heart failure patients in an emergency room or an intensive care unit, you must try to prevent a rehospitalization. That means you must foresee what is coming in after the discharge. If you look at the heart failure population, the rehospitalization rate is extremely high within 1 month, within 6 months. And the mortality related to the rehospitalization is extremely high, almost 5 times. So, whenever the patient is coming back into your hospital time and again, that is a red flag sign. You must be cautious that why this gentleman is coming back again and again. What are the shortcomings in the current existing therapy or the evaluation? So, that is what is very important. And the rate of rehospitalization mortality is extremely high. If you look at the mortality data of a heart failure, be it a preserved ejection fraction or a reduced ejection fraction, despite the best therapy, the mortality in 5 years is almost 50%. So, that is quite an alarming kind of thing. Because of this, the heart failure associations of US or European Society of Cardiology, they have chalked out a treatment plan for such kind of heart failure patients. Being an heart failure nurse or a transplant nurse, you may not be really deeply involved in this kind of therapeutic flow chart, but it is an extremely important because when you are incorporating any patients for the heart transplant program, you must have a tick box that whether my patient who is coming in for a heart transplant, whether he is satisfying the criteria for a heart transplant or not, or we have some kind of other modalities where we are not giving the right kind of therapy which may be responsible for the current status. So, when we diagnose a heart failure based on the echocardiography assessment or a clinical assessment, we subcategorize these patients based on the ejection fractions and we confirm the diagnosis by various biomarkers called NT-proBNP, ST2 and so on. Once we have come to a conclusive diagnosis of a heart failure, then we adopt the guideline that has been prescribed by the ACC or the ESC. Here we should not question about the guidelines because many of the physicians have a tendency to tell that we are not convinced about the guidelines. So, that is an outrageous kind of thing. You must follow the guideline. When your teacher says something in your class and you try to counter that thing, either you are an extremely genius or you are a different kind of person. So, try to follow the guidelines, and we have a nice set of guidelines where we do not have too many medications. We have 5 medications. So, if we have a heart failure checklist and we tick all the medications are there in place in the right doses or not, then we go to the next stage called the device therapy. So, out of the 100 patients of heart failure, probably 20 or 25% of the population might require this device therapy occasionally. So, we have to confirm that our drug therapy or the initial pharmacotherapy for the heart failure is in place, and we are not missing out any kind of reversible cause for the heart failure. Then once we diagnose that, we have a different set of medications for different classes of heart failure. Like if a patient has got a heart failure with a extremely uncontrolled heartbeat, then we give a subset of medication called ivabradine, which has been very helpful. This is I am talking beyond the first line of therapy, that is the S inhibitor, ARB, ARNI, sacubitril/valsartan and SGLT2 inhibitors, MRAs and beta blocker. then there will be a subset of patients who will require some additional therapy. And fortunately, there has been many innovations in this heart failure therapy that we know of. That is, many of the drugs have come, like initially in the 2014, the ANI came, which actually shown a significant improvement in the heart failure populations, so far as the mortality and the primary outcomes are concerned, like a heart failure hospitalization. So they enormously reduced the heart failure hospitalization and improved the quality of life. And then came the SGLT2 inhibitor, which is an anti-diabetic medication initially, but it has shown an equal kind of promising effect as an ARNI in heart failure therapy. And the most importantly, these SGLT2 inhibitors are very, very important for heart failure with a preserved ejection fraction, where ARNI has not shown that kind of promise till date. Now, in the recent 5 to 10 years, we are exploring many other medications. Like 3 days back, we launched the Vericiguat, and fortunately, we have started the first couple of Vericiguat in this country, in this particular zone. So there are many medications are also coming up, so that we can probably optimize our pharmacotherapy of heart failure is concerned, and that has improved the outcomes. Beyond the pharmacotherapy and the age-old cardiac resynchronization therapy in a very particular subset of patients, and that we decide based on the echocardiographic and the electrocardiographic nature of the heart failure patients, like an LBBB and so on. But that has shown some kind of limited success. Initially, after an enthusiasm of the CRT therapy in heart failure population, which was shown to be very, very effective in that population, later on we realized that probably the CRT is not for all. Then started having some kind of innovation so far as the drug device therapy is concerned, which is emerging in the recent past, like the cardiac counterpulsive therapy and vagal stimulation and so on. So these kind of innovative approaches actually has helped to reduce the mortality and improve the quality of the life quite significantly. But that has not been adopted in our current guideline till now, and probably in the future this therapy will be very, very commonly happening in our heart failure arena. These device therapies are not very intricate as compared to the cardiac resynchronization therapy, but in particular subset of patients who are actually the right candidate for such kind of therapy, they may be helpful. So this is a complicated flow chart of the patients where after the initial assessment of the heart failure based on the clinical evidence, echocardiographic evidence and pharmacotherapy, we have the correction therapy for the mitral regurgitation, which is a very common accompaniment of a heart failure, where we do a end-to-end mitral repair endovascularly, called the MitraClip, and the CCM and the other therapies that we are talking about has been shown to be very, very helpful in certain subset of patients. This is how we select the cardiac resynchronization therapy based on the electrocardiographic evidence of the electrical dyssynchrony or mechanical dyssynchrony, and there is a particular subset of patients who may be helpful from this device therapy. Now, once we have exhausted this kind of modalities of pharmacotherapy versus a device therapy, then there will be a significant population of heart failure patients who will not respond to this conventional therapies. Then comes the heart failure and heart transplant therapy. Although in our country that has not shown an enormous growth globally in India, but in a particular places or particular center that has been enormously doing well, and that has got many factors, as Mr. Diwan was actually telling us regarding the problem of organ donation and retrieval and transport. So it is not a single hospital that will be responsible for the eventual efficacy or the outcome of the heart failure heart transplant program, but as a country or as a government, many agencies should be involved to make this therapy successful. So, we will not talk about the bureaucratic angles of this heart transplant program, but we will talk about the various basic elements of the heart transplant program. We all know the heart transplant surgeries are basically categorized into two different categories, that is the orthotropic and the heterotropic. So, when we are sure that this patient has got a end stage heart disease and which is not amenable to the therapy that we just discussed right now, or maybe a surgical therapy, either a surgical revascularization or some kind of corrective therapy for the regurgitations that we see, we try to assess whether this patient actually is a candidate for a heart transplant or not. Because just visibly looking that is a failure of the treatment of the pharmacotherapy or the device therapy doesn't necessarily mean that this particular patient is a heart transplant candidate. So, we have various kind of assessment for this kind of patients, like the max BO2, and patient has got a severe underlying ischemia which is not amenable for revascularization by any strategy, whether it is a percutaneous or surgical, and if the patient has got a recurrent ventricular arrhythmias. When we talk about this third category, we had a recent boy who was just 39 years of age, very close to the Chief Minister of Punjab, very active member of the Aam Aadmi Party. He initially had a diagnosis of a dilated cardiomyopathy back in 2014, and 2019 or 2020 he got a defibrillator implanted. And after the defibrillator was implanted, he had a downhill course with close to around 56 shocks during this COVID period, and he was emotionally drained out, suicidal and very pessimistic. His ventricular arrhythmia was untreatable by any kind of medications, although we did not try the other kind of aggressive therapies like the sympathectomy and other medications. So, after a lot of counseling, he actually agreed for a heart transplant. But because of the fact he was almost getting a nice government job because of the Aam Aadmi Party, he thought that let me postpone. His kids were just 4 and 5 years of age. But because of whatever reason he went, he was about to get his heart the next day. He again had an incessant VT, and that could not be managed by this place, and he ultimately died. So, when we talk about a heart transplant candidate, we should try to look out all the possible reasons why this patient should be getting a heart transplant and he should get benefit of it. Now, in this population, suppose I would have decided for an VT ablation, whether that would have been anything meaningful impact so far as the long term survival is concerned, probably no. Because we all know the VT substrate in such kind of population can be enormous. It is humanly not possible to neutralize each and every scar. So, these are the population that we should be looking for. There is a subset of patients who may not be fitting into this three category, but they are almost there. So, these are the patients again have a similar kind of spectrum of symptoms like refractory heart failure, unstable angina, that means there is an ongoing ischemia, and the patient has recurrent heart failure hospitalizations, and in pediatric population if the heart failure falls into class 3 and 4, and in an adult population if it is class 3 and class 4, despite the optimal therapy probably you should think of. Now, coming to the heterotropic heart transplant, how it is different from the orthotropic is, the basic philosophy of the heterotropic transplant is the same as the orthotropic, with some benefit that if the patient has got an irreversible pulmonary arterial hypertension, because of an intricate right heart disease or because of the associated lung or pulmonary parenchymal disease, then these are the patients they can safely be taken for this kind of heterotropic transplants. So this is in nutshell. Because I am not a surgeon, I may not be able to tell you about the intricacies of the surgeries, but in a heterotropic basically it is a series kind of connection, and in a orthotropic it is almost like a near correction of the disease heart, where the disease heart is taken out almost totally, leaving aside some of the vital components like the left atrium and the great vessels, and the donor heart is fixed into the remaining part of the heart and stitched. So these are the quicker procedures with great success. So if you look at the advantages and disadvantages of the heterotropic versus the orthotropic heart transplant, as I told you, the heterotropic heart transplant basically is an additional heart that is given to the disease heart. I will not read out the whole thing, but to make it more comprehensible for you, when we are adding a new heart, the acute problem, whether it is acute graft rejection or the acute hemodynamic problem, that doesn't happen too dramatically in such kind of heterotropic heart transplant patients, because we have a recipient heart and the donor heart, they are there. So the in case of any kind of eventuality of a donor heart decompensation, the recipient heart still kicks on. So that is the safety of this heterotropic transplants. So there are many kind of acute problem that happens in a heart transplant, like a acute hemodynamic instability, pulmonary edema, pericardial effusions, and arrhythmias, and so on. So they are usually better compensated in such kind of heterotropic transplant patients rather than the orthotropic. It do have certain kind of disadvantages that we discussed about, like various kind of arrhythmias which are more common in these populations, and embolizations from the recipient heart. So whatever the surgery may be, because most of the transplant these days are orthotropic. So how this whole concept of heart transplant came? So it all started long back, when initially in 1950s the NIH actually started a program in the animals. Then subsequently two surgeons actually started implanting the heart, and they did it for a shorter period of time. The survival was not great, and one of the implanter got sued legally for some kind of violation. But later on, the same surgeon went on to do the best of the heart transplants and kept on going. So what they felt in this whole historical data of the heart transplant was, although the surgical part of the heart transplant was good, but the post-transplant therapy, that is the management of the acute rejection and various other complications associated with the heart transplant, was not adequate. So immunosuppression came as a rescue for a long-term survival of these patients, and from there the survival has become better. And if you look at this data of the heart transplant longevity, after the initiation of an aggressive immunosuppression or the most modern immunosuppression, the longevity has actually increased significantly, both in the congenital heart as well as in the adult heart programs. So if you look at the global data so far as the heart transplant active program is going on, there are very active centers everywhere. If you look at the Indian subcontinent also, there are some centers they are doing aggressively heart transplants. Similarly, in the most modern subcontinent like North America or Europe, there are particular centers who are dedicated for this heart transplant program, and they are doing exceedingly well, good volume of heart transplants. And if you go beyond this two subcontinents like the European and the American continents, then in the other continents they are, although they are meager, but they are increasing in number in the last few years. Similarly, the pediatric program, because many of the pediatric hospitals or dedicated hospitals like the sick kids or in the American like Seattle and all, they have a dedicated pediatric heart transplant program because they see an enormous amount of patients of hypoplastic left heart and non-hypoplastic left heart who requires a heart transplant for a ultimate survival of this patient, because there is no corrective pediatrics cardiac surgery which actually improves the outcome of these patients. So these are the population of the patients, they are seen in greater number in the current heart transplant programs. If you look at the subset of the patient who actually get the higher rate of heart transplant, it is particularly the adult kind of range like 40 to 50 years of age and maybe 60 to 70, 50 to 60 years of age. These are the patients who they get the most of the heart transplant because of the nature of the disease. If you look at an Indian data versus the other data, we are still very, very low so far as the volume of the heart transplant is concerned. And probably the awareness for a donation program, retrieval system, government venture and their help, that might help to increase our heart transplant volumes in this country. If you look at the donation, spiritually we are so that our God doesn't allow us to enter the heaven without our lungs and the heart, diseased heart and the lungs. So, as a religious mindset, we avoid such kind of things after our death. But fortunately for few people like Dr. Mr. Diwan and so many other people who are actually doing this kind of sea change so far as the mindset is concerned, so that many people are coming forward to donate their organs post death. So that probably will increase our volume of donation so far as the heart in particular is concerned, because kidney, the cadaveric programs and everything is there and we do a lot. Now, if you look at the subset of patients who are getting the heart transplants, primarily the cardiomyopathy patients, like the dilated cardiomyopathy patients or ischemic cardiomyopathy patients, they have seen a huge proportion of the heart transplants. I was involved in this heart transplant program before coming back to India, but in that particular province, we were almost transplanting all the ARVCs. I happens to be from that kind of place where there is a malignant mutation for the ARVC and none of the adult men would be alive beyond 40 years of age. So, as a program of that, as a policy of that continent, we used to transplant all the diagnosed ARVCs before the age of 35. So, we used to do a huge amount of ablation and arrhythmia management for such kind of populations. But if you look at the congenital heart disease, that is shown a great increase so far as the heart transplant is concerned, and the others are also getting better. So, if you just categorize the heart transplant volume, primarily the cardiomyopathy patients, they actually counts the whole lot of heart transplants patients, and the rest of the diseases like patients with some kind of inheritable heart disease, congenital heart disease, they are also growing. And with the advent of this immunosuppression, the longevity has phenomenally has grown, particularly in congenital heart disease patients as well as in the cardiomyopathic populations. So, as I told you, the hypoplastic left heart in the pediatric population, they counts to the maximum amount of the heart transplant in the pediatric heart transplant program. And if you look at this particular graph, this might look slightly upsetting because of the curve that is going steeply down with the mortality increasing. We still have the problem of the first initial decline, that is post transplant mortality is significantly high. But in a good program, probably this is going to be manageable, and post acute problems of the heart transplant, then there is a steady decline. That is the reason why the mortality is still not really low. So, with the innovation in the post transplant therapy and the management, probably we can make this curve looking slightly better and more positive, so that we make our post heart transplant patients live for a longer time. Now, as I told you, the heart transplant has a particular subset of patients who actually benefits from that. And as we discussed, the patient has got a terminal heart disease like a refractory heart failure, patient requiring inotropic support time and again, or domiciliary inotropic support, patient is in cardiogenic shock following an acute viral infection or whatever, and the other parameters like the VO2 max, which is less than 10, and patient continues to have a worse NYHA class despite the best of the available therapy. These are the particular subset of patients. They are the best patient who can be salvaged with the heart transplant, along with some non-treatable pediatric or congenital heart diseases like a hypoplastic left heart and so on. So, if our heart transplant indications are narrow, probably we may not be able to give this heart transplant benefits to many other patients. So, that is the reason why they have slightly broadened the indications of the heart transplant indications in various other subset of patients who actually are not truly the most sicker patients, but they have a potential to decline over a period of time if we don't institute the corrective therapy. So, that is the reason there has been some kind of soft indications like patient has severe symptoms, patient has heart failure hospitalization time and again, and so many other things. So, when we talk about the heart transplant for a particular individual, we have to balance out the risk and the benefit. Like if you are a rich person and you are 80 years of age and your folks they want a heart transplant because you can probably afford it, that is not the indication for a heart transplant. Because you have to see for the eventually the outcome of the heart transplant in that particular person. If the patient has got some kind of disease which can kill the patient within 1 year, probably that is not the ideal indication. So, if the patient is very sick and patient is logistically in a very disadvantageous place versus a patient who is a young and probably can wait for a couple of months more. So, in this kind of situation you have to balance out whether you should transport this patient who is actually sick and may not survive for a longer time because of the age or other comorbidities, or you should very well accept this young boy who has a potential to survive for a longer time and the transplant or the donor is easily available. So, it is a very crucial decision when we are talking about a donor versus a recipient and the eventual outcome of the heart transplant. So, this decision is quite a tricky decision. Like as Mr. Divan told, like when he actually counseled the patient in the midnight many years back for a patient dying of a possible disease for a liver transplant, it actually a very, very crucial decision because the patient's family has lost a life, and during that crucial phase, you are going to intervene their psychology. So, you have to be tremendously intelligent and professionally experienced to crack those kind of situations where eventually the patient's attendant can probably come forward and agree for this kind of donation program, because that is important. So, as I told you, it is not the most seriously patient they are the right candidate, but you have to count for many other factors which eventually will make that heart transplant outcome better. So, that is more important. So, for that the most of the heart transplant programs they have categorized these patients based on the risk factors or the comorbidities or the kind of clinical status of the patient, whether the patient is on some kind of total artificial heart, or the patient is on intra-aortic balloon pump, patient is in cardiogenic shock, patient requiring many kind of inotropic support, patient age is young, no too much of comorbidities, and the long term survival is probably better if we do the corrective therapy. Accordingly, they categorize this patient so that based on this category or the criteria, we select these patients so far as the appropriateness of heart transplant is concerned. This kind of criteria, they slightly different from geographical location to geographical location, but they eventually mean the same, that if the longevity of this patient is better with a potential heart transplant, then we must try to put the patient on a first category. So these are the various kind of criteria that many of the organizations have formulated so that they make the things better so far as the category of the heart transplant need is concerned. So this is a flow chart of patient, how we evaluate so that we can potentially prescribe the heart transplant and try to aggressively pursue it. So when we talk about the assessment of the patient or the recipient for a heart transplant, we don't only see for the clinical status of the patient, but we have a holistic way of analyzing what is the outcome of the patient based on the cardiopulmonary exercise testing and various other assessment, so that we can make a meaningful impact of the heart transplant. There are few contraindications for heart transplant that we all know about. If the patient's overall life expectancy is not too great, then probably we should avoid getting a heart transplant. Or if the patient has got certain kind of comorbidities like cancer and untreatable diseases, then probably we should avoid. If the patient's economic conditions is not great, probably we should avoid listing this patient for a heart transplant. So as I told you, this donation again is a hostile kind of environment where there is a huge amount of emotional setbacks from the donor's perspective, and we have to counsel this patient for a possible donation. So we should be very, very sensitive enough to put our right foot forward so that we can eventually crack this kind of bad situation and we can help a needy patient. So this comes with experience, expertise and time. So initially, from the donor perspective also, there has been a very, very strict criteria that the donor should not be very, very aged and donor should be free of any kind of diseases and so on. But with the eventual experience of the heart transplant program globally, we have seen that if we are very strict so far as the heart transplant program is donation is concerned, then it is probably not going to be very, very helpful. So they have slightly softened those kind of criteria for donation, and eventually the bottom line is the patient should not have some kind of intractable disease which can have an impact on the long term outcome of the heart transplant. So in that context, we evaluate the patient medically, we do little kind of assessment pre-mortally, and then we put the patients on a circulatory support so that the damage to the heart is the minimum. Because when you are retrieving the organ and you are transporting to a far place, there is an ischemic burden and there are other kind of things that can actually have an eventual impact so far as the long term heart transplant program is concerned. So we must try to reduce the damage post death. So there are many challenges so far as the heart transplant is concerned in this current world, despite having all the modern facilities. That will eventually be there, but we can certainly reduce it by our own intelligence, experience and interventions. So as I told you that we assess the patients who is a potential donor based on various clinical characteristics, evaluation and removing all the potential hazardous conditions that might impact the long-term outcome of the heart failure patients. So when we talk about the which patient should get the which heart, so that is an extremely crucial kind of decision, but for a seasoned program of heart transplant, that is not a very big deal, because most of the time situations the recipient and the donor heart usually matches. Like we have a patient who was from the RBI in Chandigarh. He was having a ARVC for quite some time, like from 2014 when I came in until 2019 I saw him. He was doing very well, and he was about to retire in 2 years. But in the later half of his life, he started having pericardial effusion, the RARV was grossly dilated, yet he was symptomatically not too bad. Now, if you look at the strict guideline of the heart transplant program, that patient will be category in 2A or 2B. But because of the other futuristic thing, that we decided that you must go for a transplant because your chances of survival is great. The patient stayed for 3 months in a remote location in Tamil Nadu. He got a heart on the day 50 or 52 second day. He was getting a heart from Vadodara, who is a patient dying of a cancer prostate, 70 years of age. So because of this patient's refusal, they refused the 70 years heart, and eventually the next day he got a heart of a 17 years old boy from Coimbatore. He got the 17 years heart at the age of 57, 56. He stayed for 7 days there. He came out of the hospital. Then eventually, during his transport to Chandigarh back, he contracted some kind of bad infection and died within 24 hours. So this heart transplant program doesn't necessarily mean the indications should be the correct, the donor should be the most perfect, but it is eventually the whole lot of the post-transplant therapy that also is very, very important. So when we are talking about a pediatric versus an adult, so our body surface area, BMI should match around 75% to 125%, so that we do not have a significant mismatch of the transplant in the donor heart, so that the long-term or the immediate post-transplant outcome should be better. Because when we have a mismatch, there are certain kind of problems that can happen, and when we are talking about the post-transplant patients, so we have to plan it before, so that the immediate requirement for the desensitization following a heart transplant should be the most appropriate. For that, we run certain kind of biomarker and other immunological tests, so that we are fully prepared to chalk out our post-transplant desensitization program, so that the acute graft rejections are minimum. So for that, we have various kind of strategy that we do, like the elevated PRA titers and so many other kind of tests that we do. So after the transplant, the most important strategy is the desensitization, where we have a different protocol, which is a very, very robust protocol, which we adapt to most of the patients, and that actually reduces the acute graft related problem to a significant proportion. So they are not very, very out of the world kind of therapy, like the uses of intravascular immunoglobulins, plasmapheresis and so on, and certain kind of immunomodulation that we give for the long-term survival of this patient post-transplant. This we have already discussed. Now coming to the surgical part of the heart transplants, as we talked about, we have the orthotropic and the heterotropic. They do not make too much of difference, but the easy doability of the orthotropic transplant probably has made that most of the transplants today are orthotropic. However, it carries its own demerits sometimes. And when we talk about the transplant, we should try to minimize the injury to the donor heart to the minimum so that we do not have significant kind of ischemic damage to the heart or some kind of other kind of problems, so that after the implantation that patient can have a better survival. We have different techniques of the orthotropic transplants, and both the techniques do not have any kind of superiority over each other. However, so far the arrhythmic outcomes and so many other things, they are slightly better. So far as the need for any kind of arrhythmia management like the conduction blocks or the pacemaker requirement are slightly lesser in a bicaval kind of orthotropic transplants. Heterotropic, as we discussed, it has got its own advantages, like in patients with significant irreversible pulmonary arterial hypertension, probably we can still go ahead with an heterotropic transplants. And we also should be aware about after the transplant the physiology of the heart changes, and because of the nature of the heart transplant, whether it is orthotropic or the heterotropic, and accordingly we should be prepared to manage this altered physiology post transplant. There can be hemodynamic problems, there can be arrhythmic problems, and so on. So we should realize the eventual outcome of this particular surgery, and we should be prepared for that. Like suppose we have an orthotropic transplant and we have an ECG which will show some kind of conduction block, because there is a conduction block of the recipient and the donor heart, that we need not discuss about in detail about the ECG changes, but there are certain kind of arrhythmia which can happen. Post transplant, there is some kind of physiological changes that also happens. They may not be very life threatening, but they can be troublesome if we don't understand and manage those altered physiology post transplant. So there will be abnormality in the heart rate variations, there will be changes in the Frank Stankling mechanism, and the denervated heart also will behave in a different manner to the physiological requirement. That also needs to be understood and managed appropriately. The most important factor that actually decides the outcome of the heart transplant patients are the managing the acute complications post heart transplants. Fortunately, with the set up guideline of the acute desensitization protocol and the immunosuppression, the acute problem post transplant has been reduced to minimum and quite manageable. That probably has helped to improve the outcome of the patients, and we have different strategy like arrhythmia monitoring, the hemodynamic monitoring post transplant for a week or two, that actually eventually helps us to manage those hemodynamic challenges. These hemodynamic changes are usually short term or temporary, so that doesn't give rise to any kind of acute long term problem. But there are certain kind of problem that can be really challenging, like the acute right heart failure in certain cases. And if you look at the right heart failure, they are extremely challenging to treat, but because of the new vasodilators, probably they can be conquered and we can manage this acute RV dilatations or RV failure in such kind of populations. There is a propensity for an elevated pulmonary arterial pressure, so that has been adequately managed by various kind of innovative vasodilators with good success, and the overall outcome can be very good. So far as the graft failure, we have discussed in the previous slides that we have many kind of innovative immunosuppressive therapy or strategies which can probably manage this kind of situations quite aggressively, and the outcomes can be better. And we have various kind of pharmacological intervention depending on the kind of problem that patient may be having, and we manage those patients appropriately. Time and again we do the echocardiographic survey of these patients. If it is required to have an endomyocardial biopsy to find out the graft status of the recipient heart, the donor heart, then we do from time to time to understand the graft reactions and manage those patients appropriately. And as we all know that many other kind of pharmacotherapy is available to decrease this kind of situations. And so far as the long-term maintenance of immunosuppression, they are not very, very crucial or very, very intricate. We have various kind of medications are available, which can probably be given like any other transplant, post-transplant immunosuppressions like kidney and the liver. And beyond that, plasmapheresis and so many other things that also can be done. So, beyond this heart transplant, the maintenance for a long-term surveillance of the heart transplant is equally important. However, I am not discussing those topics of a long-term rejection and its management, and what are the other complications related to this immunosuppressive therapy, whether there is an increased risk of any kind of cancer and all. Those things probably we can discuss sometime later. And if we adapt to this kind of program, probably we can have a meaningful survival of these patients following a heart transplant. Thank you. I try to make this talk not too scientifically burdened, so that we remember each and every data of or the parameters for identifying the problems, but just for a basic perspective that what are the challenges and what are the way forward to have a decent heart transplant program, indications, so that we can restart a heart transplant program in this particular part of the world.
Thank you so much, sir. Thank you so much for that wonderful insight into the intricacies of cardiac transplant. On the first day of inauguration, when Dr. Mahant sir was here, he told us heart transplant is the simplest transplant.
Yeah.
But after listening to your lecture, I think it is the most difficult transplant.
No, the transplant surgery is not probably the most difficult one, because it is very, very simple if you are adapting to a orthotropic transplant surgery. But before the transplant, it is intricate, because as Mr. Diwan also will agree, for any transplant program, because the kidney transplant program has been actually a matured program all over the world, the difficulties of getting a donor is not so intricate. But in a heart transplant program, because of the various kind of immediate post retrievable injuries and other things, and getting the right kind of donor is very, very crucial. Similarly, after the transplant, which may seemingly very, very easy, takes around 6-7 hours time, but then also it is an acutely challenging because of the acute hemodynamic changes that may be troublesome sometimes. Various kind of arrhythmias, they can actually trouble you. Various kind of individual heart failure, like particularly the right heart dilatation and the right heart failure, and persistence of the pulmonary arterial pressure, they can be challenging. So those are the kind of thing that you can see, probably that is applicable for all the transplant programs, but they will be different.
So if we can take one question, if anybody is inquisitive. Yes, go ahead. No, only one. So whichever is the most important question, you just put it first.
So, good morning, sir. Thank you so much, sir, for providing providing us a lot of information regarding heart transplant. So I have a lot of questions, but I ask only one. That in after heart transplant, when we get ECG of patient, so normal ECG होती है, there is some clue होता है कि ये heart transplant की ECG है या something like that.
Yeah. So the person is actually excited by my brag probably. That is the reason he is asking me. So it is a wonderful thing. Yes. इसको दिखाओगे? You are right. So when we do an ECG of a patient post-transplant, depending on what kind of surgery you have done, let me come here. If we look at this ECG, for a blind person it might look normal, because the QRS is looking nice, narrow, there is a small hump before all the QRS like there will be two P waves. One coming from the recipient SA node, and that will be blocked. That cannot be conducted down to the donor heart. So you will have one P wave, then there will be a block, then there will be the donor's P wave. And these two P wave, the recipient and the donor P wave, will be not associated. And beyond that, everything will look normal. The other point is, because this is a denervated heart, there is no sympathetic innervation to the heart. So the heart rate variability that we commonly see in a normal physiological heart, that will not be there. If you give some kind of sympathomimetic amines, doesn't necessarily the heartbeat will go up or down because they are denervated. So these are the certain kind of things that we commonly see, and many a times because of the diseased left atrium, you can still see the remnants of the atrial arrhythmias in such kind of populations like atrial fibrillation, flutter, and so on. But stunningly, it will not look something different, but academically, if you want to impress people, then you can actually show this kind of ECGs to know other person's intelligence, but visibly you can't really make out until unless you really see very, very intricately the depolarization waves like the A waves and the QRS complex.
Thank you, sir. Thank you. We'll have a short deep break in some time. You can catch hold of Dr. Rajat there. In the meantime, I would request Divan sir to please felicitate Dr. Rajat. Thank you, sir. Thank you so much. And with that, we straight away go on to the next session. And I would request Pallavi from Mohan Foundation to take over the dais. And she would be telling you about the initiation of a deceased donor program at your center. So many a times, many of you would be going to join new transplant institute, new hospitals where transplant program is upcoming. Including the deceased donation program, because that is one of the most difficult and challenging programs to start off. Okay, so over to you, Pallavi.
Hi, good morning, everybody. Fourth day of training. How has it been? Good. So raise your hands if this has been the longest training that you've been a part of in all your life. Been part of longer training? Okay, good. All right, so you're going to be seeing a lot of me today. I don't think you can hear me till the end. You're going to be seeing a lot of me today, so you better like me because throughout the day you have some sessions with me. I'm going to be changing around the. I'm going to be doing something that I was planned to do. They can hear me. Live के लिए अच्छा ठीक है. All right. So I'm going to start with a session that was planned towards the end of the day on role of a transplant coordinator in deceased donation and how they handle grief of families, how they approach families, and how do you try and get a consent from families. Before I start, I would like you to let me know how many of you are already working as transplant coordinators in your hospitals. Just raise your hands. Not too many. How many of you are nurses? Quite a few. How many of you are inspired to take on transplant coordination now that you've been how many? Quite a few. Good. I hope this session will perhaps inspire you a little bit more. Do you have this thing? Role of TC का जो है मेरा ये वाला चंडीगढ़ वाला खोला चंडीगढ़ वाला फोल्डर खोला role of TC कौन सा ये
Videos?
हाँ videos नहीं हैं All right. Do you know that it's mandatory for a hospital to have a transplant coordinator on their roll if they have to apply for a license for a transplant? How many of you knew that? Okay. So for the rest of you, the Government of India in the Transplantation of Human Organs Act has made it mandatory for a hospital to have a transplant coordinator on their roll if they have to even apply for a transplant license. So that's how important this person is. Yeah? So don't let anybody else make you believe otherwise. The hospital cannot start its program without a transplant coordinator. So it's a fairly important person. Now, how does the Act define the transplant coordinator? So the Act says that transplant coordination is a person that is appointed by the hospital for coordinating all matters relating to removal or transplantation of human organs or tissues, or both, and for assisting the authority for removal of human organs in accordance with whatever that provision is. That is the official definition of a transplant coordinator. So you could be in a hospital and both retrieving and transplanting organs, or you could be part of a hospital that is not doing transplants but is retrieving organs and giving it to other hospitals. So it could be a person who's involved in both of that. What does the Act say should be the qualification of a TC? It is a registered hospital employee who is a graduate of any recognized system of medicine or nurse, like many of you are, has a bachelor's degree in any subject, preferably with a master's degree in social work, psychiatry, sociology, social sciences, and public health. That is what the legal qualification of a transplant coordinator in India is. What do we think should be the qualification? A person who's passionate about this job. Yeah? A person who believes in this process, who believes that every family should be given the opportunity to decide whether they want to donate their loved ones' organs or not, and a person who believes that there are many people on the other side who will benefit with this decision, and that you think you could be that person who can make this marriage happen. That you think you could be someone who can inspire families to say yes, so that many people who are dying for want of an organs will help with that whole activity. So that is very important. If you decide to take on this as a career option, please believe it is not an easy job. It is a very difficult job. There are multiple challenges. Your work begins with somebody's grief. किसी की लाइफ में कोई मरा है, कहीं दुख शुरू हुआ है तो आपका काम शुरू हो रहा है. How can that be a pleasant job? How can that be a easy job? Yeah? So don't take it if you're a weak-hearted person. Don't take it if you have your own religious beliefs against this whole process, or if you think it should not happen. Take it up if you truly believe in this process, if you're passionate about this process, because मुश्किलें बहुत आएंगी, challenges बहुत आएंगी, दिक्कतें बहुत आएंगी. ठीक है? So you have to believe, because then you won't see the obstacles. So if you look at deceased organ donation, अब हम living की बिल्कुल बात नहीं कर रहे हैं इस session में, we are only talking about deceased organ donation. It can very broadly be divided into these 7 steps. आपको donor identify करना है, potential आपका donor कौन है, obviously फिर brain death declare होएगी, आपको फिर family को approach करना है with the objective of obtaining consent, donor manage होएगा because obviously उसके organs आप दूसरे लोगों के लिए use कर रहे हैं, and organs have to be retrieved, and there is work with the family. Now let's see कि transplant coordinator इस पूरे process में कहाँ आता है. हर जगह. You are there from the start till the end. The amount of work that a transplant coordinator does sometimes just goes completely unnoticed. सारा focus चला जाता है किसने brain death identify किया, किसने transplant किया, उन सबका अपना job है. But transplant coordinator को एक शायद moment का भी rest नहीं मिलता है. And we did a little bit of a survey. On an average, for one donation, the transplant coordinator has to make around 250 calls between various people. So it is a lot of hard work, and let's see where we do what. So you had sessions on brain death. So donor identification is the role of the ICU team, critical care people. But please remember, as a transplant coordinator for deceased organ donation in a hospital, तुम्हारा वही काम है, उनके हजारों दूसरे काम हैं, ठीक है? Your main focus is to know that if there's a brain death, it should not go unidentified. The family should not go unspoken to. So while the actual process of donor identification is the critical care team, you have to, as a transplant coordinator, develop skills to be alert to who can be a potential donor. And as nurses, you are greatly qualified to do that job. GCS कहाँ पहुँचा है? Can this person probably move towards brain death? Is enough focus in the ICU being given to this person? कहीं ये तो नहीं है कि बिल्कुल ही वो undetected जा रहा है? So you play that role. Then of course, you identify a donor, you have to declare the donor brain death. Again, who does the declaration of brain death? Who does it? The brain death committee consisting of 4 doctors, yes. But assisting in that process is again the transplant coordinator's job. Making sure your documentation is complete is your job. ढूंढने कोई कौन करेगा साइन, ये नहीं कि कोई डोनेशन हो रहा है तो चारों आके खड़े हो जाते हैं. You have to find your brain death committee members. Sometimes nobody is available. Sometimes you have to go to the house and get the person back or get signatures done. So making sure your brain death certification, all the signatures are there, everything is documented, all of that. Ultimately, the responsibility is the transplant coordinators. Okay, that's your brain death certification form, Form 10. It will be in your manual. Make sure ये सारे 4 लोगों के signs हैं. I think by now you know who does the signing. All of this, all the information of the family, all the medical information has to be filled by the treating physician. Please make sure that each column is filled. पता नहीं लॉ ने यहाँ पे 2 कॉलम्स क्यों नहीं बनाए. कल नवदीप दिखा रहा था फॉर्म. So normally we just draw a line here, physically draw कर लेते हैं, or you can even just create a form with law. And first set of tests, second test of test, each of those aspects have to be documented. The brain death team will document it, but if they've missed out, say, sir, this particular section is missing, please fill it up. And then you complete the form with the second set of signatures. What is the time of death in case of, when is a person declared dead in brain death? After the second set of tests. Very important. Sometimes you will have doctors arguing with you in the hospital. Please remember, how can you answer back logically? You cannot finish this form after the second. You cannot sign this statement. This certifies that the patient has been carefully examined twice after an interval of about 6 hours, and based on these findings, so and so is declared brain death. So a person can be declared brain death only and only after the second set of tests. Please be very clear of that. सबसे important step अब आपका, बाकी में तो आप assist कर रहे हो. This is your baby. You are approaching the family. कब करोगे? While the person is officially declared dead after the second test of tests, but for all practical purposes हमें time की बहुत ज़रूरत होती है. तो हम family से conversation after the first set of tests शुरू कर देते हैं कि test कर रहे हैं उन्हें डॉक्टर लोगों ने. Doctors already informed the family about the fact that there are no reflexes and all. So you start the conversation about organ donation or generally to establish your relationship with the family after the first set of brain death tests. I've used the word decoupling there. Does anybody know what that means? Decouple. Decouple is that the conversation of declaration of death and the conversation of organ donation, ये 2 अलग मुद्दे हैं. इनको अलग अलग ट्रीट करना है. ये नहीं जी आपके मर गए अब आप ऑर्गन्स देना चाहेंगे, आपको मिलेगा कभी हाँ उसके लिए? Never. You have to, the doctor and the treating team talks about death, lets the family accept death, internalize that information. They may have doubts, they may want to come back to the treating team. That is one separate set of conversation. And at a certain later point in time, you will bring up the conversation of organ donation, because these are 2 very, very distinctly different sets of conversations. कहाँ बात करोगे आप फैमिली से? कॉरिडोर में खड़े होके? कहाँ करोगे? Ideally, if the hospital is serious about this program, there should be a room for such kind of conversations, a counseling room. अगर hospital के पास इस तरह का counseling room नहीं है, तो एज अ काउंसलर, एज अ ट्रांसप्लांट कोऑर्डिनेटर शुड बी वेरी क्लियर कि मैं इस फैमिली को कहाँ ले जाऊँगा अगले आधे पौन घंटे तक, 1 घंटे तक. सो देयर कुड बी कॉमन रूम्स. यू विल रिक्वेस्ट परमिशन दैट आई एम गोइंग टू बी स्पीकिंग टू अ फैमिली. I will not want to be disturbed. People should not be coming up to pick up their backpacks and tiffin boxes and all. So that planning you have to do because it disrupts the flow of your conversation with the family. It's a serious conversation you're having. और कौन करेगा ये conversation? Ideally हम लोग advocate करते हैं एक approach where the treating team, treating physician along with the transplant coordinator does this conversation. Ideally, because so far the family is used to being with the treating team. They are familiar with the treating team. अगर तो तुम शुरू से इस टीम का पार्ट थे in all your conversations with the family, great. But if you're suddenly coming in at the last minute, request your treating physician कि सर आप थोड़ी देर के लिए आके मेरे साथ बैठिए, फिर I'll take it up from there. But you definitely have to be part of this conversation, all right? In all your conversations with your families, please remember and please remind yourself, it is the family's prerogative. आपको लगता होगा बहुत अच्छा काम है, बहुत नोबल काम है, लोगों की ज़िंदगियाँ बचेंगी. It's not about you. It's about this family. ये यूनिक फैमिली है, इनका ग्रीफ यूनिक है, इनका एक्सपीरियंस विद दिस हॉस्पिटल यूनिक है, इनकी नॉलेज ऑफ ऑर्गन डोनेशन यूनिक है. Let this fact that you believe that it is his family's decision be reflected in what you say and in your body language. Please, don't come on too strongly on families. You are there only to provide support, to provide information, so the family can take an informed decision. ठीक है? अब आप क्या ज़रूरी होता है? ये सब end of life care के मुद्दे हैं because obviously the person has died. तो बहुत ज़रूरी होता है that this family has trust and confidence in the treating team. Actually, a lot of time, a lot of focus is given on the counselor's final discussion. उसने जब बात करी फैमिली से उन्होंने हाँ बोला या नहीं बोला. But a lot of good or a lot of damage has already been done with this family from the time they entered into your emergency till the time death is declared in this conversation. तो does this family believe कि इस hospital ने मेरे लिए सब कुछ किया? मुझे वो सही टाइम पे आके मुझे अपडेट्स देते रहे. They kept me informed. They kept the communication open. That the family feels trust and confident in this system. अगर वो होता है, then they also feel very involved in this end of life review कि अब क्या करें? अब death हो गई तो अब क्या करें? You know, and being able to take more decisions. So it's important that if a hospital is looking at this program, this approach is followed from the moment the family is entered into the emergency area till the time death is declared and conversation of organ donations are picked up. Okay? क्या करना चाह रहे हैं आप इस conversation से? सबसे पहले you want this family to understand and accept death. ठीक है? उनको समझ में आ जाना कि मेरे loved one की death हो गई है. कितनी बारी होता है, you know, there was this Nepali lady, उसके husband की death हुई थी और मैंने उनसे जाके पूछा, अच्छा आपको डॉक्टर साहब ने कुछ बताया होगा, आप क्या समझे हैं? किसी उन्होंने बोला है सर मैं चोट लगी है बहुत और दिमाग मर गया है और रिफ्लेक्सेस नहीं है. एंड देन शी ब्रोक डाउन एंड शी थिंक मुझे लगता नहीं है मेरे हस्बैंड अब बचेंगे. व्हाट डज इट मीन? दैट शी हैज़ नॉट अंडरस्टूड डेथ. मुझे नहीं लगता मेरे हस्बैंड अब बचेंगे. सो there has to be a clarity that this family has understood and accepted death. Not lack of reflexes, not legal death, not brain death, whatever, death. ठीक है? वो establish करना, while that is the duty of the treating team, to establish कि उस family ने समझा है कि नहीं is your responsibility. Then you have to help families cope with grief because obviously they have lost somebody, they are grieving. Now grief is not an overnight process. Perhaps this family will grieve till the end of their life or whatever for years altogether. But you as counselors have to work with families that they are able to deal with the grief to an extent that they can at least understand what you are saying. You know, अगर वो जोर की रोए ही चले जा रहे हैं और अपनी बात आप पेश कर रहे हो सुनेंगे नहीं. I will come to the stages of grief, but that is your second objective, and of course your main objective is to motivate them and help them to give consent to organ donation. यही तो हमारा ultimate objective है, but there is no shortcut to this objective. You have to go through a lot before you reach there. क्या ज़रूरी होता है कि आप इस फैमिली को समझते हो. कौन है ये लोग, क्या फैमिली डायनेमिक्स क्या है. अच्छा है तो उसका हस्बैंड, बट डिसीजन तो चाचा लेता है. यू नो, all of these things over the past 3-4 days और जब से फैमिली आई है, you have to start understanding, you have to start observing, you have to pick up these little unsaid things. कौन डिसीजन मेकर्स हैं, क्या इनकी इंटरपर्सनल रिलेशनशिप्स हैं, डू द मेन इन द फैमिली मेक ऑल द डिसीजन, तो फ़ायदा क्या है औरत से जाके बात करने का, इनका सोशो इकोनॉमिक स्टेटस क्या है, विल दे पिक अप इशूज़ अराउंड बिलिंग, मुझसे पूछेंगे कि हमारा बिल माफ़ कर दो, आर यू अलाउड टू डू दैट, व्हाट इज़ योर हॉस्पिटल्स पॉलिसी, ऑल ऑफ दैट. इनका रिलीजियस ओरिएंटेशन क्या है, कल नवदीप वाज टॉकिंग अबाउट समबडी फ्रॉम अ पर्टिकुलर रिलीजियस ओरिएंटेशन. इफ़ यू नो अबाउट दिस फैमिली, you know, you can get yourself a little aware कि maybe I'll have to call up somebody else to speak to this family. General readiness has to be there, and obviously you get a feeler about what is the family's understanding of the patient's condition. उनको समझ में भी आ रहा है कि डेथ हुई है कि नहीं हुई है. ये सब चीज़ें आपको better prepare करेंगी to have that conversation with the family. Then you're not bungling in like a blind person. You are going prepared. You're going more alert to the signals. So you're basically trying to build a partnership with this family. टाइमिंग, बहुत जल्दी पूछोगे बहुत जल्दी ना मिलेगा. मोर क्विकली यू आस्क द मोर क्विकली यू गेट अ नो. बट एट द सेम टाइम वी अंडरस्टैंड कि ऑर्गन डोनेशन में हमारे पास शायद वी डू नॉट हैव द लग्जरी ऑफ टाइम. वी कांट से अच्छा अगले हफ्ते बात करेंगे. कैन वी डू दैट? वी कैन नॉट. सो you have to create this balance. It comes with experience, it comes with your perception of the family, it comes with your understanding of this process, but you have to create a balance. Not too soon, not too late, so that you don't lose your family. Okay. Now I very quickly want to take you through stages of grief. Grief typically passes through these stages, but ज़रूरी नहीं है कि हर फैमिली में आपको ये stages बड़े distinctly दिखाई पड़े, और ज़रूरी नहीं है कि सारे इसी ऑर्डर में आए. ठीक है. बट फॉर यू एज अ काउंसलर, एज अ ट्रांसप्लांट कोऑर्डिनेटर, यू हैव टू बी वेरी वेरी अलर्ट टू दीज स्टेजेस एंड देयर मैनिफेस्टेशंस. डिनायल. डिनायल का मतलब मान ही नहीं रहे हैं कि कुछ हुआ है मेरे पेशेंट को. एंड हाउ विल डिनायल शो? क्या बोल रहे हैं डॉक्टर साहब, उनके तो हार्ट अभी भी बीट कर रहा है, यू नो, कैसे मान लूँ, अभी तो उसके रिफ्लेक्सेस हैं, नहीं हो ही नहीं सकता, कल ही तो लाए थे उसको, इतनी जल्दी. ऑल ऑफ दीज sentences and statements show that the family does not want to accept death. It is a very typical form of denial, of grief, very typical stage of grief. When a family is in denial, can you be talking to them about organ donation? उन्होंने तो भी डेथ ही नहीं एक्सेप्ट करी, तो आप ऑर्गन डोनेशन की बात कैसे कर रहे हो? और करोगे, दे आर लाइकली टू बी एंग्री कि मतलब क्या आपका, मैं तो हमारा हम बचाने की कोशिश कर रहे हैं वहाँ पे और आप ऑर्गन्स की बात कर रहे हैं. सो डिनाइल इज द फर्स्ट स्टेज. एंगर. नाउ एंगर doesn't always have to be gali galoch and throwing stones and breaking things. Anger can also be a very quiet form of anger. Anger can be at the hospital team. Anger can be at abstract things like God. Anger can be at your own self. This woman I was speaking to, she kept saying, मैं इतनी बड़ी बेवकूफ़ हूँ, मैं पहले उनको छोटे हॉस्पिटल ले गई अपने हस्बैंड को, वहीं मामला ख़राब हो गया. इतनी बारी उसने वो वाली बात रिपीट करी. And that's a form of anger. She was angry with herself for not having been smart enough to bring her to a bigger hospital, and that she wasted time by taking the husband to a smaller hospital near the. So again, when a person is preoccupied with anger issues, can you talk to them about organ donation? No. Because अभी इसको उन issues से वो इंसान डील कर रहा है. ट्रीटिंग टीम ने तो कुछ किया ही नहीं, जब लेके आए 3-4 घंटे तक किसी ने देखा ही नहीं, इन्होंने कुछ किया ही नहीं. अगेन एंगर. भगवान तो मेरा कभी साथ ही नहीं देता. ऑल ऑफ दोज आर एंगर इश्यूज एंड यू कैन नॉट बी पिकिंग अप ऑर्गन डोनेशन. बार्गेनिंग. बार्गेनिंग का मतलब आप कुछ करो मैं कुछ करूँगा टाइप, यू नो, कि कुछ डॉक्टर साहब मैं और भी पैसे देने को तैयार हूँ, आप कुछ भी करिए, आप ऑपरेशन करिए, आप कुछ भी करके मेरे लव्ड वन को बचाइए. ऑल that means the person still has hope. They still think something can be done. Can we get some Baba, you know, हमारे हैं जान पहचान के, वो आके यहाँ पे कुछ कर देंगे, या can you give me the papers, I would want to take a second opinion. All of these things again show that the family is hoping against hope that some miracle will happen, that their loved one will be. So all of that is bargaining, and again you cannot be bringing up organ donation issue. Depression. इस स्टेज में आप देखेंगे कि families quieter हो रही हैं. They are withdrawing. They are not trying to argue with you. No, they're not trying to bargain with you. They are not screaming, shouting, or crying. They are quietening down. And quietening down means that there is some degree of acceptance of the finality of the situation. उनको समझ में आ रहा है कि शायद अब कुछ हो नहीं सकता. And the final stage is when the family has accepted death. इस stage पे वो लोग दूसरे family members को बुलाना शुरू कर देंगे. They are talking about end rites, क्या करेंगे, कब करेंगे, उनका cremation कब होगा, चौथा कब, इस तरह की बातें discuss होने लग जाती हैं, which means the family has accepted death. Very often families at this stage will ask, अब क्या करें डॉक्टर साहब? And that is the stage where we really have to bring our families to, because अब क्या करें में you will say कि आपके पास ये 2-3 choices हैं, you know, या तो आप wait करें, you know, heart will stop beating in a day or two while the person has died, it's being artificially maintained, we will stop any active intervention, heart will stop beating on an average in 2-3 days, or you can do LAMA, you can advise LAMA, but इस situation में आपके पास एक और choice है, and that's where you bring in organ donation. And I always tell my families, there are so many deaths happening in an ICU, but I'm not having this conversation with everybody. You know, I'm having this conversation with you because you as a family have this extra special choice in your hands, you know, and I would like to talk about it. And that's how you bring in, everybody has their own style of how they want to start the conversation, but that's when you bring in organ donation as a conversation. हमेशा establish करो कि वो किस stage. Don't leave it to doctors कि उन्होंने death की news दे दी है. Every time when a coordinator is called, we are told that the death has been conveyed. Now you start with your conversation on organ donation. But please start with establishing कि उनको समझ में आ गया. Like I told you about that Nepali wife. So start open-ended questions like कि आपको बहुत कुछ information मिली होगी ICU से, आप क्या समझें अब तक? You know, so when you give open-ended questions, you have an opportunity to get back where the family is. So do not start your organ donation conversations till the such time you've established कि family को death समझ में आ गई है, उनके कोई doubts नहीं है, उनके कोई worries नहीं है. And these are called open-ended questions. I would like to start by asking if you have any questions. Would you want me to call the doctors again? Is there anything else that you want to clarify? So this helps you establish where your family is. Please avoid things like, मुझे पता है आपके साथ क्या हो रहा है, मैं सब समझ रही हूँ, मुझे समझ में आ रहा है, नहीं आ रहा है आपको, आपके family member की death नहीं हुई है. Is that family member's grief? Don't belittle it by saying random statements like this. It's all right. Don't say anything if you don't know what else to say. क्योंकि आपको नहीं पता है. Please avoid false promises like, कल 6 बजे आपको body मिल जाएगी. After you've spoken to the family, your role is very minimal. It's the OT, it's all the tests that are being done, दूसरे teams, आपकी state authority, इन सब की responsibility आप अकेले कैसे ले सकते हो? नहीं ले सकते. So what we call a huddle. Everybody has to get together, all the teams, and they have to collectively arrive at a time. और अगर वो आपको 8 बजे बोलते हैं, आप family को बोलो 10 बजे. Because family is going to ask you, कि आपने तो कहा था 6 बजे. You know, so you tell them and prepare them that there are always delays. I'll do everything in my capacity to hurry up things. A lot of things are not in my control. Things take time. Sometimes the patient itself gets destabilized. You have to maintain. दूसरे लोगों को देना पड़ता है. So please do not make false promises just to get a yes out of the family. Waiving of hospital bills. What is the law on hospital bill waiving in deceased donation? Does anybody know? What does the law say? Yeah. So according to the Transplantation of Human Organs Act, billing stops the moment the family says yes. अगर आज 12 बजे family ने हाँ बोला है, तो officially billing according to the law legally वहाँ stop हो जाएगी. उसके पहले वाली hospital has every right to take. उसके बाद बहुत खर्चे होते हैं, and the patient continues to be on the ventilator till the time the person is taken to the OT. A lot of expenses there, but that has to be borne by the hospital or the recipients. डोनर की बिलिंग खत्म हो जाती है उस टाइम पे. However, some families as a mark of respect, पिछली रात कोई आया और डोनर hardly कुछ बिल है, as a mark of respect they will waive off, but that's not your decision. So you cannot have this conversation. In any case, in your conversations about organ donation, do not bring money. These are not transactions. ये बहुत ही noble act है. Let's not take away the flavor of that goodness of this act. से मैं बात कर लूँगी एडमिन के साथ, जो भी मैं आपका रिक्वेस्ट उनको फॉरवर्ड कर दूँगी, बट आपने सोचा है इसके बारे में, आपको क्या लगता है ऑर्गन डोनेशन के बारे में? सो हेल्प देम अंडरस्टैंड द गुडनेस ऑफ देयर एक्ट, बिकॉज यू वांट देम टू फील गुड अबाउट इट फॉर years आफ्टर दैट. इट शुड नॉट बी अबाउट some 80,000 bill that was cleared. Funeral charges, as hospitals we never cover that. Recipient's identity, can you disclose? No? In fact, I was a little upset with this one latest article of PGI, where in the same article they have given the name and age and details of the donor and the name and age of. So normally we don't do that. There's nothing in the law, but ethically we are not allowed to share the recipient's identity with the donor for various reasons. कल को जाके पैसे मांगने लगे, कल को जाके बैठ ही जाए मेरे बेटे का हार्ट आपके आए हैं और रोज़ आके वहीं बैठ जाए. People want to move on with their lives, so we don't. So don't say that, don't promise that, say sorry, I'm not allowed. But there is a system in place as to how organs are allocated. Government is involved. We don't do the allocation. The private hospital doesn't do the allocation. There's a proper system in place, but I cannot share with you who will get the organ. And any compensation to the next of the kin, we do not do. As Indians, we are very uncomfortable with silence. हमें कुछ ना कुछ बीच में बोलना ही रहना है. But please understand, sometimes it's good to be quiet. Family रो रही है, शायद सोच रही है अपने loved one के बारे में. It's all right. 15 मिनट बीत गए बिना कुछ बातें किए. Don't, like I said, bring in irrelevant statements. That doesn't help the matter. All right. So you've got a consent. Where do you get your consent recorded? Form 8. It's called the family consent form. कौन करेगा उसको साइन? कौन करेगा? Next of kin. Now next of kin हर situation में differ करता है. And you have to see according to that family who the next of the kin is. But in a case of a married person, it has to be the spouse. That's why Navdeep brought up that case where they were separated but legally divorced नहीं थे. But law उसको फिर भी उसका spouse मानेगा. अगर spouse नहीं है तो बच्चे, grown up बच्चे. If it's a child, obviously the parents have to be the decision makers. So it differs from. What happens if there is dissent within the family? एक family member हाँ बोल रहा है, बेटा हाँ बोल रहा है और husband ना बोल रहा है, आप क्या करोगे? क्या करोगे? Good. So if there are people who are willing, you become team with them, you partner with them to reach out to those that are not agreeing. You try to change their mindset. If it doesn't happen, you withdraw. You leave the family to decide on their own. Our objective is not to create rift between families organ donation को लेके. हम चाहते हैं families united और खुश हो इस decision में, ठीक है? So you move back. That's your form number 8. Please make sure it's filled. सबका नाम, address, नीचे sign होते हैं. And while the next of kin signs, जितने भी लोग हैं वहाँ पे उनको witness की तरह sign करा लो. कोई चाचा आया है, कोई पंचायत का आया है. It's okay. Get as many signatures as possible. While all this is happening, donor को भूल जाओ वहाँ पे. Manage हो रहा है, नहीं हो रहा है. So it has to be managed because now you're talking about other lives, healthier lives. उनको save करने के लिए. So make sure that in the ICU, the teams are concentrating on the donor, managing it. And then, of course, you begin all of these steps. जो कल बातें हो रही थी, blood samples to be sent to appropriate labs, diagnostic tests शुरू आते हैं, maintenance protocol शुरू आता है, दूसरी teams आने लग जाती हैं to get the organs. You are coordinating with them as a transplant coordinator. Make sure the OT room is available. Fight for it to be available if it's not, or obtain privileges for outside teams. A lot of work is there for the transplant coordinator to do. And then, sixth step is retrieving organs. Again, everything has to be very clearly documented. किसको गया है वो organ, उनका signature. Left kidney went to Max Gurgaon, signed. This one went to Medanta. That one went to Sabdajang. Each organ has to be documented, signed by the retrieval team that has come to this thing. All of that, make travel arrangements for organ teach. You have to help because they are coming from other hospitals. You have to support them in that whole process. But इस पूरे दौरान आपकी family तो है ही, you can't leave them. You cannot leave them for a single minute. You have to keep going back to them, informing them. If the family is from another city, make sure that they have a room in the hospital and they are looked after. Many families want to go back home. That's their prerogative. And ensure that there are no delays. Arrange for an ambulance for the body to leave the hospital. That is a done thing. That is something the hospital does it legally. Respectfully hand over the body, provide follow-up support. We always go back to the family. Cremation के टाइम पे भी जाते हैं हम लोग, एक सर्टिफिकेट देते हैं. It's our way of showing respect. We also go for चौथा और तेरहवीं and then keep a relationship with this family because ये तुम्हारे ambassadors हैं आगे के लिए. So often in our counseling cases we call other families who consented कि ये family को थोड़ी मुश्किल हो रही है decide करने में, आप बात करोगे. So then families realize कि हम ही से नहीं मांग रहे. There are many other people who have taken this difficult decision. And other than that, a lot of work you have to do. Public awareness. कल शायद दिवान जी ने आपको बोला होगा. That is not just the job of NGOs. I'm sorry to say बहुत कम NGOs हैं इस country में और उनके staff बहुत कम है. It is every person's responsibility who's involved in this work. Because आपका कौन आ रहा है अंदर hospital से बाहर के तो लोग आ रहे हैं ना. And if they come more aware, if they come more knowledgeable, your process inside the hospital becomes easy. So take out a couple of days in the month कि every quarter में ये महीना or whatever, at least 2-3 days you keep out for public awareness. Contribute to research. There is such little research coming from transplant coordinators. There are such few transplant contributing papers to journals. अपना experience को document करो ताकि you can present it. Maintaining donor database. Every donation has to be documented. उसके बारे में लिखो कौन सा organ कहाँ गया so that your records are पक्का. And all of this has to be done very, very carefully. Medical legal case पे आपका हो गया होगा शायद session. I just want to introduce these 3 forms. I think they are there in your manual. They are not in the act. But if there is a medical legal case in the family, this is form 1, which is your police intimation form, जो कि hospital के MS से nearest police station पे जाएगा कि so and so case हमारे यहाँ है, brain death है, family is keen to donate organs. आप आके अपनी inquiry करिए. That's the first letter. Family comes. Please, we are not seeking for NOC from families. Do not fall in that trap. Police only has to do their inquiry. They are not giving us permission. Permission कौन देता है? Precisely. Forensic permission देता है. So don't give undue importance to the police. Don't ask for an NOC. They get very scared when you ask for NOC. Just say आप अपना inquiry करिए. And all they have to do is that we have conducted an inquiry and forward the documents to the forensic officer. This is a form that goes out from the critical care team to the forensic expert saying ये organs functional status में हैं और हमें आप इनको retrieve करने की permission दीजिए. And you have to write very clearly, left kidney, right kidney, liver, only the organs that are going to be retrieved. And by this time that has been established. अगर 70 साल का इंसान है आप उसके lungs और heart ले रहे हो? नहीं ले रहे हो. So by this time you know क्या निकाल रहे हो. You have to exactly put that down and send this form to the forensic. And this is what the forensic sends back saying कि ये organs मेरे autopsy में interfere नहीं करते हैं. You may please go ahead and retrieve them. And once you get this, that's when you go ahead with the organ donation. Families नहीं क्यों बोलती हैं? क्या reasons है family का नहीं बोलने का? Awareness ही नहीं है, पता ही नहीं है आप क्या बात कर रहे हो organ donation. Who never heard of it, they've never thought of it. That's perhaps the most common reason for no. What else? What else? Why do families say no? हाँ जी? Hope कि अभी भी कुछ हो जाएगा, कुछ miracle हो जाएगा. So that means they are in one of their grief stages and you perhaps started the conversation too early. Religious sentiments कि हमारा religion allow नहीं करता, which is very stupid because कोई religion कुछ बोलता ही नहीं है organ donation के बारे में. These religion and religious scripts were written bloody 20,000 years ago जब organ donation की बात ही नहीं हो रही थी. So you should encourage people to go back कि बताइए अपने religious कहाँ लिखा है. And let me be very honest, when I started work about 13-14 years ago, मुझे बताया गया था religious beliefs बहुत लोगों के हैं. In all these years and all the families that I've counseled, I've got a lot of no's. Not one of them said no for a religious reason. इतने बेवकूफ़ नहीं होते लोग. You know, we are not doing work in छोटी-छोटी cities. We are doing work in metros. पढ़े लिखे लोग हैं. लोगों के बहुत real concerns होते हैं. किसको जाएगा organ? Misuse तो नहीं होंगे organs? कब मुझे body वापस मिलेगी? When can I plan my end rites? They are concerned about recipient's identity. Is there a fair process? They want to know how their loved one's body will look once the organs have been retrieved. So that's important for you to know. आपको पता है कैसा लगता है body once the organs are retrieved? Huh? So for those of you who don't know, it's a single surgical cut that is made from here to here, like any other surgery. All the organs are retrieved from that one single cut. ये नहीं यहाँ से kidney निकाले, यहाँ से heart, ऐसे नहीं करते हैं. And then once the organs are retrieved, that cut is stitched surgically, covered very respectfully. So you should be able to explain these things to family members. ये जो पहले 3 हैं, इसके साथ आप कुछ नहीं कर सकते क्योंकि they have come with that into the hospital. But जो नीचे के 3 हैं, इसके साथ आप काम कर सकते हो कि आपने उनको हॉस्पिटल में ट्रस्ट दिलवाया कि नहीं दिलवाया. आपने उनको ये फील करवाया कि नहीं, कम्युनिकेशन लेवल वाज ओपन, डिड दे फील गुड अबाउट द इवेंट्स इन द हॉस्पिटल? सो मेनी टाइम्स यू हियर फैमिलीज से कि हमारा वो चला तो गया बट इतने अच्छे से सबने हमारे साथ कोऑर्डिनेट किया, सब डॉक्टर ने इतना किया. दैट इज़ द फीलिंग वी वांट टू गिव आवर पेशेंट्स. दैट्स वेयर यू गेट मोर कंसेंस. सो एज अ फाउंडेशन वी हैव द अपॉर्चुनिटी टू वर्क विद डिफरेंट हॉस्पिटल्स. तो क्यों इस हॉस्पिटल में ज़्यादा डोनेशंस हो रहे हैं, क्यों इस हॉस्पिटल में? बिकॉज वी कैन सी इट्स सो क्लोजली लिंक्ड टू द ट्रीटिंग टीम्स बिहेवियर विद द फैमिलीज. अगर नहीं मिलता है, accept it. It's all right. It's not easy for families to say yes. Believe you me. And after all of these years of talking to families, abhi bhi I get more surprised when a family says yes. No is normal. कितना मुश्किल है. अभी आपका कोई मर गया है, इतना bills भी बन गए हैं, you've lost a person also, you're grieving also, and then suddenly these strange people are coming and asking for organs for some strangers जिनको आप जानते भी नहीं हो. कितना मुश्किल है. So it's all right if you get no. Continue to show the same amount of respect and care that you were showing till 10 minutes ago when you wanted organs. Don't change your body language. Please remind yourself as coordinators, it's okay to get no. It's not always about you. It doesn't make you a bad counselor. There are families with their unique set of background, and I will talk about it later in the day as to how showing unconditional support helps. I will share a case with me. ये मेरा बड़ा फेवरेट स्टाइल है. डॉक्टर रंजन यहाँ पे. सो दैट्स ऑल योर ट्रांसप्लांट टीम्स, दैट्स योर मैनेजमेंट, एंड दैट्स यू. एंड समटाइम्स इट कैन बी वेरी स्कैरी, बट प्लीज़ वॉक टॉल, क्योंकि तुम्हारा बहुत इंपॉर्टेंट रोल है. तुम्हें लॉ ने बोला है तुम्हें वहाँ होना चाहिए. तुम्हारे बिना तो हॉस्पिटल काम ही नहीं शुरू कर सकती. सो प्लीज़ बिलीव इन योर सेल्फ, बिलीव इन द इम्पॉर्टेंस ऑफ योर वर्क, एंड स्टैंड टॉल. थैंक यू सो मच.
Thank you so much, Pallavi. That was really very, very, very real, soulful, heart-touching, and a true reflection of a true transplant coordinator's heart. And that is what the ground reality is. That is what we as clinicians also see. It's a very, very difficult job to initiate those soft skills to be able to communicate with someone who has just died. The family is in the stage of grief, and it is very important, as Pallavi rightly pointed out, to know what stage of grief it is. So there's a lot of psychological elements, and if I see donations in northern part of the country are really very extremely low as compared to southern India. Probably we can attribute it to literacy rates or psychological inputs, whatever you may say. But then all of us should make efforts to reach that deep ground level, talk to families, encourage more and more people to donate organs. If there are any questions to Pallavi, we would be glad to take it. Or she will be here the whole day. What I'll do is I'll request our Director of Liver Transplant and Gastroenterology, Dr. Sahni is here. So we'll straight away move to his talk about indications of liver transplant, liver failure, and then you can have all those questions with Pallavi during the tea session. Okay? Does that make sense? All right. With that, I invite Dr. Arvind Sahni, sir, who is the Director of Gastroenterology, and he has been instrumental in initiation of liver transplant program at our hospital, and is a very well-known gastroenterologist who has been making lot of efforts towards starting of disease donation program in this part of the country. Pointer.
Thank you, Dr. Ranjan, for a very kind invitation. This topic is very, very close to my heart, and if you feel you are not able to understand, please feel free to interrupt, ask. I am willing to engage in a dialogue. I've divided the talk as per Dr. Ranjan into basics of liver failure, types of liver failure, the epidemiology of liver disease, need for liver transplantation in India, indications for liver transplant, contraindications for liver transplant, pre-transplant coordination, post-transplant recipient follow-up, cost, and a brief video. Let us see how much we can cover. This is probably the most important of all slides. Liver is life. Liver is a vital organ, and if your liver is not healthy, there is significant amount of morbidity and mortality due to various reasons which we should be discussing. This is the diagrammatic view of the liver. Sorry. This is showing the anterior aspect. This shows the right lobe and the left lobe, and this is showing the posterior aspect. So when we ask for a live donor, most important question is, Dr. Saab, I have only one liver. How come I can donate this? So for that, I have this diagram, and I explain to them that this has got, basically it is 2 in 1. You have a right lobe, you have a left lobe, and the surgeon is skillfully able to calculate the volume and to dissect the right lobe from the left lobe, and you will be able to donate your right lobe, and the remaining 30% of your left lobe will be sufficient to regenerate. Within 2 to 3 months, the entire liver function will return to normal. They appear to be somewhat convinced with that. Otherwise, they always give me an example that I have 2 kidneys I can donate, but how can you're asking for your organ donation from the liver? So that is your explanation for that. These are the anatomical segments or the coniad segments based on the vascular supply, portal supply, hepatic venous drainage. Very, very important for the surgeon, and they form the basis of liver resection or donor hepatectomy. So they are able to follow these planes very, very carefully. Now, there are various functions of the liver: synthetic function, metabolic function, detoxification function, storage function, immunological function. Once we are able to define what is liver failure, so we say that there is failure of synthetic function of the liver. This is probably one of the very important functions. Liver is able to synthesize various types of protein. Most important is albumin. It synthesizes about 15 grams of albumin per day. Without albumin, there is loss of oncotic pressure, there is pedal edema, anasarca, ascites, and pleural effusion, etc. Liver is also able to synthesize various vitamin K dependent factors like 2, 7, 9 and 10, and in the absence of liver function there is evidence of coagulopathy and bleeding. 3 unique features of the liver: a double blood supply by the portal vein and hepatic artery, one of the largest organs in the body, weighing 1 to 1.5 kgs, and extraordinary capacity for regeneration. This is the concept used for a donor hepatectomy, where about 60% of the liver is taken out and still the patient survives with a 30% liver because of the because of the extraordinary capacity to regenerate. The definition of liver failure is a loss of synthetic properties of the liver. The antecedent cause may be progression of chronic liver disease or hepatocellular necrosis in acute. So there may be acute liver disease, there may be chronic liver disease. A third category I will not be covering is acute on chronic liver disease. Just for purposes of simplicity, I will be covering the 2 main features, which is the chronic liver disease and acute liver disease. Now, what is the concept of chronic liver failure? From hepatic fibrosis to cirrhosis, CLD denotes an ongoing liver injury and inflammation for a period of at least 6 months. Please remember the time of 6 months. This is reported as grade of inflammation, which may be mild or severe, and stage of fibrosis. The findings of discrete fibrous nodules, this amounts to evidence of cirrhosis. This progression of fibrosis to cirrhosis, if unmitigated, leads to end-stage liver disease and chronic liver failure, and this is irrespective of the cause. Whatever the injury, whether it is alcohol, whether it is fat, whether it is copper, any etiology, hepatitis B, C, irrespective of the etiology, the end result, how the liver reacts, is the same. This is the picture showing the external surface of a nodular cirrhotic liver as well as a cut surface. with various distribution, irregular distribution of varying size nodules, multilobular, many of them with thick septa and with broad bands. This is typical of a post-viral cirrhosis. Now, what is the basic process in cirrhosis? You see in the bottom figure, you see evidence of regeneration of the nodules, thick fibrous septa. In the fibrous septa are various shunts between hepatic artery and portal vein and hepatic vein. This leads to an inflow kind of obstruction and a sinusoidal hypertension. These nodules also press on the hepatic veins and cause some degree of portal hypertension. Portal hypertension is the driving force for majority of the complications of liver cirrhosis, such as ascites, such as bacterial translocation, and development of collaterals like esophageal varices, episodes of bleeding, and hepatic encephalopathy. So an advanced patient with cirrhosis invariably has a severe degree of portal hypertension, which is a disaster. The hepatic stellate cells, HSC, is the primary source of extracellular matrix in liver fibrosis. Remember this cell, HSC. What are the key features of cirrhosis? They include diffuse fibrosis, nodule formation, regeneration, altered lobular architecture, establishment of intrahepatic cellular shunts between portal vein and hepatic artery and hepatic vein, as I've just mentioned. The pattern of progression to cirrhosis and decompensation is variable. Most of the times, cirrhosis takes over a decade, maybe 2 decades for this to progress. But there are certain forms of cirrhosis, like in neonates, if you have extrahepatic bile duct atresia, EHBA, the development of hepatic fibrosis and cirrhosis is rapid. It may occur within 6 to 12 weeks of age. Hence, you may need an early liver transplant in such patients. Again, I want to stress, regardless of the underlying etiology, the replacement of the liver tissue by fibrosis, scar tissue, and regenerative nodules associated increase in intrahepatic resistance and portal hypertension leads to a turning point between compensated liver disease and what is known as liver failure or disease decompensation. This marks the loss of synthetic properties of the liver and the development of complications like portal hypertension, variceal bleed, encephalopathy, ascites, coagulopathy, sarcopenia, malnutrition. Remember, onset of decompensation is a turning point in the history of cirrhosis, where survival is decreased from an average of 12 years in compensated cirrhosis to about 2 to 3 years in a decompensated patient in the absence of a liver transplant. What are the 4 common causes of liver cirrhosis in adults? Hepatitis B, hepatitis C, alcohol, and non-alcoholic liver disease. Virus hepatitis C, we are seeing a decrease in the number, obviously because of the government's effort for the very good hepatitis C viral eradication program, which the government is supporting. There is increase in incidence of alcoholic liver disease and NASH, fatty liver disease. Common causes of liver cirrhosis in pediatric age group are extrahepatic biliary atresia, metabolic liver disease, Wilson's disease, and autoimmune liver disease like autoimmune hepatitis. Now we come to the acute liver failure. This was originally defined as fulminant liver failure by Trey and Davidson in 1970. Considering jaundice as the first symptom, hyperacute liver failure describes patients developing hepatic coma within 7 days of noting jaundice. And if the patient develops coma within day 8 to day 28 of developing jaundice, we call it as acute liver failure. And then there is a term of subacute liver failure. This describes hepatic coma occurring within 5 weeks to as late as 24 weeks. The disturbances of coagulation required to define ALF are determined by a prolongation of INR, usually greater than 1.5, in the absence of correction of by giving vitamin K. And important to realize, by definition, ALF should not have any pre-existing liver disease. Otherwise, you will be labeling the patient as an ACLF or acute on chronic liver failure. Another important point is that encephalopathy may be subtle and difficult to detect in very young children. Therefore, in the United Kingdom, encephalopathy is no longer a prerequisite for the diagnosis of ALF. A severe impairment of liver function defined as coagulopathy without encephalopathy if the PT is more than 20 seconds or INR more than 2, that is unresponsive to IV vitamin K correction, or coagulopathy with encephalopathy, PT more than 15 seconds or INR more than 1.5, that is unresponsive to vitamin K correction. Common causes of ALF: viral hepatitis like hepatitis E and A. Hepatitis E happens to be one of the commonest causes of ALF in India, especially in pregnancy. You can have a 50% mortality rate of hepatitis E in pregnancy. Second is what is known as DILI or drug-induced liver injury, particularly due to anti-tubercular therapy. And another common cause, there may be autoimmune liver disease, Budd-Chiari syndrome, and Wilson's disease. Now, coming to the epidemiology, about 50 million people across the world are affected by cirrhosis. Out of 2 million global deaths due to liver cirrhosis, almost 18% occur in India alone, about 1/5 of the total number. Liver cirrhosis accounts for 2.1% of deaths in India. Approximately 10 lakh new cases of CLD are added every year to our country. The prevalence of hepatitis B in India is about 2.4%, hepatitis C is 1%, and non-alcoholic fatty liver is about 8 to 24%. Remember, males are always more frequently affected than females in various causes of liver cirrhosis. Coming to the indication, when do we consider a liver transplant? Now, in putting it very simply, once the limits of medical therapy has been reached, you have tried everything medically, the patient is still in liver failure, yes, you opt for a transplant. This can also be considered in patients of CLD where 1 year survival without transplant, if it is estimated to be less than 90%, if the MELD score is 15 and above, transplant would be indicated. In the absence of certain diseases like HCC and hepatopulmonary syndrome, which are granted MELD exception points. Now, a liver transplant must be technically feasible, medically appropriate, ethically justified, and in the best interest of patient and society. A liver transplant is life-saving and life-prolonging, should be considered in all cases of irreversible liver failure or complications of decompensated cirrhosis, systemic complications of liver disease or liver cancers or liver-based metabolic condition which are causing systemic disease. Now, the patient undergoing a liver transplant should have sufficient reserve to withstand the procedure of liver transplant, which may take up to 10 to 12 hours. The commonest indication for liver transplant is liver cirrhosis and its complications such as refractory ascites, recurrent hepatic encephalopathy, a variceal bleed, spontaneous bacterial peritonitis, a hepatorenal syndrome, or hepatic hydrothorax. Now, hepatocellular dysfunction with a MELD sodium score of 15 or greater is also an indication for transplant, or liver cancer can be an indication for transplant within Milan criteria if the size of one nodule is less than 5 centimeters or less than 3 nodules, each nodule less than 3 centimeters. Liver transplant is done in cholestatic liver disease, and these are various diseases like primary biliary cholangitis, primary sclerosing cholangitis, secondary biliary cirrhosis, biliary atresia, and various other congenital syndromes. In general, liver transplant for cholestatic liver disease can be done at a lower MELD sodium as compared to other indications, and one special indications of doing liver transplant in cholestatic liver disease can be a poor quality of life and severe degree of pruritus or severe itching. Liver transplant is indicated in vascular disease of the liver like Budd-Chiari syndrome or veno-occlusive disease if there is presence of liver failure or liver cirrhosis. Liver transplant, as I mentioned, can be done for various malignancies of the liver, HCC, hilar cholangiocarcinoma, and various other tumors like carcinoid tumor, etc. Liver disease is also, liver transplant is also done for metabolic liver disease like Wilson's disease or various type of hemochromatosis, GSDs, cystic fibrosis, Crigler-Najjar syndrome, and galactosemia. Liver transplant is done also for autoimmune hepatitis. Now, what are the pediatric indications for liver transplant? I mentioned the commonest indication is extrahepatic biliary atresia in the newborn, Ehlers-Danlos syndrome, sclerosing cholangitis, alpha-1 antitrypsin, and hepatoblastoma, which is one of the common liver malignancies in children. These are the this is how you do organ allocation. This is for DDLT. This system is followed in the USA. This is the one on the right showing highest priority, which is status 1. I'll be covering what are the indication of status 1. On the left hand side is the lowest priority, in which MELD is less than 15. Now the status 1 basically indicates fulminant liver failure if the life expectancy is less than 7 days. Now, and this has 4 types. One is fulminant hepatic failure as traditionally defined. Second, if you have done a transplant but there is primary graft non-function within a week of transplant, as indicated by liver enzymes SCOT level of more than 3000, INR more than 2.5, bilirubin more than 10, or acidosis, if lactate is more than 4, pH less than 7.25, they qualify for a primary graft non-function. If there is a hepatic artery thrombosis within less than a week of transplant, or acute decompensation of Wilson's disease, these are all status 1 category, most urgent or super urgent indication for transplant. Sometimes you have to do a retransplant, which is the second transplant, which can be done due to primary non-functioning of the graft or hepatic artery thrombosis or disease recurrence. Remember, retransplant is always inferior to the primary transplant. 3-year survival is only 40 to 50%. Liver transplant is also indicated for systemic complications of CLD like hepatopulmonary syndrome and portopulmonary hypertension. Liver transplant can be done in acute liver failure. An important statement: the use of liver transplant has been the most significant development in the treatment of acute liver failure in the last 40 years. So this is the main treatment which has transformed survival. And even though this is done as an emergency, the transplant survival stands at an impressive 80% 1-year survival, which is quite good. We have the King's College criteria due to paracetamol and non-paracetamol. They can be followed. And ALF not due to paracetamol. Single important etiology, single important factor is if INR is more than 6.5 or 3 out of 5. If etiology tells us it is drug induced or indeterminate, age less than 10 or more than 40. If jaundice to encephalopathy interval is more than 7 days, bilirubin more than 17 milligram, INR more than 3.5. You should have 3 out of 5. Now, important to remember that these criteria are not 100%. They are specific for 80 to 90%. Sensitivity only is about 2/3. There are various other prognostic indicators useful in prediction of outcome and selection of liver transplant patients in acute liver failure. Most important would be the etiology, certain lab parameters, and grade of hepatic encephalopathy. People with grade 3 or 4 hepatic encephalopathy are more likely to have cerebral edema and mortality will be higher, so they should be listed at least in grade 3 hepatic coma. Now, certain lab indicators like lactate, phosphate, ammonia, AFP, MELD score, and bile score, they are other indicators to select people for transplant. Now, this is an important slide. This is showing the survival for different etiologies of liver failure. And please notice that in pregnancy-related acute liver failure, survival from grade 3 to 4 encephalopathy is almost 100%, close to 98%. So pregnancy-related liver failure, survival 98%, which is the highest. Hepatitis A-related liver failure, survival 67%. Drug-related like acetaminophen or paracetamol, survival 56%. Hepatitis B, survival 38%. Seronegative hepatitis 20%. idiosyncratic drug reaction, only survival rate is 2.5%. Worst survival is in Wilson's disease with acute liver failure, less than 1%. So please transplant a patient with, if you have a severe drug-induced liver injury with ALF or with Wilson's disease. Now, liver transplant can also be done in acute and chronic liver failure, whether there is grade 1, 2 or 3. Then you have combined liver and kidney, in which you can have coincidental liver disease and kidney disease, like various causes of kidney disease. I'm sure Dr. Ranjan would know all of the kidney diseases. I don't have to list them. And then you can have advanced liver disease with acute renal failure. This acute renal failure may be in the form of HRS or ATN, and it is defined as if the patient is dialysis dependent, say for over 6 weeks, or if the ATN persists for over 6 weeks and estimated GFR is less than 25 ml per hour, they would qualify for a combined liver and kidney transplant. An important thing is that age should be less than 60. Beyond 60, it is difficult to do a combined transplant. Types of transplant, majority of the liver transplant surgeries in India are live donor liver transplant, 20% are those of deceased donor. Need for liver transplant. Now, every year about 30,000 patients in India need the liver transplant. At present, 1800 plus liver transplants are done in our country per year. There are 90 to 100 transplant centers in India, out of which 8 to 10 are high volume centers. Outcomes of liver transplant in India, mostly hospitals from Delhi have published their results. So just an approximation, 1 year survival stands at about 84%. Survival at 5 years is 75%. Survival at 10 years is 72%. For liver cancer, HCC, patients' 5-year recurrence-free survival is listed at 70%. Pediatric liver transplant survival is quite impressive, 1 year at 95%. And at 5 years is 87%. Survival of patient transplanted for ALF is slightly lower than these figures. Now, etiology-wise indications for transplant in India, commonest still would be combination of virus hepatitis B and C, followed by alcohol and NASH. Autoimmune hepatitis, ALF and HCC will fill up the gap. Now, this just shows a decrease, this shows a change in the trend in liver transplant etiology. And the first bar shows that it is, the first bar is basically patients who have hepatitis C. As you can make out, the indication in 2012 was in 37%, whereas in 2016 it's come down to 24%. So there is a decrease in the incidence of hepatitis C related transplant, whereas alcohol, which is shown in the second bar, and the non-alcoholic fatty liver shown in the third bar, they are showing a gradually increasing trend. And eventually alcoholic liver disease and NASH are going to overtake every other liver disease, and possibly NASH worldwide will become the commonest indication for doing a liver transplant. Types of graft, just go through it: whole graft, split liver, reduction, domino, auxiliary, ABO incompatible, whole list of them. This shows various centers in USA utilizing all these type of grafts, basically whether it is a live donor or domino type, or this is from living donor, or for reduced graft, split liver graft, just the various proportions. Types of liver donors may be a live donor, donation after brain death, as we were discussing, DBD, donation after cardiac death, DCD. Now, DCD donors are more prone to complications like biliary tract injury, ischemic cholangiopathy, bile duct stricture, simply because of the increase in the cold ischemia time. Types of live donor hepatectomy: open, lap assisted or robotic. In the end, if we have time, I've got a video about robotic type of donor hepatectomy. Now, about 60% of the liver volume is taken in donor hepatectomy. Minimum 30% of residual liver volume must remain in the donor. GRWR is important. Graft ratio to body weight ratio should be minimum about 0.8. I've given various figures. If the body weight is 100, you must have a minimum graft volume of 800. If the body weight is 70, minimum graft volume should be 560 grams. Now, there are certain absolute contraindications for transplant. They include if the patient has very severe cardiac or pulmonary disease like cardiomyopathy, valvular heart disease, symptomatic coronary artery disease, advanced ILD and COAD. Some of these patients would need a coronary artery stenting or a bypass before you can even consider transplant. Uncontrolled sepsis, intrahepatic cholangiocarcinoma, extrahepatic malignancy, hemangiosarcoma, HCC with metastasis, ongoing alcohol use, any other illicit substance abuse, MELD less than 15 in the absence of MELD exception points, persistence, non-compliance, lack of adequate social support system. In case of ALF, if there is brain death with pupils fixed and dilated, please do not transplant. If the patient is an MODS, has fungal sepsis or is on triple inotropes, do not transplant. Now, relative contraindication would be HIV. Many centers are able to do even with HIV positive. Portal vein thrombosis, chronic or recurrent infections like tuberculosis, psychiatric disorders, if BMI is less than 18.5 or more than 40, and cigarette smoking. Now, contraindications for a live donor liver transplant, if the liver biopsy shows more than 20%, if there is evidence of macrovascular steatosis, please do not use this donor. If BMI is more than 40 or liver attenuation index is less than 5. Now, pre-liver transplant coordinator, I think we have already discussed in a lot of detail. I just want to mention that to assist with the entire process of liver transplant, the liver transplant coordinator must be the primary contact for patients and their caregivers. This, I think, has summarized your role, and transplant will not be possible without you people. Will not be possible. Not just the doctors, not the surgeons, not this thing, but I think that's a very, very important role which you have. Now, there are various documents, certain legalities. You can go through the list. There are 17 documents required for liver transplant. We have a system in place at Fortis Mohali. Now, we have the informed consent form for liver transplant donor. We have very detailed informed consent form for liver transplant recipient, in which it is mentioned that there is a 5 to 8% risk of death at any time during the hospital stay, 5 to 10% chance of excessive bleeding. There may be a risk of intraoperative post-op bleeding, risk of doing a second surgery, risk of bile leak, risk of hepatic artery thrombosis. Everything is mentioned. They have to sign on the dotted line, otherwise please do not proceed for a transplant. A very detailed form. Now, these are various counseling. We have a first meeting counseling, we have a second meeting counseling, we have a third meeting counseling, then we have the final fourth meeting counseling, in which there is collection of the letter of approval. There is that is coordinating with doctors, OT staffs, and then we have a video recording consent, name of the patient, name of the donor. So we have 4 levels of counseling. Now, if you want to do a donor like health package for a live donor female, there are various departments which are needed in terms of cardiology, in terms of pulmonary medicine, gastroenterology, surgery, anesthesia, ENT, and OB-GYN, and a whole lot of tests, including detailed blood tests, including details like MRCP and a triple phase volumetry to assess for liver volume. Similarly, we have a complete list for a liver transplant donor male package. We also have got a very detailed recipient evaluation checklist. This has got about 18-20 pages in which we check the recipient in great detail. Now, what about the post-operative recipient care? Now, once the transplant is done, what to do in the ICU? You have to monitor a lot of things. ICU management of volume and hemodynamics in terms of ECG, blood pressure, volume status, management of volume status and hemodynamics in the initial liver allograft in terms of whether the patient is hypovolemic, hypervolemic, what are the vascular hemodynamics, management of liver allograft issues, how do you assess the initial liver allograft function by blood test, radiological studies. You can do a Doppler of hepatic artery, you can do a Doppler of the hepatic venous outflow tract. Then how do you manage the issues of respiratory and ventilator issues? Try to extubate as early as possible, try to avoid TPN, avoid prolonged ventilation, avoid pulmonary edema, keep in mostly isobalance, use of albumin in a very judicious form, then ICU management of cardiovascular issues and hemodynamics. You have to look after hypotension, you have to look after hypertension or any arrhythmias, you have to manage the fluid and electrolyte like hyponatremia, hypokalemia, hyperkalemia, hypomagnesemia, hypocalcemia, hypophosphatemia, and blood sugar control. Then there are management of renal issues post-transplant. We have to be very careful in terms of rising RFT, in terms of worsening RFT or creatinine. They may need a post-operative dialysis also. ICU management of immunosuppression and their complications. We normally start the patient on steroids, which we continue for 3 months. MMF is used. Then we start the patient within 24 hours on tacrolimus. Dose is very low, very less as compared to a kidney transplant. It's about 1 milligram. We start in the morning and evening. We check a TAC level and we maintain a TAC level between 8 and 10 immediately after transplant. Then we look after the side effect of steroids like gastritis, hyperglycemia. We check out for other kind of other systems like CNS in terms of calcineurin inhibitor neurotoxicity, seizures, CVA, post-transplant encephalopathy, and CPM. Many of these patients are hyponatremic. You have to be careful in correcting their sodium, otherwise there is a risk of CPM. Then we use certain antibiotics like piperacillin, tazobactam, or carbapenems would be indicated in high-risk transplant patients. Judicious use of antifungals or antivirals as per the clinical situation. Now, what is the cost of liver transplant? Difficult to get one figure, but this was an article in Times of India, and the range is between 20 to 30 lakhs. It could be even upwards of 30 lakhs. Mostly the hospitals give a package of up to 21 to 28 days if there is a complication, or if the patient needs regular dialysis, or hepatitis B immunoglobulin is needed, they bill extra. Or if they cross that 21 or 28 day stay, every day the bill is added. So still as a safe range you can say 20 to 30 lakhs. Now this is a lot. This is not cheap by any stretch of imagination. The future of liver transplant should be towards a more accountable, equitable and accessible form. Now, how do you prevent liver disease? Hepatitis B vaccination, lifestyle modification, control of diabetes and obesity, eating a healthy diet, regular exercise, and avoid alcohol. This is showing the lifestyle modification in case of liver disease. Probably this comes at number 3. After control of diabetes and hypertension, you look after your liver and you will be able to lead quite a healthy life. Now, can I have the video, please? 3 minutes. This is regarding a. This is from the YouTube, and this is for about 6 minutes or so. This is showing a robotic donor hepatectomy. जब 3 minutes पे आप start करना, या 3 minutes पे अपने पीछे या पीछे या can start.
Can you hit play?
Here we go.
Okay. This is our disclosure site. We have nothing to disclose. Our donor is a 26-year-old healthy female who completed her living donor evaluation and was found suitable to be a right lobe donor to her father, who had cirrhosis secondary to primary sclerosing cholangitis. Her predicted right lobe volume was 760 grams, leaving her with a remnant of 38%, which is more than adequate. This is a 3D reconstruction of a liver anatomy. This is the portal vein anatomy. We showed normal bifurcation. Hepatic vein anatomy. We show a dominant right hepatic vein with no need to reconstruct segmental veins. We note that she had a right hepatic artery arising from the SMA, which is a replaced right, and her bile duct had normal bifurcation with early bifurcation of the right hepatic duct into segmental ducts. This is a proposed transection line, leaving her with a remnant of 38%. These are some of our ports placement. We began by taking down ligamentum teres and the falciform ligament, proceeding superiorly until we reach the confluence of the hepatic veins. And our aim here is to expose the confluence of the right vein and the middle vein. We then move to the hilum of the liver, where we first perform a cholecystectomy. The cystic artery and duct are individually ligated, and the liver, the gallbladder is taking off the liver bed. We then pay attention to the hilum of the liver, where you can see this is the CBD, and because she has a right replaced hepatic vein, it is located behind the CBD. You can see the artery here, behind the CBD, and we are around the artery here, and this is loop with a vessel loop. Next, we are going to dissect superiorly behind the common hepatic duct to locate the portal vein bifurcation. And we've looped the right portal vein, which will go with the graft. We then rotated the liver towards the left of the patient to expose the retrohepatic vena cava, and we took down the attachments between the lobe of the liver and the diaphragm. We dissect the lobe of the IVC by ligating and transecting small hepatic veins that drain directly to the IVC. And you can see here that's the hepatocaval ligament. And before we leave here, we transect the caudate lobe. Back to the hilum. We are now demarcating the right lobe of the liver by clamping the hepatic artery and the portal vein. And you can nicely see the demarcation line here, but superiorly it's probably not as easily seen. We then ask our anesthesiologist to inject intravenous ICG, and you can see a very nice line of demarcation here as evidenced by the ICG. And even superiorly, it creates a nice line of demarcation to tell us where we should be going superiorly. And this will meet our confluence of the right and middle hepatic veins near the IVC. Again, ICG use. We then remove the clamps. And the next thing we will do is dissect the bifurcation of the bile duct, because the right hepatic duct will have to go with the graft. And this is where the transection line will end up in the hilum. And this is an ultrasound to check that we are on the correct side of the middle hepatic vein, and this is using the Tau Pro technology on the robot, where you can look at your ultrasound images and operative images at the same screen. We begin our transection. We use the robotic harmonic scalpel and the robotic bipolar with Maryland forceps. And this is a very meticulous and tedious process. All intervening vessels are thickened and ligated. And here we are going around the right hepatic duct. We had used the ICG to determine where the location is, and we are going to encircle the right hepatic duct with an umbilical tape. So this is the CBD here, and that's the right hepatic duct, and we will show with ICG, this is CBD, common hepatic duct, right hepatic duct, and after we've confirmed this, we are going to clip the right hepatic duct just before the bifurcation. Again, we will confirm again before we transect the hepatic duct. You can see the lumen of the hepatic duct. And then as we went posteriorly, we encountered a tubular structure, and we weren't 100% sure what this is. It could be a hilar vessel, or it could be another duct. So we decided to clip the other end, and then we realized it was the second hepatic duct, so the clip was removed. So this graft had two hepatic ducts, which will be anastomosed to the recipient. The sum of the right hepatic duct in the donor was then suture ligated with 6O PDS. This is to ensure no bile leak and also hemostasis of the hilar vessels. The rest of the liver parenchymal is then lifted off the IVC, and we continue transection until the whole liver is transected. And now we are going around the right hepatic vein, and we encircle it with an umbilical tape. Liver is then put in a bag. We're ready for removal of graft. The hepatic artery is clipped, transected. Portal vein is transected with a stapler. This is the right portal vein. And then the right hepatic vein is transected with a stapler. Small diaphragmatic attachments are taken, and then the lobe is inserted into the bag and removed through a phanesil incision. The minute it's out, the recipient is flushed with preservation fluid. In the donor, we complete the operation by irrigation, ligating the hepatic artery, and we check the remnant vessels to make sure all vessels are patent before we close the patient. We lost about 100 mils of blood in this procedure. The recipient and donor both did very well after the operation, and it's about 6 months later, and they're both still doing very well.
Okay, thank you for a patient hearing. I hope you understood. About 2 weeks ago, Dr. Ranjan had requested, I had no idea what to present. He told me, so somehow I could gather some information, and I hope it is useful. I'm here for any doubts, questions, queries. Dr. Ranjan is a very good personal friend also of mine.
So much, sir. Thank you so much for that excellent, very scientific and very well-designed presentation. And I must admit that you don't need time to present. You are such a spontaneous speaker with such a huge in-depth knowledge about the subject. I don't think so you need any time to prepare your presentation. And this is a really a very modern development. I see robotic hepatectomy, especially for the donor, because in kidneys we have always been doing laparoscopic donor nephrectomy, which enables the donor very swift recovery. Vis-a-vis in liver transplant, liver donors always go back with a very big incision. So I think this is a very major step which has happened because of the advent of robot. And I think this again is the surgery of the future. And in due course of time, at least the donors would be done robotically. Yeah. Are there any questions from the audience about liver transplant? Yes?
Yes, yes. Mike.
Sir, which lobe of liver is commonly harvested and why?
It is the right lobe of the liver, mainly for adults, because the volume, as I showed you, the right lobe is more than 2/3 of the liver. So we harvest the bigger lobe. In children, especially in neonates, you can harvest the left lobe or a part of the left lobe also in neonates. Otherwise, standard, it's a donor right hepatectomy, robotic, lap assisted or open. Right lobe because of greater volume. If you harvest a left lobe for an adult, the patient, the recipient will not survive because of small for size syndrome, right? Within a couple of weeks, the recipient will develop jaundice, hepatic comycytis, and you will lose your recipient. So wrong selection.
Thank you, sir.
Look at the type of equipment, type of workup, type of investment that goes in from a hospital. Right, I think the cost, honestly, hospital may not be making that much, to be very honest, because there are a lot of logistics involved, lots and lots of logistics involved. There is a high cost. I mean, I'm not able to tell each cost of, say, if post-operatively the patient needs something like meropenem, or if he needs expensive antifungal, needs hepatitis B immunoglobulin, or if there is some complication, the donor normally we keep for 7 days, recipient for 3 weeks. If there is a complication, the hospital has to bear up with that expense also. So I think it is reasonable. Yes, the government should be able to sort of help in some this thing, but hospitals can't do a liver transplant at 3 lakh, 4 lakh. I don't think so. It is not, the cost would be there. Cost would be there. Dr. Ranjan, your views on the more expensive liver than the kidney?
Because see, even in PGI, in an institution which is almost fully supported by the government, there also the cost of liver transplant is approximately 5-6 lakhs. in a fully supported government institution. So the kind of consumables which are used, the kind of blood products which are used, because as sir had rightly pointed out, liver is the synthetic machinery of the body. So once you clip the synthetic machinery of the body, the maintenance of the donor and the recipient both are very, very expensive in terms of the kind of blood products which are used, the kind of transfusions which are being done. Then hepatic artery is a very, very small artery. If you see the liver transplant team, there are two teams. One is a donor team and one is a recipient team, and there are 3 surgeons minimum in each team. So there are 6 surgeons continuously operating, and the liver transplant goes for most of the times 12 hours. 12 hours, 14 hours, many times they are operating.
Yeah.
So a lot of manpower cost is there. Equally important are the OT team. There would be approximately 20 OT personnel. Then there are certain tests which are done at very regular intervals, such as thromboelastography. These are expensive tests, and these are done very, very regularly, because liver is the storehouse of the coagulation proteins which are being produced. So every hourly you have to check the TEG, thromboelastography, to know what is the quality of the blood. Otherwise, it's such a huge raw area, patients would bleed to death. So liver transplant took a lot of time to be successful, and even in today's date, you can count on fingertips how many surgeons do the liver transplant, how many centers have a good result in liver transplant. Still, it is less than 10. So liver transplant is a very, very labor-intensive, very richly expertise-backed surgery, which needs a lot of equipment, whole infrastructure, as well as the ancillary equipment. Probably that is why the cost is so high.
So these data are from like private hospital, 20 to 30 lakh?
Yes, absolutely.
Majority of the liver transplants are done in a
99% of
private.
liver transplant is done in the private
in
hospital
a private
only.
sector, yes.
So government hospitals are very few which are doing liver transplant. 10 to 12 lakhs. So if a surgery in PGI is costing around 10 to 12 lakhs, then at least private sector, the cost is at least 3 times, because the salaries of individuals are excluded. PGI is entirely being this, government is bearing the salaries of huge manpower.
No, it's not very common. It is more fulminant actually. There are various reasons. One is not entirely clear, but pregnant females are very, very prone to acute liver failure due to hepatitis E. Per se, it is not more common, but the fatality rate for some reason is high. So one has to be very careful during pregnancy, and hepatitis E is basically through orofecal transmission. One should, these people say during 3rd month, 4th month should not be going out eating chaat and golgappas and all. One should be careful. No, that is very important, and especially during monsoon season, they should be very, very careful. This is a waterborne ailment. Okay, yeah. Dietary, no major modifications. 20-30% of people will develop a metabolic syndrome or diabetes due to steroids and tacrolimus. So mainly some restrictions as far as the diabetic control is concerned. That is that majority of the patients will put on some weight, may develop metabolic syndrome, and newly onset diagnosis of diabetes mellitus after transplant would be as high as 25 to 30%. So from that point of view, otherwise they lead a pretty normal life. Yeah, one has to be careful not to start alcohol. Basically, you will be surprised, about 1 in 10 people will go back on alcohol, maybe more. More than 10% of heavy alcoholics will go back to drinking alcohol. There's one patient of mine I'd referred to, Gangaram, I just wanted to share. So the wife told him that you have had a liver transplant for acute liver disease, do not go to any theka. So theka, you understand, huh? Do not go to any shop, okay? So he said, so after 6 months he was totally sozzled. The wife said, ki, I asked you not to go to a theka. Kanda, I got the theka in my house. I have opened a shop in my house. So this is the level of desperation which people have after a liver transplant, which was donated by his son from Australia, and he gave him a brand new sports car in return. This is my patient. Okay, so I won't disclose the
Rather,
name.
he would have said, I've got the transplant done to be able to drink. So,
Nothing major. They are not on any drugs now. Even the scar, if you're doing it robotic or laparoscopically, there's hardly any scar. Otherwise, they are okay. Within a period of 4 weeks and all, they are okay. In the first month or so, avoid lifting heavy weights and all, but no major restriction on the donor.
I think the scar would be around, say, 8 to 10 centimeters just to deliver out that segment.
That's
Otherwise, in a traditional
Yeah.
wound, should be around 25, 30
Yeah.
centimeters. Anything else? So, with that, thank you so much,
thank you.
sir, for this elaborate talk.
Thank you.
And I would request Pallavi to please honor Dr. Sahni. Shashi, can you take the photograph? Thank you. Thank you, sir. Yeah. So we'll go ahead with the next session. And for the next session, we have Pallavi. So what we have done is we have skipped off the tea today. Tea is kept there. If you want, you can have it with lunch. But we'll just quickly go to the next session, finish it off in next 15-20 minutes, and then break off for lunch. Okay?
So this session is about how to start a deceased organ donation program in a hospital, and how useful it will be for any one of you is really dependent on your individual initiative. Because ये ऐसा program है कि कोई एक इंसान champion करे ना, उसको push करे हर वक्त, it takes off. Because otherwise it's nobody's baby. All right? So normally I like to do this session in hospitals with various levels of people, the senior management, the transplant teams, the critical care, all of that, the nurses, admin people. But I'm going to lay down this session for you, and keep it in mind. So when you go to a hospital where this program is not happening, you at least know what needs to be done. I call it ingredients of a successful. Chandigarh? ये वाला Chandigarh. Yeah. So when you're So when you're making a dish or something, you have to have certain ingredients, and if you miss out one, your dish really doesn't work. So that's true of a deceased organ donation program also. When you're going to start a program, you need to ask yourself some questions, and the hospital has to ask themselves some questions. Do we have a transplant program? Normally, if a hospital has a transplant program, it's largely dependent on living donation. We all know that. You have to ask yourself, is that enough? If it is not enough, do we really want to invest in a deceased donation program? Because it has to really mean something for you if you have to make it work. अगर ऐसे एक नाम के वास्ते अच्छा चलो deceased donation भी एक दो कर देते हैं, it will never take off. It won't reach its optimum. So, and I was talking to the PGI coordinators yesterday. They have, I think, 6 dedicated counselors for deceased donation program. Now that shows the seriousness. Of course, 2 of them were involved in COVID during the COVID time, but that shows the seriousness of the hospital to make their deceased organ donation program work. Okay. सबसे पहले ज़रूरी है, your top management has to be interested. There has to be an interest from the head of the hospital. If the person is not interested, believe you me, this program will not take off. So don't start this program if your top management is not interested and if there's no buy-in from the head of the hospital. Then you create a formal policy document which should be part of your overall hospital policy. That's the kind of seriousness you have to give it. The policy document you would have for kidney transplant or critical care or whatever, you have to have something on organ donation. And of course, it should be based on the guidelines suggested by the Transplantation of Human Organs Act. So it should be an ethical document. this is one program that requires a collective ownership and interdepartmental efforts of so many departments. Just see the number of departments that are involved. You're talking about the hospital management, your MS, your head of intensive care, your neurosurgery, neurology, forensic, of course it will be outside, transplant nephrology, transplant urology, liver transplant, cardiology, cardiothoracic, nursing superintendents. So number of people who are involved in making one donation successful. So before we start this program, we suggest that you have an organ donation and transplant committee which has representation from all of these departments. And we work with a lot of hospitals, so we also want to be represented, so as an NGO representation. So maybe in the beginning, you want counseling to be done by a NGO before your own transplant coordinators start off. Okay, and of course the transplant coordinator, the hospital. So this is a larger committee, and there should be a chairman, there should be a convener, there should be proper this thing. What is this committee really doing? It is actually getting together, discussing and formulating an action plan for your deceased organ donation program. How will we take it forward? Kya karenge hum? How will we put it in place, you know? And on all aspects of organ donation and transplantation, how will identification be done? You know, the policy for that hospital, how will maintenance be done? ये नहीं कि donation हो रहा है और ICU के बाहर खड़े होके people are arguing with each other. No, maintenance should be done with this medicine, whatever. All of should be written down, laid out, and agreed policy for the entire hospital. How will the certification be done? How organs कैसे harvest होंगे? Sharing and distribution कैसे होगा? In a lot of places, when we start, in a lot of states, there is no sharing protocol. Even in Delhi, when I started 14 years ago, there was a lot of pressure on the foundation to do allocation. Of course, NATO and all came into place later on. But जब तक वो नहीं है, hospital should be clear. What, we will keep one kidney, one liver, the other one we will offer to a government hospital, whatever. All of that should be very clear. And of course, if there's a state authority, you don't need to do all of that. Then, of course, as you know, if you have to start a deceased organ donation program, you have to have a brain death committee. You cannot declare brain death without a brain death committee. So you make an application to your appropriate state authority. The brain death committee has specialists of the hospital that are not involved in transplants. The head of the institution, the MS, has to be part of it. Now, the law does not say कितने लोग होने चाहिए ब्रेन डेथ कमेटी में, तो आप ज़्यादा से ज़्यादा लोगों को डालो, बिकॉज यू नो पीपल विल मूव आउट, समटाइम्स पीपल विल नॉट बी अवेलेबल, उस वक्त रात को नहीं अवेलेबल हो, ड्यूटी पे ना हो. सो मेक इट अ रियली लॉन्ग लिस्ट, बिकॉज लिस्ट को बार बार चेंज कराना इज़ अ cumbersome process. So make sure you have enough people on that list, and has to be continually updated. Keep looking कौन लोग चले गए, 10 लोग तो उसमें से चले गए हैं, so then you look at making a new brain death committee. If you have to be a hospital that is going to be successful in deceased organ donation, declaration of brain death has to be a mandatory process. It should not be at the whims and fancies of the neurosurgeon or whatever, कि नहीं ये family तो हाँ नहीं बोलेगी, इसको क्या declare करना. Every family has to be declared, and that conversation with the family has to be done. हाँ बोले ना बोले, that is a subsequent thing. But the fact that it is mandatory in this hospital to declare brain should be part of your policy document. There has to be a willingness of neurophysicians, neurosurgeons. So, इनके कुछ concerns हैं, you have to have training, meetings to address those concerns. It should be part of the culture of the hospital, and sometimes very good to identify a champion. Champion is a person who is leading this program, जिसका main interest ये है कि disease donation होए इस hospital में. Spain, as you know, as a country, is doing very well in organ donation. They work on this champion. Every hospital has one. Normally, it's an ICU intensivist person who's a champion for the program. क्योंकि बाकी लोगों के, like I said, interest differ होते रहेंगे. इस champion का काम ही यही है कि disease donation होए इस hospital में. Then, of course, you have to have a transplant coordinator who, as we just learned earlier in the session, is central to the process. Counsel भी कर रहा है, family support भी कर रहा है, coordination documentation भी कर रहा है, you know, interacting with the police in MLC cases. So it's very important to have a trained transplant coordinator. And as the program grows, make sure there are separate set of transplant coordinators for a living program. Very often hospitals, what they'll do is they have a living program going, they have a living donation transplant coordinator. उसी को use करते हैं for deceased donation. एक इंसान की उतनी ही तो लिमिट हो सकती है ना कि वो सारा दिन भी काम करे, रात को भी कुछ काउंसलिंग केस आ जाए. सो इफ यू आर लुकिंग एट अ डिसीज डोनेशन प्रोग्राम, यू हैव टू हैव अ सेपरेट सेट ऑफ ट्रांसप्लांट कोऑर्डिनेटर्स. उनको रेगुलरली ट्रेन करना, उनको एम्पावर करना, बिकॉज दिस इज द पर्सन हु विल लीड दैट प्रोग्राम. Providing designated room, as I said, is very important. Then we suggest having what is called a hospital coordination committee. पहला था organ donation and transplantation committee जो कि policies decide कर रहे हैं, program की progress decide कर रहे हैं. The hospital coordination committee is the committee that is in play when an actual donation takes place. आज donation हुआ है तो this committee will be involved. फिर वो larger committee को नहीं उसका तो आप involve कर रहे हैं. Coordinates the actual process of donation. तो आपके ट्रांसप्लांट कोऑर्डिनेटर्स होंगे, एक कन्वीनर होता है. यूजुअली द चैंपियन इज अ कन्वीनर. सो गेट अ हॉस्पिटल कोऑर्डिनेशन कमिटी सो दैट नो केसेस गो अनलुक्ड इनटू, अनआइडेंटिफाइड, अनकाउंसल्ड. हर चीज़ के हर एस्पेक्ट ऑफ दिस प्रोसेस यू शुड हैव वेरी डिफाइंड स्टैंडर्ड ऑपरेटिंग प्रोसीजर्स. हम लोग का एक स्टैंडर्ड डॉक्यूमेंट है विच वी शेयर विद हॉस्पिटल्स, बट वी से आप लोग बैठ के इसको डिस्कस करें एंड अराइव एट अ document that is true for you, that is accepted by your hospital as a collectively as a team on every aspect of organ donation. चाहे वो identification हो, GCS 5 होगा, क्या होगा, सर्टिफिकेशन कैसे करेंगे, मेंटेन मेडिको लीगल केसेस में क्या करेंगे, कौन करेगा, किसकी रिस्पॉन्सिबिलिटी, इट इज़ डिफाइंड दैट डॉक्यूमेंट. First call कहाँ जाएगा, who will inform the state of, so there's no confusion because an organ donation process is a very complex process. उसका काफ़ी confusion मचा होता है. So if everything is laid down कि ये role TC का है, ये critical care का, ये इसका है, ये convener का है, then at least confusions can be avoided. Costs, अगर आप किसी दूसरे hospital से potential donor को ला रहे हैं, वैसे तो वो avoidable होता है, but sometimes you have to do it. You have to bring the person in a ventilated van. There is cost involved. Who will share that cost? All of these things should be answered. Billing considerations, room देना अगर family को, all of this becomes part of your policy document. अगर आपको, if you have to be a hospital that is looking at a disease donation program, you can't just be involved in counseling and retrieval of organs. You have to have be known as a hospital that supports organ donation. आपके reception में there should be messages on organ donation, there should be things put up, posters, standees, जो भी आपका LCD screen है. So there is an investment required. Go out and do public awareness and sensitization in hospitals, schools, corporate, around your hospital so that you are contributing to the larger ecostructure. And of course, all those activities require a budget. Are you a hospital that allows for organ pledging? You know, does it have information and flyers available where patients are sitting? FAQs on organ donation, all of that has to be in place. And of course, like I said, it requires a budget. Here, what becomes very important for this program to succeed is regular monitoring and review, which is done by the larger committee, which sits together at least once in a quarter and says, अच्छा, or maybe you can do 6 months, कि कितने potential donors थे इस 6 महीने में और कितने certify हुए, बाकी certify क्यों नहीं हुए, क्या reasons थे उसको ना certify होने के, कितने families को approach किया, कितनों ने हाँ बोला, कितनों ने ना बोला, ना बोलने के क्या reasons थे, you know, कितने organs utilize हुए, कुछ waste हुए, क्यों waste हुए, donor family, what does it feel about it, when you what did the team involved in the donation feel about it? When you do this kind of a review, then you are able to arrive at reasons for lack of success or reasons for failure. Kya, you know, did we not certify certain patients because there's one neuro who says कि नहीं, मुझे तो इस program में interest ही नहीं है. So then you work with that person. So when you do regular monitoring and review, you are able to relook at the program and address difficult areas. There is no underlying the importance of ongoing training and sensitization, whether it's for doctors and paramedics or for transplant coordinators. It should be ongoing because people keep moving, keep changing, newer people keep coming, and when you have trainings like this, then you look at things with a newer perspective, with a fresh perspective, energy infused hoti hai. So it's very important to do that. आपको क्लैरिटी होनी चाहिए, अगेन पार्ट ऑफ योर पॉलिसी डॉक्यूमेंट कि मेडिको लीगल केसेस में आप कैसे करोगे, हैव यू स्पोकन टू योर नियरेस्ट पुलिस स्टेशन, हैज समबडी सेंसिटाइज द पुलिस पर्सनल, ऑल ऑफ दैट. सो डू good relationship with your local police authorities and the forensic? Are your forms in place? Do you know how to create a green corridor? ये सब चीज़ें पहले से ही thought out होनी चाहिए. They don't come at the last minute because then they don't get done. And like I said, for a successful program, if you are serious about it, please make sure that there's a room, counseling room allotted to the grieving family. Admin knows what they need to do, when the billing has to stop. यही सब चलता रहता है. Family गई, counselor बताता है family को कि आपकी तो billing रुक जाएगी. वहाँ से admin कोई billing मांग रहा है. Post the consent time. So that kind of a confusion is very disturbing for the family, and that's why everybody in the hospital has to be on board. ओटी से बॉडी निकल के आ गई है, हर्स वो टू टेक इट डाउन टू द एम्बुलेंस वही नहीं आ रहा है, उसमें 25-30 मिनट निकल गए बिकॉज person doesn't know what is expected. So how do you put systems in place? You know, you put a wreath on the family when on the body when the body is being taken out to show a mark of respect. Have you heard of donor corridors, where hospitals and staff, they line up on either side of the corridor when the body is being wheeled out to show mark of respect? Everybody should know. ये नहीं हो कि लोगों को बुला रहे हैं, कोई आ ही नहीं रहा है, वही 3-4 लोग खड़े हुए हैं, transplant coordinator एक दो. All of this has to be part of the culture of the organization, and the fact that every document should be part of a folder or whatever, and a combined commitment of all to make it a success. Yeah.
Thank you, Pallavi ji. I think very well spoken, and it simply shows the sheer passion involved in the work and the kind of commitment you already have. And it just shows all of us that how deeply you have been involved with your soul and passion to develop this program. We have had many years back, there was a donor, potential donor. She was a gunshot wound. The lady came from Shimla, and we were clueless what to do. So Dr. Avnish Seth was there at Fortis Gurgaon, so he was being called. He checked all those forms. There was no systems in place. The point which you made out, the billing of the donor has to stop. All of a sudden, some front office receptionist sends the bill, calls them for, the moment they realize the patient is dead, they are in a hurry to clear the bills. So all these things create a lot of confusion in the mind. Then we were not clear about how to approach the police, where will the autopsy be conducted, post-mortem. So all those confusions arose so much so. Yes. So once the family also is looking that the entire system is confused, they will never agree for. So ultimately, but since the family wanted organ donation, so we had to shift that donor to PGI. And that was also a huge hue and cry. With that, the patient was shifted. So many lessons were learned that time. So all these things were very highly surfaced, and we could gather that there are so many things which we have to first correct before we even think of this program. So it's not easy to... Exactly. That it has to be culture. It has to sink in the administrators, doctors, as well as the other staff. Yeah.
Wife was supposed to come from other foreign country. तो बाकी family member से बातचीत हो गई थी, and then everybody left because they didn't know whether she was going to come into the hospital that night itself or come tomorrow morning. She had a late night flight. वो by chance wife came into the hospital late at night, and she asked somebody, वो नाम लिया, and the ward boy or somebody was saying, oh, organ donation वाला case. You know, she had not even been told कि ऐसी कोई बात उठ के आएगी, and she was so horrified to hear that, and then of course it became a big issue, and then of course the donation never happened. That's a different matter, but you can't blame the ward boy. किसने उसको बैठ के समझाया था किस तरह से बात करनी? They should all feel part of a bigger objective, a bigger calling, a bigger purpose, you know. And everybody has to be sensitized. You can't just say कि critical care को train कर दो, इसको कर दो. Everybody from top to bottom has to understand that we are part of a common purpose, you know, and speak the same language and follow the same culture. So that's really, really important.
So any doubts or any questions bubbling in your minds? Yes, ma'am. Yeah, mic दे दीजिए, please. Mic.
hospital has to be there.
There is, and if you go back to your manual, it says where you are applying for to be a organ transplant center. It says certain requirements are there in terms of ICU facilities, beds, surgeon facilities. It's all there.
Okay,
A very
thank you.
small nursing home can't be a organ
Okay.
retrieval center.
Yeah,
Okay.
what was
Thank
the question?
Basic requirements to be a hospital that can start a program.
Okay, so we have an entire licensing process for a hospital. Now under the NOTP program, we have the National Organ Transplant Program. So it has given way for two types of hospitals. One is an organ retrieval hospital and another is a transplant center. For example, suppose, and under the program, almost all hospitals or small nursing homes should apply for resistance for license and registration at least as an organ retrieval center. So even if they don't have the facility or licensing for transplantation, because it's a long process, there's a list of infrastructure, list of manpower, list of trained personnel, blood bank, ancillary facilities. So a lot goes into the licensing of the hospital for a transplant. But yes, for a non-transplant organ retrieval center, there are very lenient provisions. Suppose there is some brain death happening at a peripheral hospital, which is 40-bedded, 50-bedded hospital, small hospital in Ropar. So if they have applied a license for retrieval center, then the surgical team can go there, retrieve the organs, and they can come back. Otherwise, the entire donor needs to be shifted, which is a very, very difficult shot.
They still have to have their own brain death committee. They still have to have a transplant coordinator. उसके भी कुछ
There are requirements for that.
it's not that easy. And sadly, then hospitals that are not going to use organs for transplants never seem to have an interest.
Yes, yes.
Sad thing, but
Basically, their interest is if they are not transplanting, the money doesn't come in. So they are least bothered. So that is why this program is not very common. Anything else?
Thank you very much, ma'am, for nice presentation. And I have one query from the last session you have taken. जो consent form है, it is only available in English or in local language also?
It's available in language, but local languages में translate करना है.
कर लेंगे अभी लाइक इंग्लिश में है ये ओके क्योंकि वी प्रेफर कि लोकल लैंग्वेज वगैरह समथिंग या ओके
नहीं, लोकल डायलेक्ट में है. मतलब आप उसको कर सकते हो. उसकी कॉपीज हॉस्पिटल में, अब यहाँ पंजाब में है तो हम पंजाबी में रख सकते हैं, उधर केरला में तो एवरी स्टेट कैन हैव इट्स ओन.
हाँ बिकॉज वी हैव अदर प्रोग्राम्स तो हाँ
कभी भी उसको ट्रांसलेट करके नया फॉर्म नहीं बनाना. यू कैन आइदर हैव इंग्लिश एंड देन हिंदी की लाइन.
ओके
सो द ओरिजिनल हैज टू बी मेंटेन. यू कैन हैव हिंदी की लाइन नीचे और द लोकल लैंग्वेज, बट नेवर जस्ट ट्रांसलेट एंड मेक अ हिंदी फॉर्म.
थैंक यू सर
नेवर डू.
All right, so no more questions. So we break up for lunch and then we again assemble here at 2 o'clock. Okay? Thank you. Ajay, before that, all those people who wanted the photographs, so the photographs will be available by evening in my office. So group A and group B can respectively collect. We have those number of photographs which we ordered yesterday. Okay? Reena in my office will assist you. Thank you.
Okay, good afternoon all. I hope you had a lunch and you're not sleepy, right? Okay, so now we have next lecture by Dr. Amit Kumar Mandal, and he is a Director Pulmonology and HOD of Medical ICU and all other general ICUs. So please.
Yeah, I'm audible now. Yeah. So post lunch, I hope I don't put you through a mundane kind of a lecture. So, please pardon me. We don't have a lung transplant program here, but yes, some of our patients, are referred for transplant. Some of them have been accepted. We do get to see some of these patients back for different reasons. So the way that I would go through the next half an hour or so is take you through where we are with lung transplant in the country, what is the ideal lung donor conditions like, what are the general conditions for, or general considerations, not conditions, general considerations from the surgical point of view for a lung transplant, the different indications. Now there are different indications. There is a time that you would refer down to, there is a time when you will actually put them on the list for the transplant. And then in a country like India, with TB being prevalent so much, it is something that is fearful in our patient, because all these patients would be on immunosuppression. Talk about the sir. Thank you. So talk about the risk factors, the absolute contraindications, the high risk factors, and some of the unfavorable risk factors, and then of course complication, and then close. So we are a big country. We contribute about 18% of the world population, but ironically, and mind you, this is only the obstructive airway disease. So there are two types of diseases: obstructive airway disease and a restrictive lung disease. So in the obstructive, this in India contributes to about 32% of the global chronic respiratory disease burden, and this doesn't have the interstitial lung disease data. So this would probably be much, much more. In India, the first lung transplant, probably the double lung transplantation, happened way back in 1999, along with the lung and heart transplant, and that's where our lung transplant era kind of began. 2007, the combined heart-lung transplant had taken place at Apollo Chennai, and subsequently more centers came in. In 2011, this first single lung transplant was performed in global hospitals in Chennai. This is where we are, predominantly down south, Tamil Nadu, Telangana, Karnataka. These are the states which are doing maximum amount of work. Rajasthan and the northern part is just getting into the picture. This is where we are in terms of the numbers. Tamil Nadu, of course, it's all probably because, as we were just discussing a while ago, it's probably because of the beautiful public and private partnership where the government machinery is also equally involved along with the medical decision making, and that's why you see these large numbers and huge success stories. Survival, surprisingly, lung is considered one of the not so good organ to get transplanted. Yet you do have good survival worldwide, and as ma'am just asked, who is the longest survivor in the world, and it happened way back in 1990 when the gentleman was about 28 years of age for cystic fibrosis. That's the reason why he got lung transplant. Till 2017, 27 years post-transplant, he was doing well. So in the 2020 published data from Apollo Chennai, they had given a survival, 3-year survival of about 76%. From Gleneagles Hospital, Chennai, it was in the range of 85 to 78 at 1 year, and from KIMS Hyderabad, it was about 80% in the end of the first year. So if you look at the indications, which in the Indian context, with these two centers being the largest, interstitial lung disease contributes to about 65%, with hypersensitivity pneumonitis and idiopathic pulmonary fibrosis, both restrictive disorders, being the leading cause for the lung transplant. Bronchiectasis, about 10%. Now, in India, we don't have so much amount of cystic fibrosis. Yes, there are children being diagnosed with cystic fibrosis, but a lot of them do not see the end till the transplant. Idiopathic pulmonary arterial hypertension is the other. In the Apollo experience, purely lung transplant, it is again interstitial lung disease, end stage, which contributed about 84%. They had about 10% of chronic obstructive pulmonary disease. Mind you, this was the data that I showed right in the beginning. 32% of the world data obstructive both asthma and COPD, but COPD predominantly. Here, only 10% underwent lung transplant. Bronchiectasis was about 5%. Both heart and lung transplant, it is again ILD with end-stage cardiac disease, about 40%. Idiopathic pulmonary hypertension, about 35%, and then subsequently bronchiectasis, congenital heart disease, COPD, ischemic cardiomyopathy, and irreversible pulmonary hypertension. These are the indications why these patients went through the lung transplant. Now, the peculiarity why lung is not such a favorable organ for transplant is because it has a dual supply. One, the large pulmonary artery circulation, which supplies the desaturated blood under low pressure, and this is basically takes part in the alveolar gas exchange. The smaller bronchial arteries is the oxygenated blood under systemic pressure, which provides nutrition and oxygenation to the bronchial and lung tissue. And this is the only organ, this is the only solid organ transplant that does not undergo a primary systemic or a bronchial artery revascularization at the time of surgery. And because of the absence of the bronchial system in the lung allograft, the increased susceptibility to microvascular injury and chronic airway ischemia, and that's the reason why lung has so much amount of rejection and complications, and which is unfavorable compared to the other organs. So what are the characteristics of an ideal lung donor? Who would be the patient that we would probably harvest the lungs? Somebody who's, now mind you, this is the ideal ABO incompatible donor, size which is matching the height and the predicted total lung capacity, age less than 55 years, a smoking history of less than or equal to 20 pack years, no history of chest trauma. This patient is ideally been ventilated for less than 72 hours with a PaO2 of more than 300 on 100% FiO2 with a PEEP of 5 centimeters. And on bronchoscopy, there is no evidence of major secretions or any infection. There is no evidence of aspiration or sepsis, and no prior thoracic surgery on the side of the harvest. And this is one of the problems, though the data doesn't suggest that there is poor response, but yes, ideally there should be no history of surgery. Ischemia time as low as possible, but yes, there is a time lag from the time that it is harvested to the time that it is transplanted. Ideally, it should be less than 6 to 8 hours, though long durations of even 11 hours have been done. In terms of the allograft or the donor size, yes, it would be equal. Best is when it matches the size of the donor, but at times, the smaller grafts leave a significant amount of empty space, necessitating the tubes to stay in a longer time, as a result of which it can cause pleural infections and empyema and so on and so forth. And if the donor size is larger than the space that is to be transplanted into, then you can end up with tamponade and atelectasis. Even torsions happen. So what is normally done is the larger organs are used for patients with something like an obstructive airway disease where they are hyperinflated lungs. So preoperatively, these are hyperinflated, and these are the lungs which are transplanted with the larger lungs. For the restrictive impairment or the restrictive lung disease, the smaller organs are chosen. And donors with a predicted TLC of about 75 to 125% of the predicted TLC of the recipient can be safely be used. Now, this is one of the ways. There is no perfect way to have the best, what is the best size for the lung. But this is how probably, the lungs are measured from the dome of the right diaphragm to the apex on the right lung. Similarly, on the left side, as well as at the aortic notch level, the width of both the lungs, as well as the width of both the lungs together at the level of the higher end of the hemidiaphragm. And that's how you would probably look at the donor and the recipient, and that's how, if it matches, that's the best fit. Now, when it comes to the, when should we start, sending our patients down? When should we start evaluating? When should we start listing them? These are different terminologies, and they have important, implications to the patient end. Now it's a complex process. All this transplant is a complex process and should be begun as soon as possible. So there is ideal time is before they meet the criteria for active waitlisting, wherein there would be the first couple of people to be chosen to be transplanted at the time of availability of an organ. And this is primarily to introduce the concept of the lung transplant. It's not the end of the problems. If it's a beginning of a series of issues which the family and the patient needs to be apprised of. The concept of lung transplant, its requirement, and importantly discuss the expected outcomes. Why is an early referral an ideal thing? It's basically to look at the modifiable barriers to transplant such as obesity, malnutrition, medical comorbidities, or inadequate social support. Vaccination should be done as early as possible, mind you, because post-transplant the live attenuated vaccines will be contraindicated, and they should be ideally be vaccinated with all the hepatitis and the pneumococcal vaccines, and so that because a lot of these patients will require subsequent vaccinations also, because the protective effect in the immunocompromised state decreases. In terms of the full evaluation, these patients should be assessed, the assessment of the lung disease severity, the anatomy, the nutritional status, the degree of frailty, presence and severity of comorbidities, the psychosocial circumstances, which is so often overlooked in the medical scenario, and health-related behaviors that could impact the recovery and long-term survival. In recent times, since the times of COVID times, you would have seen that a lot of our patients who have gone on to ventilation and gone on to ECMO services have been fast forwarded into the transplant. So patients on life-sustaining interventions can be used as a bridge to transplant and may be considered in highly selected patients at centers with expertise. Now these patients are generally moved from one center to these specialized centers on the extracorporeal life support, which is the ECMO typically, and that's how they are transported. So coming down to the general considerations in terms of who needs the lung transplant. So I've taken all this from the 2021 publication of the ISSLT, the Journal of Heart and Lung Transplantation. So lung transplantation should be considered for adults with chronic end-stage lung disease who would meet all the following general criteria. A high risk, almost more than 50% risk of death from the lung disease within the next 2 years of time if the transplant doesn't happen. Or more than more than 80% likelihood of a 5-year post-transplant survival from the medical perspective, provided that there is adequate graft function. So these are the two indications where one would think in terms of providing the lung transplant to such a recipient. When it comes to the children, typically, children in the this thing has been defined as less than 18 years of age. Patients with cystic fibrosis less than 18 years of age should be referred when their FEV1 or the forced vital capacity, forced expiratory volume at the first second is less than 50% predicted with markers of increased disease severity or a rapidly declining FEV1, or it is less than 40% of the predicted. These are the patients with cystic fibrosis who should be taken up for, considered for lung transplant. Now, when it comes to patients with pulmonary arterial hypertension, now this is a population that we see often less in our context, in our country, but just for the sake of discussion, these are the indications when a patient with pulmonary arterial hypertension less than 18 years of age should be referred despite being symptomatic with optimal PAH therapy, and this is primarily because of the need for intravenous or subcutaneous prostacyclin therapy, significant RV dysfunction, continues to be dyspneic with a WHO functional class of more than 3, deranged, elevated, rising NT-proBNP, diminished growth, progressive disease despite the appropriate therapy with recent hospitalization suggesting worsening of the arterial pressures, significant other extra organ damage in terms of the liver or kidney functions due to pulmonary arterial hypertension, and potentially life-threatening complications, particularly recurrent hemoptysis or patients having syncopal issues. They could also be considered a high-risk atrial septostomy, which is done by cardiologists in the cath lab, or a reverse pot shunt as a palliative procedure by the time they get down to the transplant. In terms of the listing of the children, apart from the general recommendations for adults, Cystic fibrosis less than 18 years should be listed when the FEV1 also has a 40% or 30%, as I just talked about. I think this is a repetition of the same slide. Now, as I talked about the bridge to transplant, or the patients who are on extracorporeal life support. This has gained, a lot of enthusiasm after the COVID times, when a lot of our patients who were almost not looking at a survival, severe ARDS, were offered lung transplant in different centers. Now, there is, in some countries, there is urgency-based lung allocation systems where they can probably use this as a viable option for lung transplant. And this is where the usual patients are kind of superseded. Indications for the extracorporeal life support systems include hypercapnic respiratory failure, hypoxic respiratory failure, right ventricular failure. Mind you, not all candidates could be candidates for such a transplant. Extrathoracic organ dysfunction is a strong contraindication, excepting in patients with pulmonary hypertension where liver and kidney are dysfunctions are seen to, they generally get reversed once the transplant kind of happens. Coming now to the individual indications, and this is where we'll talk about the time of referral and the time of listing. These are the various diseases that one could think in terms of transplanting. When we talk about COPD, now COPD is our biggest burden in the context, but if you look across both the large centers from down south, this was not such a popular disease to be transplanted. It was interstitial lung disease primarily. So board score is basically body mass index, dyspnea score, oxygenation, as well as an obstructive airway disease, dyspnea score more than a 5 with additional factors of frequent exacerbation, increase in the board score of more than 1 over the last 2 years of time, and the pulmonary artery to the aortic diameter being more than 1 on CT scan, which means that the pulmonary artery pressures are increasing, and the FEV1 is just about 20 to 25% of predicted. This is the board score. Now, there is also a clinical deterioration in spite of being on maximum therapy. A lot of these patients are on LTOT, long-term oxygen therapy at home, non-invasive support. Poor quality of life, which is unacceptable to the patient, can also be one of the times when the patient would be ideal for being referred to a lung transplant center. Some centers, some teaching institutes are running clinical studies based on the LVR, and that's how the bronchoscopic lung volume reduction can be done in some centers, when these patients are also candidates for appropriate referral down. So this is the timing for referral. Now, when should be the timing of listing these patients for a possible transplant? A score which jumps from 7 to 10. Additional factors which may prompt listing could be FEV1, which drops to less than 20%, moderate to severe pulmonary hypertension, severe exacerbations repeatedly necessitating hospitalization, and chronic hypercapnia not amenable to non-invasive therapy at a home setting. Coming down to interstitial lung disease, which has been the largest segment of patients who have got transplanted in our country. This, important to note that the referral should ideally be at the time of diagnosis, particularly when we are dealing with UIP or IPF, which is a progressive disorder, which has a lifetime of about 3 to 5 years. So even if the patient has been initiated on therapy, based on a radiographic or a histopathological UIP, we rarely do histopathology nowadays. It's predominantly CT-based diagnosis of a probable or a definitive UIP pattern, which is idiopathic pulmonary fibrosis. The referral should be ideally made then for the patient and the family to get into the discussion. Any form of pulmonary fibrosis with an FVC of less than 80% predicted, or a diffusion study suggesting less than 40%, should again be sent for a referral. Any form of pulmonary fibrosis with one of the following in the past 2 years: a relative decline in FVC of 10%, decline of DLC by 15%, relative decline in FVC by 5% in combination with worsening of the symptoms. In terms of timing of referral, supplemental oxygen requiring either at rest or on exertion. For patients with connective tissue disease or familial pulmonary fibrosis, early referral is recommended, as the extrapulmonary manifestation may require some special consideration, especially the medications that these patients may be on. Inflammatory ILDs are all the other ILDs which are not part of the connective tissue disorders or the IPF. So anything like those diseases would probably also be recommended once they have documented progression of the disease. Now comes the timing of listing. One is the referral, when they should start talking to the transplant center. When should the transplant center start listing them as a possible candidate for transplant? Any form of pulmonary fibrosis, this is mind you in terms of interstitial lung disease, with one of the following in the past 6 months, despite being on appropriate treatment: an absolute decline in FVC more than 10%, an absolute decline in DLCO by more than, this is diffusion, more than 10%, a decline in FVC of more than 5% with radiographic progression, and a desaturation of less than 88%, which is the norms of a 6-minute walk test that we do often in our day-to-day clinics, or a more than 50 meters of decline in the 6-minute walk compared to in the last 6 months of time. Pulmonary hypertension, very few centers are doing right heart catheterization. Most of them are doing it on 2-dimensional echocardiography. This is the time that we would also probably look at listing these patients. And hospitalization leading to respiratory decline, pneumothorax, or acute exacerbation could also be the time for listing these patients. Cystic fibrosis is, as I said, is not a population that we see in our country very often. But yes, there is a timing for the referring these patients also. I don't know whether this drug, this combination is available or not. This is the cystic fibrosis transmembrane regulator. If, in spite of being on the regulator, if there's a FEV1 of less than 30%, if there's a FEV1 of less than 40% compared to the adults with the presence of a 6-minute walk distance of less than 400, a rising PCO2, hypoxemia at rest or on exertion, pulmonary arterial hypertension, worsening nutrition status, or repeated exacerbation of 2 or more per year requiring IV antibiotics, or massive hemoptysis, which has been defined as 240 ml or more, requiring bronchial artery embolization, or the existence of a pneumothorax. This is the time that one would talk about the referring these patients to of cystic fibrosis for transplant. An FEV1 of less than 50% predicted and a rapidly declining based on the PFT or progressive symptoms, or any exacerbation requiring positive pressure ventilation. Now, the next comes the time of listing for cystic fibrosis. Now, this is where the FEV1 becomes less than 25%. There's a rapid decline in lung function or progressive symptoms of more than 30% relative decline, frequent hospitalization of more than 28 days hospital in the preceding year, exacerbation requiring mechanical ventilation, chronic respiratory failure with hypoxemia or hypercapnia, particularly those with increasing oxygen requirements, pulmonary hypertension of more than 50 millimeters of mercury, and a worsening nutrition status or recurrent massive hemoptysis requiring bronchial artery embolization becomes the automatic timing for listing these patients. Now, non-cystic fibrosis bronchiectasis, this is the population that is probably been used for transplantation in our country in the different centers that I just said right in the beginning. Now, for individuals with non-cystic bronchiectasis, the criteria remains more or less the same, but yes, there is some quite a few variable factors which could probably be used in terms of the indications for the transplanting. A majority of our bronchiectasis patients are medical management. Rarely do we ever refer them down for lung transplant. So this is a very select population, and there has to be adequate justification before placing these patients for transplant. Pulmonary arterial hypertension, this is again typically seen in the Western world more often than in the, though we have in our recent times, we have started diagnosing them, particularly the individual patients who come from high altitudes. So there is an intermediate or a high risk reveals risk score despite being on appropriate pulmonary arterial hypertension therapy, and scores above a certain level would predispose them for an appropriate referral to the transplant centers. Significant RV dysfunction or the need for IV or subcutaneous prostacyclin therapy, progressive disease despite appropriate therapy with recent hospitalization, known or suspected high-risk variants such as scleroderma, large progressive pulmonary arteries, aneurysms, signs of secondary liver or kidney dysfunction due to pulmonary arterial hypertension, or life-threatening complications such as recurrent hemoptysis. Time of listing, again, the REVEAL score being more than 10 on an appropriate pH therapy, including the, I don't know whether these are being used in the Indian context. They need to be imported if they are at all being used, IV or a subcutaneous prostacyclin. Progressive hypoxemia, progressive but not end stage liver or kidney dysfunction due to pulmonary arterial hypertension. As I said, this is the only indication where, in spite of the fact that the other organs are showing signs of dysfunction, the correction of the, after the transplant, the correction of the pulmonary hypertension actually reverses the renal and the liver dysfunctions. Lymphangioliomyomatosis is a rare condition which is rarely seen. I remember seeing only diagnosing 2 cases till now in my lifetime, and these are the patients who would have cystic lung disease on the CT scans with repeated admissions, exacerbations coming into the hospital. A lot of these patients would have multiple pneumothoraxes, and that's how you would actually narrow down to doing a lung biopsy and diagnosing this disease. So this disease, there is an appropriate time for referral. Patient with severe abnormal functions, FEV1 of less than 30%, exertional dyspnea, hypoxemia at rest requiring oxygen therapy, pulmonary hypertension, and refractory pneumothorax, as I just talked about. The timing of listing for such patients should occur for an individual with LAM who meets the above criteria and has shown evidence of disease progression in spite of being on this mTOR inhibitor therapy is not available in our country, but wherever it is available in the world, in spite of being on that, if the patient still continues to have the symptoms, is thought of being transplanted. Now, this is a controversial topic in terms of indication rather for lung transplant. This for thoracic malignancy, lung transplant should only be limited to very select cases of lung limited adenocarcinoma in situ with minimal invasive adenoCA or lipidemic in predominant adenocarcinoma for patients in whom the surgical resection is not either feasible or either because of multifocal disease or significant underlying pulmonary conditions in the background. Multifocal disease which has resulted in significant lung restriction and respiratory compromise and medical oncology therapies have not been successful. Here the lung transplant is considered to be curative, mind you, but it requires a lot of investigation to figure out that there is no metastatic involvement, and that's how one would probably look at. But this is a very, very rare indication. As I did talk about bridge to transplant, ARDS is being used as ARDS patients who are not looking at an appropriate survival with good quality of life. And these are the patients where one could probably look at, and it has happened in the last 2.5, 3 years of time. A lot of these patients who have been on mechanical ventilator or an extracorporeal life support without expectation of an appropriate clinical recovery and with the evidence of irreversible lung damage, destruction with significant fibrotic and fibrobronchiectatic changes would probably be considered for such a lung transplant. Now, there are some surgical consideration as in terms of a patient who's undergone previously a history of chest surgery. Now, no surgeon would want to operate on such a patient again, all over again, and particularly lung transplant. But the results have shown that there is no significant survival difference in a patient who has had a surgical chest history in the background. In terms of pneumothorax or pleurosis, a lot of our patients, for example, COPD patients who are waiting for a lung transplant develops pneumothorax. The expectation is that you give the best form of therapy to these patients. Even if it requires pleurosis, one would go ahead. Normally, one would try and avoid, but the best of care of therapy at that point of time should be given to the patient. That's the norm. In terms of coming down to the types of lung transplant, you have heart lung transplant, you have a single lung transplant, you can have a bilateral lung transplant, you can have a lobar lung transplant. And amongst the heart lung transplant, it's primarily because of an Eisenmenger syndrome or a chronic end-stage lung disease with severely depressed LV dysfunction. This is the indication why a patient would be subject to a heart and lung transplant. Now, single lung transplant was the norm at one point of time, but of late it is the bilateral lung transplant which have taken over, primarily because of a better long-term survival. Single lung transplants do have a short-term survival, but a long-term survival is better with bilateral lung transplants. In a country like TB, with India, with tuberculosis being so prevalent, we cannot escape this discussion. TB in transplant patients increases to the risk of 20 to 75 times, particularly in patients with solid organ recipients. And the mortality can go up to 30% in solid organ transplants and about 50% in hematopoietic stem cell transplants. So there is this concept of preventive chemotherapy or a chemoprophylaxis, and this is where latent tuberculosis becomes treatable. Preventive chemotherapy is therapy given to patients with latent tuberculosis with a positive immune response. Chemoprophylaxis is therapy to prevent TB in high-risk individuals who do not have a positive immune response. Now, what is a positive immune response? A positive immune response is something like a Montu test. That is the in vivo tuberculin skin test, which is the delayed type hypersensitivity reaction, and the IGRAs, the ex vivo, which basically the interferon gamma assays which are done, which lead to the stimulation of the T cells artificially in the in vitro. So here, how does that help us? We need to give these patients an isoniazid prophylaxis for 6 months. Anybody who tests positive on whether it's a Montu test or whether it is one of the IGRA tests. If the recipient who has tested positive on the immune response gets an organ, the therapy is continued post-transplant for a total of 6 months. So this is the norms that are kind of followed. Why is TB such a problem? Because of T cell depletion, because of the therapies, particularly in renal transplant or in renal patients, where a lot of these patients do have concomitant, while the time they're on dialysis, they do develop tuberculosis. This is the skin test, the Montu test, and this is the IGRA facilities that are used. So what are the scenarios that can happen? One is this is when the window for the pre-transplantation window for screening, and the post-transplant period. This is the recipient, this is the donor. In the initial phase, everything happens free. There is no TB anywhere. But in a patient who has probably latent tuberculosis, once the transplant happens, patient goes on to immunosuppression. There is probably a possibility of an endogenous reactivation. Or the third possibility is where the patient does not have any latent tuberculosis, but the organ from which the patient has received probably would have some amount of latent tuberculosis. Once the organ gets transplanted, after the immunosuppression starts off, the patient may go on to develop reactivation. The next scenario is a patient who kind of gets exposed after the transplant to a positive patient somewhere in the environment and then develops de novo infection. So these patients would all require treatment. Or this is rare, an active TB patient who requires a transplant, extremely rare. The problem is when you treat these TB patients, the interactions with the ATT, particularly with rifampicin, and one will probably look to avoid rifampicin and pyrazinamide in these treatment regimens. Now coming into the risk factors, there are some absolute contraindications where probably it is best to avoid transplantation in such a scenario. These patients are considered too high risk with a significant high risk of adverse outcomes, and ideally these patients should not be transplanted. What are the absolute contraindications? A patient who has a complete lack of willingness or acceptance for a transplant, existence of a malignancy, renal dysfunction with a GFR of less than 40 mL per minute, ACS or an acute coronary syndrome or a myocardial infarction within the last 30 days, stroke within the last 30 days, patient with cirrhosis with portal hypertension or synthetic dysfunction unless being considered for liver and lung transplant together. There have been incidences where they have had multiple organ transplants happening. Patient with acute liver failure, acute renal failure with rising creatinine or on dialysis and low likelihood of recovery. Again, unless you're looking at a multi-organ transplant. Patient with active infections, septic shock obviously contraindicated, progressive cognitive impairment, repeated episodes of non-adherence, or the use of active substances or dependence, including current tobacco use or other drugs, or any other severe uncontrolled medical condition which are expected to limit the survival of the transplant. These are ideally situations one should avoid for transplanting such a patient. Now, there are risk factors one can be considered where the patients can be considered for transplant. There is no strong data supporting, but yes, one could probably optimize these conditions and probably with an increased risk of adverse outcomes. This has to be discussed with the family and the patient before the transplant happens. What are those conditions? Age more than 70 years, a patient who with severe coronary artery disease that requires CABG during grafting at the time of transplant, or a patient with reduced ejection fraction of less than 40%, significant cerebrovascular disease, untreatable hematological disorders, morbidly obese or a moribund patient, BMI of more than 35 or less than 16, active tubercular infections or any other active infections, hepatitis B or C infection with detectable viral load and liver fibrosis would be a high risk. Any patient with psychiatric or psychological or cognitive condition with potential to interfere with medical adherence without sufficient support system should also be carefully chosen. And in a patient who has unreliable support system or caregiving plan, lack of understanding of the disease, severe esophageal or chest wall deformity, patient on extracorporeal life support. Mind you, this is one of the situations where one could probably bridge, but again, not all patients. Transplant less than 1 year following initial lung transplant, and limited functional status with potential for post-transplant rehabilitation. Now, the third group is a patient where there are unfavorable implications which could increase the risk for adverse post-lung transplant issues, but can still be transplanted, and the same discussion should need to be done and documented. What are those risk factors? 65 to 70 years of age, renal disease with a GFR of about 40 to 60, mild to moderate coronary artery disease, severe coronary artery disease that can be revasculated using the PTCS or the percutaneous coronary interventions, reduced EF about 40 to 50%, peripheral vascular disease, connective tissue disorders, blood discrepancy like thrombocytopenia, leukopenia, anemia, with a high likelihood of persistence after the transplant. Patient with gastroesophageal reflux disease, osteoporosis, a BMI of in between 30 to 35, BMI of 16 to 17, which means that they are in the obese or under nutritional status. Any patient who's frail, hypoalbumic patients, diabetes which is poorly controlled, mind you, these patients would be on immunosuppression with steroids, and the sugars might only get worse with time. Patient with addictions to different kinds of drugs, and of course active infections. Patients on mechanical ventilation with prior pleurosis or previous thoracic surgeries. Mind you, these are not contraindications, but high risk of adverse outcomes. When it comes to any surgical intervention, or for that matter any transplant, there are complications that we need to be aware of. Now, this is the timeline that one could probably look at: early post-op from day 0 to about 2 years of time, early post-op period where you look at the early onset complications, and after discharge or the late onset complications. So after 1.5 or 2 months, it becomes post-discharge or late complications. In the initial, it is primarily the reimplantation response or the acute rejections. Bacterial and fungal infections are two infections which can occur throughout the course of the patient's disease. Viral infections typically happen after the first month is done. Post-transplant lymphoproliferative disorder again happens after the first month or probably after discharge. Bronchiolitis obliterans is a late kind of beyond 6 months of time. That's when this kind of setting comes in, and this is a form of ultimately the demise of the patient with chronic rejection. Restrictive allograft syndrome or recurrent disease. So this is the timeline that probably we need to be careful about, and this is what needs to be followed, and probably the reason why lung transplant doesn't have such a beautiful outcome as other organ lung transplants. So complications can be divided into non-infectious or infectious. Non-infectious, these are the table that one could jot down from the books. Infectious complications, there are numerous, as we talked about. Bacterial and fungal infections can happen from day 0. It's the viral infections which will happen typically after the first month, not early on. Airway complications are also known, but they're getting reduced in nature as time goes by and as the experience becomes stronger. There are 6 categories of airway complications post lung transplant. Bronchial stenosis at the point where the adhesions are done. The anastomosis happens. Bronchial dehiscence can happen. Exophatic excessive granulation tissue formation can happen. Tracheobronchomalacia can complicate these patients and resulting in significant respiratory distress. Bronchial fistulas can happen, and so can endobronchial infections. This is just to take you through some published literature on how it presents. This is a patient who's undergone bilateral lung transplant. Day 1, mild bilateral airspace consolidations. In the day 2, in the worsening bilateral airspace, and as day 8, it kind of starts clearing off. This is typically what is seen in most of the patients, about 80-85% of the patient. This is typically called the reimplantation response, also known as the reperfusion pulmonary edema, or more popularly as PGD, or primary graft dysfunction. So this is not, I think this is a reversible phenomenon, and this is commonly observed in most of the patient. Again, a patient with bilateral lung transplant, on day 15, bilateral atelectasis in the basal zones, progresses to day 30, significantly involving both the lung funds. This is consistent with acute rejection. And this is where, so late in the hospital stay, one should not have such a picture. This is again 2 years post bilateral lung transplant. Again, a patient, normally we would look at consolidations bilaterally, one would think in terms of infective complications. And this has to be proved with appropriate transbronchial lung biopsies, and this is where these patients will need to go repeated bronchoscopic interventions. And this was a case of antibody-mediated rejection. When the surgery happens, it happens with a clamshell kind of a surgical procedure, and so the both the sides of both the chest cavities are act as one, and that's where such a bilateral pneumomediastinum and a pneumothorax can be just dealt with just one catheter, one chest drain, because it acts like one space. Complications, talking about complications, you can also have empyema or pleural collections which get infected with time, and there are some airway complications, typically bronchial stenosis or the dehiscence. There were some images, I thought it would get a bit too mundane and probably long. My take-home message is the fact that it is lung transplant, just like any other organ transplant, would have its own expenses. This is probably one of the most expensive treatment modalities. It is unfortunately one of the only last resort treatments for certain end-stage diseases, particularly our interstitial lung diseases and particularly our emphysematous COPD patients. Lung transplants have changed a lot of these patients' quality of life. It requires appropriate and careful selection of the recipient. Yes, there is a lot of work that needs still to be done in the expansion of the donor pool, particularly in the northern part of the country. Down south, there's a beautiful partnership in the public-privately, as I just right in the beginning mentioned, with a lot of government machinery support. A lot of work has been done, and thanks to NGOs like Mohan Foundation, who've done an enormous amount of work. We today, organ transplant is looking forward. We do have a lack of universal government policies, though they are improving with time, but there's still a lot of support and hand-holding that is required. Infections continue to be a major problem in some of our centers, and better infection control practices probably would need to be evolved. Something that we as chest physicians, as pulmonologists need to learn is to refer the patients appropriately at an appropriate time to an appropriate lung center for transplant for consideration, and then subsequently build on them. And yes, teamwork stays essential at the end. We all need a dedicated team of CDVS surgeons, anesthesiologists, transplant coordinators, nursing people at the ground, counselors, chest physicians. You just name it, and it's probably endless. Thank you, Dr. Ranjan, and thank you to Mohan Foundation for this wonderful opportunity. I hope I've added substance. Thank you so much.
Thank you so much, sir. That was really very scientific and very methodical and a systemic integrated approach. And I'm sure it's a very, very difficult topic. And as you could see, that lung transplant is one of the most critical transplants even in today's date. Not many centers are doing it, and not very successful results are being produced. Because of the recent COVID pandemic, you might have seen there were so many referrals for a lung transplant. So all of a sudden, there was a surge for this organ. So with that, if there are any questions you would like to ask, sir.
Thank you, sir, for a brief presentation. Sir, in one slide it shows post-lung transplant complication, bronchial dehiscence. So normal surgical wound dehiscence means opening of sutures and wound edges are separated. The bronchial dehiscence is same or different?
It's the same. It happens typically at the area where the anastomosis happens, and it is typically the main bronchi, close to the main bronchi, yes, where the anastomotic.
So the patient further
they develop either subcutaneous emphysemas or pneumomediastinums.
So the re-anastomosis done in OT or not?
Sorry?
Re-anastomosis done, sir?
These patients have a tumultuous course. My experience will be very low on this. I would not know, but yes, a lot of these patients are taken up for resurgery, or probably not resurgery. Stenting is the way methodology where most of these patients, because taking them again for a surgery would be very, very difficult.
Yes.
But most of these patients end up with undergoing airway stenting to bypass that time for the healing to happen.
Okay. Thank you, sir.
So any other questions? Rajinder, what has been your experience with the shifting of lungs, and what is the PGI experience about lung transplant?
Yeah, so we have shared 3 lungs, 2 with MGM Chennai and 1 with Fortis. Okay. So, and in one case, the team from MGM Chennai, they came, but the patient was already on like 4 days or 5 days on ventilator. So the moment they came, they did the bronchoscopy and the lungs were no more healthy. So it's the time when they just go back and they didn't even retrieve. We were not able to retrieve the lung.
I think what the point which sir made in one of the slides is that the patient should not be ventilated for more than 72 hours.
Yes.
3 days, yes.
3 days.
Patient will definitely have ventilator-associated pneumonia,
Yeah.
and that will definitely.
So it's a very tender
quality.
organ. And
Yeah.
thank you so much, sir. Are there any other questions?
Good afternoon, sir. Thank you so much for a very informative lecture. So I just want to ask, when we retrieve the lungs, what we do to prevent its collapsing of alveoli?
This is one topic I haven't touched upon. I would not want to give you a wrong answer, so I would not be able to answer that.
I think that's a purely surgical question, and this should be directed to lung surgeons.
So this is out of curiosity.
No, that's a very right question. That's a very right question. I also don't know the answer.
Thank you, sir. Sorry, sir.
So how did you, maybe Rajinder can give that answer. When you transported that organ, how was it transported, lung? Was there some mechanism by which the alveoli were made inflated, or simply you just put it in the...
We put it in the preservative solution, but it was in PGI only. The patient was in cardiothoracic OT, and they put it in on the ECMO the moment they take the organ. After perfusing the fluid, they put it on the ECMO before transplanting.
Okay, so that is the answer. So the organ is taken out and put on an ECMO machine, and then in the meantime it is transplanted. Anything else? So I would request Mr. Sudhir Diwan sir to kindly felicitate Dr. Mandal for his wonderful talk. And indeed it was a very, very difficult topic, very new topic for all of us as a whole. And it's a new organ which is born to be transplanted, and I'm sure in days to come we can refine our existing protocols, parameters, so that this organ can be beautifully transplanted. Thank you so much, sir, once again for sparing time. Thank you, sir. सर का बैग दे दिया, बैग सर का किट. Thank you so much, sir, for sparing time for all of us. With that, we go on to the next session. And for the next session, I invite Rajinder, who you know is a very, very dynamic transplant coordinator. You have heard her yesterday. And today she will be talking about the logistic of heart-lung donation. So this organ transport is one part of transplant coordinator's job where he or she is in the limelight. There's a lot of camera, a lot of shooting going on. It's a very, very film city based. It's really the most what I must say, fascinating, the most sought after segment of the entire movie of the transplant coordinators.
Sir has witnessed that too.
Yeah,
once.
I have witnessed that. So long back, we carried some organs from PGI. So it's really a wonderful feeling. You are exhausted, waking up the whole night,
Yeah.
but the next day you are really on the show. So with that, I would like Rajinder to start off.
Good to see your photo sometimes on the newspaper with the organ box.
Thank you.
Low battery. So, before going to start my session, I would like to brush up your knowledge. So what are the forms which are used in this declaration form? Form number? Declaration form. Brain death declaration, 10. And consent form? 8. Then in MLC cases, what else we need? Forensic NOC and police NOC. Okay, so these are the forms which are even required before you transport the organ to the other retrieving hospital. Okay, so you have to provide all the you have to keep the set of these forms ready, and you have to provide to the retrieving team. So anybody heard about green corridor? So what it is? Yeah, speak up.
To transport a harvested organ in quickly, like without any traffic, without any delay.
Yeah. So what is the goal of the green corridor? Why you need this rush? You are just racing against time.
To save the
Just to
time
save the
and
time to minimize the cold ischemia time.
yes.
Okay. So with that, I'll start my presentation. Hello. So I'll be covering the logistics and transporting organs to other state, green corridor, and coordinating with the airport authorities. Just to brush up the previous lecture, what are the indications of heart and lung transplant? First is sir has already covered complex congenital heart disease with Eisenmenger syndrome, both end-stage lung disease, refractory left ventricular failure, fibrosis or infarction of the right ventricle with right ventricular failure. And what is the ideal donor for lung donation? Age less than 55 years, probably a brain dead donor, ABO compatibility, PaFO2 and FiO2 ratio more than 300, cigarette smoking history less than 20 packs per year, and absence of any chest trauma. And no sign of aspiration in CT scan, no evidence of sepsis, no prior cardiopulmonary surgery, sputum gram stain absent for organism, and absence of purulent secretions on bronchoscopy. And no obvious anatomical abnormality, and ischemic time less than 6 hours. So what we do in PGI, once we have a donor, we do the basic investigation. And in case lungs are considered, we do the chest X-ray, ABG. And if chest X-ray is normal and PaFOA2 values are normal, then we do the bronchoscopy. And in case some centers also require CT chest. And in case of heart donation, we risk if the donor is having any high risk heart condition, then the donor demographic data, cause of death, ECG finding, they should be normal, an echogram normal, and there can be history of substance abuse. It doesn't affect the outcome of the organ. And the traditional cardiac donors selection, age less than 55 years, no history of chest trauma, no prolonged hypertension, hypoxemia, and central venous pressure 8 to 12 mg, inotropic support less than 10 mg per kg per minute, normal echo, normal cardio, and normal angiography. So these are the investigations which we do before taking a donor for heart donation. So after doing the donor assessment, now we know that all the tests are normal. So what is the next step? Once the donor assessment is complete, donor is considered healthy for heart and lung donation. So we have this performa in PGI. So we get it filled by the respective assessment teams. Like if lung donation is considered, the pulmonary people will come and fill the condition status of the lung, and they sign this performa. If heart donation is concerned, that the cardiologist will come and assess the condition of the heart. So in cold ischemia time, we usually take 4 to 6 hours for heart and lungs. So in cases when we have no recipient at our hospital, we can put the organ for sharing. So these are the points. If in-waiting recipient is not fit due to some active infection, and non-availability of recipient in the donor institute, and recipient refused to come to the hospital, and funds not available. So organ sharing, everybody knows the Roto, Soto, Noto model. Okay, so Soto stands for? And Tissue Transplant Organization. And then comes the Roto, Regional Organ and Tissue Transplant Organization. And each Roto caters around 7 Sotos. Okay, then it goes to the Noto. So PGIMER was designated as Roto Center for North region in 2015. Since then, sharing is done as per the National Organ Sharing Policy. So these are the logistics that first if we notify the organ to the Roto, Roto will notify it to the Sotos. If there is no recipient at Soto, then we'll put it in the general donor pool through Noto, and it will go to the person of Indian origin, else it will go to the foreigner. And we have these allocation groups. One is for Roto and another is for Noto. So in that, we'll share all the donor details. So we put, there is a tentative alert for liver, heart, or lungs. There's a brain dead donor at PGI Chandigarh. What is the name, age, blood group, and whether it is a MLC case, non-MLC case, what was the date of incidence, and time on ventilator. As sir has said that for ideal lung donor, it should not be more than 72 hours. So we mentioned that. Then we mentioned the first apnea was done on at what date and time, second apnea, and what consent given by which person of the family, height and weight of the donor, and inotropes, and the contact person of the transplant coordinators, and ICU contact numbers. Then we put it on if there is no recipient available with Sotos, then the allocation will go to the Noto. So even before, we have put the donor on Noto, once the allocation is done, it is mandatory to have a Noto ID. Okay, so we have to register the donor with the Noto and to get the Noto ID. You cannot share the organ without getting a Noto ID. And you have to provide all the medical records of the donor to the recipient hospital. Also share the transplant coordinator numbers. Also provide the contact numbers of the pulmonary and cardiac resident who has done the assessment of the organ fitness. It is better that the recipient hospital resident should talk to them directly. And recently we did an organ sharing with Soto, 60 years old male on 23rd, met with RSA, declared brain dead in PGI, Donor hospital team considered it as a marginal donor, so liver was put for sharing, and information was sent to Roto, and alert was sent to all Sotos. And Soto Rajasthan had recipient and allocation done to STM Hospital Jaipur. So we shared one liver with STM Hospital Jaipur on 23rd of August. So next very important step is that you have to arrange for the logistics. Once you have a donor but no recipient available in the donor hospital, so you have to fix the retrieval time as per the availability of the flights. Okay, so once the organ is put for sharing, whoever institute is interested, they will contact you. And you have to check for the flights availability. According to availability of the flights, you have to fix the retrieval timings. And cross-clamp time is also planned accordingly as per their flight timings. And you have to arrange for transport to pick the retrieval team from the airport. And in case retrieval is early morning, you can also arrange for their breakfast. And most of the time what happens, the retrieval team, they will say our surgeons to do a retrieval for them. They will just come and pick the organs. So in that case, like the solution, custodial solution or HTK, STK solution, they are very costly. Okay, so you have to get the replacement. Okay, so tell the retrieval team that you have to provide the replacement. And in case heart retrieval is planned, sometime the cardiac surgeon, they will say that they need a scrub nurse from CTVS OT only during surgery. So you have to arrange for the scrub nurse from the cardiac OT. And so you have to ask them to provide you the copy of boarding passes in order to get the airport permissions, and arrange for ambulance from hospital to airport, and inform the Central Industrial Security Force at airport that this organ is to be transported at this time. And also the airlines, for example, if the organ is going through Indigo, so you have to inform the floor manager of Indigo airline that such and such organ is transported at this time. And you have to keep a close contact with the airline authorities, because sometimes flights, they came early or sometimes the flights get delayed. So in that case, you have to manage the cross-clamping timing accordingly. And provide the airport copies of airport permission to commandant CISF and airline through email or WhatsApp, and provide the hard copies. 4 copies you have to provide of the airport permissions to the retrieval team. Sorry? Okay. No, I'm pantry mein rakh dein. Sometimes they provide a seat. Yeah. It can be kept. So next step is the labeling of the organ box. So it has to be marked clearly that human organ is there in that box, and no X-rays. There should not be any security check for this organ. And this is the airport permission. I'm sorry, it's not clear. So in that, we mentioned that we are transporting a cadaver organ, whether it is heart, liver, through this flight on this date at this time. And it is requested, and the dimensions of the box is also mentioned. That box is of this size, and this organ is non-corrosive, non-radioactive, and it doesn't pose any danger to the passengers on board. Okay, so you have to mention all these details, and the name of the person who will be accompanying the box you have to mention in this airport permission. And if if the organ is going to Delhi, so you have to take permission from CSF Chandigarh and CSF Delhi. Okay, so you have to inform both the airports. So organ transportation can be done through land. Okay, so liver, like the cold ischemia time is more for liver, so sometimes they take the liver through land, through ambulance. So can be transferred through flight. It can be chartered flight or the passenger flight. And for chartered flight, you need not to take the airport permissions. And for this passenger flight, you need to take the airport permissions. And organs can be transported through metro. And you have to ask the airport authorities where you need to receive where they are going to receive the organ. Okay, in case of passenger flight, they usually receive the organ at the departure gates. And if in case it is going by chartered flight, they will allow you to enter through VVIP gate. So next is the green corridor. It is a special route in which all the signals are green and controlled manually. First device to handle medical emergency. Now it is used for the transport of organs. And it makes sure that there is no organ wastage and requires a very strong coordination among all the traffic officials and the airport authorities. And in India, the first concept of green corridor has come into being in 2014. And first green corridor was conducted in Chennai in the same year. So it is the race against time. Chennai was the first city to incorporate this concept. An ambulance carried a heart to save a 21-year-old and covered a distance of 12 kilometers in just 14 minutes. And we conducted the mock drill in the same year. PGI conducted a mock drill on 7th August 2015. The ambulance started from GMCH Chandigarh, GMCH 32 to PGI MER. The distance of 8 kilometers was covered in 7 minutes, and usual time for covering this distance is 15 to 20 minutes. And then from PGI MER to airport, it usually takes it's a 20-kilometer distance and takes 12 minutes. And usual time for covering this distance is 45 to 50 minutes. So till date, we have coordinated around 57 green corridors since 2015. So coordination with the traffic police. What we do in PGI, we inform our central security officer that the organ will be transferred at this time. So he sent this request letter to headquarters police Chandigarh and headquarters police Punjab. So accordingly, time of organ out and flight timings are mentioned, and the ambulance or vehicle number and the contact number of the driver is also mentioned on that request letter. And name and contact number of the person accompanying the organ, and name and contact number of the transplant coordinators. Then traffic police coordinates with the transplant coordinators, because sometimes the organ out times get delayed, or sometimes it came early. So this is a request letter for Green Corridor, in which we request the Central Security Officer to coordinate with the police for constitution of Green Corridor. So these are the documents you have to keep ready. In case it's an MLC case, you have to keep forensic NOC, police NOC, retrieval form, blood group report to be handed over to the retrieval team. So this is the handing over certificate. Once we hand over the organ to the retrieving team, we take a handing over from them that this organ is handed over to this person. So these are the pictures, how the organs are transported through OT to the ambulance. So this is the green corridor we conducted a few days back. So the organ reached Delhi. This is the heart which went to RML. Okay, so till date we have shared 3 lungs, 1 lung transplanted at PGI. We have shared 21 hearts and 7 heart transplanted at PGI.
Thank you so much, Rajinder. That's a wonderful journey. And before anything else, I would like to welcome Professor Sunil Shroff, sir. He is amongst us, and sir has been, sir के लिए इतना बड़ा introduction है कि I can't put it in words. He has been a teacher of my teachers, a very senior urologist, president of our Indian Society of Organ Transplantation. He is the managing trustee of Mohan Foundation, और बहुत छोटे शब्दों में कहा जाए तो हम लोग के लिए भीष्म पितामह जैसी फिगर हैं सर. और साउथ इंडिया का entire cadaver transplant program, he is the one man who initiated the Mohan Foundation, and we know how diseased organ transplant program in South India is. And sir, we are very fortunate that you have spared time to be here personally. We have seen you in so many conferences only virtually, and we are really blessed to have you here in person. We welcome you, sir, on behalf of Fortis Hospital, Mohali. Thank you so much for sparing time. And after that, if there are any questions, all of you saw the practical aspects of the green corridor, and these are the actual people who have been involved in managing the logistics, transporting the organs in a very, very short amount of time. So I'm sure there should be questions which should be directed towards Rajinder. So you can please go ahead with your questions. Yes.
Ma'am, actually I want to ask, can we have any specialized facilities for the transportation of such organs? Like we have to go according to the plan of the airplanes, but we have to go with their timings. Like
Basically,
Drones.
not
Here-
drones, because see, passenger aircrafts are very, very, there are so many logistics involved in running an aircraft. So air traffic controllers is controlling the air traffic. You can't just have a organ coming and the entire air schedule is managed. There are special chartered flights. There are special air ambulances which are now coming up. So this facility is quite prevalent in the US. And now in India also, there are specialized air ambulances which are developed so that you can transport the organ from the retrieval center in the minimum amount of time, although it takes a lot of money for those services to be availed. But yes, at the government level, there are no such policies for organ transfers. As Rajinder told, they coordinate the timing of harvest of the organs with the timing of the arrival of the aircraft. So that is the only thing which can be done so that we minimize the ischemia time.
In certain cases, the airport people are wise enough, they have delayed the flight for us. Like there was 30 minutes and 45 minutes delay in flights also,
Okay.
just to support this organ donation.
Thank you.
So Rajendra, you said they don't go through X-rays and all, but the airport authorities don't insist on checking. Security का क्या है इसमें तो the going forward people
Yeah,
could misuse
we
it.
informed the CISF earlier. So they are the people who are taking these all security checks. So once we reach the airport, we just hand over the box to them. Okay. And but the person has to go through the security check. The box need not to go through the security check. And as per the SOP, which are for national organ sharing transport policy, as per NOTO, it is clearly mentioned that no security check for the organ. Even for toll plaza, they won't take any toll,
Just
and they
being
let
devil's
these
advocate,
organs.
tomorrow terrorists will start using. I'm just being a devil's advocate. Tomorrow terrorists will start using these organ shifting boxes for
That's
bombs
why
and
we
all.
take the hospital on letterhead. We are taking all these permissions from the MS.
And ma'am, what about the charges? Are they paid by the government or by the recipient?
No, not by the recipient. The hospital pay. In case of chartered flight, the recipients pay for the chartered flight.
Okay.
But else, if it is a passenger flight, the hospital pays for the charges of the flight
Okay,
ticket.
ma'am. Thank you, ma'am.
Very good, Rajinder. Well done. He is one of the champions in Chandigarh. A lot of experience on the shoulders.
You'll start off or
Whatever you say, we have actually ahead of time.
So okay. Yeah.
Role qualities. Okay. This session is about the qualities of a transplant coordinator. Qualities of a transplant coordinator. Let's hear from you. Huh? What skills? कौन से वोकेशन में communication skills नहीं होनी चाहिए? What's so unique about this communication skill that is so unique to transplant coordinator. What else? Empathetic. A teacher should not be empathetic. Doctor should not be empathetic. Okay. So what is this unique quality of a transplant coordinator? Huh? Dedication. कौन से profession में dedication नहीं होना चाहिए? So you're right. World over, there are certain desirable qualities and there are certain non-desirable qualities. And like any profession, if you have to do well, you have to have desirable qualities. So this, when the first time our then course director, Dr. Sumana, she's not with the foundation anymore, when she asked me to do this session, I said, hey, how do I do this session? You know, तो list down कर दूँगी, good communicator, empathetic, dedicated, ये तो, how does it help me? So what I'm going to do now in over the next half an hour or all, share with you some case stories, families that I had the privilege of working with. And in that particular case story, with that particular family interaction, what quality of mind I had to bring to the surface to be able to effectively work with that particular case. Sorry, where's that thing? Thank you, Dr. Amit. Thank you. So that's my very first experience with counseling, my very first family that I spoke to. Way back in 2011, Dr. Shroff said, Pallavi, I wanted to set up an office in Delhi. I had never done anything to do with organ donation before that. It was an absolutely new field. I was in the development sector, but organ donation पे कभी काम नहीं किया था. कुछ 10-12 साल पहले I was in Chennai for a couple of years and I worked with the Kidney Foundation. They were providing subsidized dialysis to poor patients. And that's where I'd met Dr. Shroff. And he said that we need to set up an office in Delhi. People keep thinking of us as a South organization, but we are a national organization and we need a presence in Delhi. So this was 2011. I had just taken over the work of the Mohan Foundation. And like you, I went to attend my first training in Chennai. And I think it was a 5-day training program. And on the 3rd day, I was called out. I was wondering, मुझे क्यों बुला रहे हैं? It had so happened that the biggest government hospital there, the Rajiv Gandhi General Hospital, the foundation has been working with that hospital for many years. वहाँ पे poor Bihari laborer, a young boy, 16-year-old boy, 17-year-old boy, who had come as a migrant laborer from Bihar, had fallen down from the construction site and had been brought to the hospital and declared brain death. Uska father had traveled all the way from Purnia, Bihar. I know of Purnia, Bihar because my father was posted there. My father was in the army. In fact, I stayed in Katihar for a couple of months. And our transplant coordinators in Chennai obviously are comfortable with either Tamil or English. Hindi is not a language. And Hindi bhi kya, Bihari, quite hate Hindi. So they said, come and speak to the family, you know. And obviously, you know, it wasn't, it was the first time. It was 26th of April. 1st of March is when I began work with the foundation, 26th of April. So it was not an easy case for me. It was my very first counseling for organ donation. People who had the experience could not communicate in the language that the father could understand. Extremely poor family. When I say extremely poor, I really mean extremely poor. He was an old man wearing a torn dhoti. You know, I remember that scene so clearly. He was in torn clothes. He was the only son out of 4 children. He had 3 other daughters. Isko bheja gaya tha to earn a livelihood for the family. Since morning, I've been telling you about having a room to yourself for counseling. It doesn't work like that in a government hospital. वहाँ पे कॉरिडोर में खड़ा कर दिया गया मुझे दुनिया भर के लोग कोई नीचे ज़मीन पे सो रहे हैं कोई जा रहे हैं they're shouting, screaming. And you must understand, for people who do not understand Tamil, it's a very different language. So for मेरे को इतनी jarring लग रही थी, उसको father को क्या लग रही होगी उनको? I spoke to the father. I explained to him क्या मैं बोल रही हूँ. उनका first response था, मेम साहब, he used the word मेम साहब मुझसे ये नहीं हो पाएगा. And by this time, I had of course started crying. मेरे तो आंसू रुक नहीं रहे थे और मुझसे control नहीं हो रहा था. And beyond a point, I stopped even trying. You know, I mean, at the end of the day, we are all human beings. You know, so over time, you learn to control your emotions. But at that point, I just simply couldn't. You know, I just requested him, I said, जो भी ये मैंने बात कही है, I just want you to go away from all this noise and cacophony. Just be on your own for 10-15 minutes. सोचिए जो मैंने कहा है, और उसके बाद आप आके जो भी जवाब देंगे वो सर आंखों पे. बट मैं चाहती हूँ ये डिसीजन आप थोड़ा सा अकेले होके मुझे फाइनल आंसर दीजिए, इवन दो ही हैड सेड मैं नहीं करना चाहूँगा. So what quality really comes into play in situations like this? Who would like to? Sorry? Okay, that's not a quality, that's a technique, that's a skill that you're giving space to the person. What is the personal quality? मैंने stable तो थी नहीं, मैं रो रही थी. Okay, I asked the father one question. I said, आपको इतना समझ में आ रहा है कि यहाँ कुछ गलत नहीं हो रहा है. You know what the father said to me? मेम साहब मुझे इतना समझ में आ रहा है कि आप कुछ गलत नहीं कर सकते. So sincerity, you cannot do well in this job if you're not sincere. Just be who you are. Just bring sincerity and honesty to this whole process. Because families know that, families understand that. And he actually said that, and he went away. He was away for half an hour. My coordinators gave him some tea and all. And he came back and he said, बताइए मैम साहब कहाँ साइन करना है? मेरे बच्चे के जो भी अंग दूसरों के काम आ जाए मैं चाहूँगा. He refused for eye donation. I tried to explain to him कि eye donation बहुत ही simple process है, but beyond a point, you don't push families. He wasn't prepared for eye donation, but he went ahead and donated every other organ. He was a young boy. We went ahead and took most of the organs. And this is this. Father didn't have the money to take the body back. The foundation organized the cremation. He went back home without the body because he was too poor to have organized the take back home. And of course, we only assisted in the final rites and appreciation certificate. There was another girl who was attending the training with me, Bhavna from Shatayu. She was also part of the counseling, again, a Hindi-speaking person. But that was my very first case, very first experience with the family. And that established my faith in the fact, if this father in this situation could say yes, then any family with the right skills, with the right intervention can be convinced to say. So it was in some way providence. क्या chances थे कि मैं उन्हीं 5 दिन चेन्नई में a Tamil speaking place and a Hindi speaking family should come and that I should be called out to counsel. I think somewhere larger forces were playing some role in that. Another very interesting case, Miss Marie Therese Hampert-Zoumian, 68 years old, citizen of France. That's Miss Marie Therese. She had come along with her husband to meet her son who was working in a multinational here in Gurgaon. And they did that golden triangle. They went to Jaipur, Agra. For me, I cannot ever think of Taj Mahal without thinking of Marie Therese Hampert-Zoumian. And this was a hospital at that time. We were working with Max Hospital. The foundation gets into MOUs with hospitals, short-term MOUs, 2 years, 3 years, to set systems in the hospital. And so these are all cases that have been, now we're not working with March anymore. So she had a subarachnoid hemorrhage. Opt-out की बात हुई थी यहाँ पे पिछले 3-4 दिनों में. What is opt-out system? So, when a country automatically assumes that every citizen is a donor by default, unless you put it in writing to say that I do not want to be part of the system, India is what? Opt-in. Nobody is considered a donor unless you opt into the process. So France has an opt-out system, and really we had to do nothing. So no counseling skills were required because his family had always spoken about organ donation, and this is what my mother would have wanted, and they went ahead and agreed to donation. Now, there were some other challenges here. Later on, I found out that there was one more foreign national at that time in Chennai, many years ago, pretty early on in the program. But when at that point of time, that evening, I didn't know of any other foreign national case. It was the first such case in Delhi NCR, and we couldn't come up with any documented evidence of any foreign national donating in India. The Act is silent. While there's enough to talk about foreign nationals in living transplants, when it comes to deceased donation, Act doesn't say anything. So we had nothing to go by. एंड जितने लोगों से बात करें उतने डिफरेंट ओपिनियंस मिले एंड मेनी पीपल सेड कहाँ चक्रों में फंस रहे हो यार, यू विल फॉल इनटू ट्रबल एंड ऑल, एंड हियर वाज हिज फैमिली, सच अ ब्यूटीफुल फैमिली, सो मोटिवेटेड टू डोनेट. कौन सी क्वालिटी निकल के आएगी ऐसे सिचुएशन में? क्या करोगे? क्या चाहिए to go forward with such a case? Courage. You have to be very, very brave if you have to be a good transplant coordinator. You have to be brave at various fronts. You're dealing with police, you're dealing with कभी कभी पूरी पंचायत आके खड़ी हो जाती है. You would know. Donor की family कहीं कोने में और पूरी पंचायत अपने लट्ठे लेके आ गई. You know, especially happens in Gurgaon hospitals, the whole Haryana, the women hardly come. You have to have certain degree of courage, and I talk about a moral courage. It comes from knowing that you're doing the right thing. You're doing what is correct, what is humanly right. I mean, I thought it was so unfair that here was this family, so motivated to donate. It just so happens that they are in your country at the time of death, and will you not as a country give them an opportunity to say yes, you know? So I spoke to Dr. Shroff. It was all in the middle of my night. I started speaking to other people, and we all decided as an organization that we will go forward. So we charted a course of action. We, of course, got the family's consent documented in Form 8. We informed the nearest police station. With the help of some family friends, we informed the embassy. I mean, obviously, the embassy was closed, but we got in touch with the officials and we informed. And at that time, there was no NATO. We informed the DGHS. Now, I want you to pay particular attention to the word informed. We were not taking permission. Nobody knew better than us. So we were going ahead. We are saying we are going ahead with this case. Here is a family who's consented. We are going through the procedures. We are going ahead with the donation. Another thing that you must learn as transplant coordinators is not to take things at face value. So the father, the husband of this woman, obviously they were aged people, had become tired. He wanted to go home, and it was decided that I will get the consent form signed after the second set of brain tests from the house itself. You know, we won't make them come back to the hospital. And they were living close to the hospital. I went to the house, and the father signed, the son signed. And just as I was leaving, at the door, the son said, "Thank you so much," whatever he said. And he's saying, in any case, if he had not agreed to organ donation, they wouldn't have given my mother's body back. They would have kept her on the ventilator. And I was like so surprised at that statement. And I said, here, his name was Henry. I said, please take this form back, keep it. We went back to the table, and we talked about for the next 1 hour. I said, why have you agreed to donate organs? We talked about the law. I said, yes, the law doesn't very clearly state that you can disconnect the ventilator. He's saying, no, nobody told us about Lama. So meanwhile, they must have spoken to their Indian friends, and somebody must have brought up Lama and all of this. So I said, you can still do Lama. I said, the hospital is doing correct by the law. You have to donate if you want to donate, not because even right now we can go back and, you know, get your mother's body off the ventilator, or whatever needs to be done, you can do Lama. And we spent 1 more hour, and my colleague was going on calling me, wondering what could take so long. Munit was there to sign. And anyway, both the father and the son said, I'm so happy we had this conversation. We are clear about it. This is what my mother always wanted. We want to go ahead with organ donation. And we did go ahead with organ donation. That's the husband. He could only speak French. He could not speak English. And this is what he wrote back in a mail. He sent a French mail back, which we got translated. I was very moved reading your words and the inference. It was sad that I could not communicate with you, but the expressions in your look and the sensitivity in your eyes always said it all. So sometimes you don't need words, as I shared with you earlier. Sometimes silence works. When our friends come over to the house, I show them the pictures of our travels to India and the exceptionally framed photo. We gave them a certificate by the foundation with both of you, and that was a special moment and will always be cherished. So that really became the first documented case. Subsequently, we moved on to write an article which was published in the Indian Journal of Transplantation, where we have laid down guidelines on how to coordinate a foreign case. And we've had one more case after that in Nepal. And now this case is cited as an example to take forward foreign national case, just because at that point, me and my colleague decided to be slightly brave and go ahead with it. Yeah? Thank you. I would like to tell you that one of the kidneys went to an army jawan in our RRN hospital. So that's the beauty of organ donation. It's beyond borders. That's Sushant Kaushal, young, tragic death, young boy, 20-year-old. I wanted to share this case because it's my first medico-legal case after starting the Delhi office. And uske pehle, there was such a hawa created around medico-legal cases. Mushkil hote hain, bade difficult to coordinate hote hain. So I was quite nervous when this case happened. He was an engineering student. 4 boys were carpooling and they were going to give their exam. He was a very bright boy, always topped in his class. Mother had already died. Father was amazing. When I spoke to him, he agreed to organ donation. And Sushant always liked to come first in everything, and sure enough, he was the first one to leave the world too, but I would like to go ahead and donate his organs, is what the father said. The accident was a bad accident. 2 boys died on the spot. One escaped with almost no injuries, and Sushant was brought to Sir Gangaram Hospital. At that time, we were working with Sansgarka. So the accident happened in Haryana, and he was brought back to. Okay. I want you to think about this particular quality. Belief. Belief in the goodness of people. Belief in the goodness of the system. Believe that people want to do well. Usse shuruaat karo. Don't start off with saying nahi karenge log. Nahi karenge, but aap shuruaat karo ye soch ke ki shayad log acha hi karenge. It had so happened that just, I think not even 2 months before this donation, I had been, this is, of course, now he's become a big friend of mine, this SHO. At that time, I would go to him and I said, I want to talk to your personnel. I want to talk to them about their role in organ donation. And every time saying, ma'am, time nahi hota, wo nikal jate hain, subah nikal jate hain, shaam nikal jate hain, yahi sab sunna padta tha mujhe. One day he's saying, acha ma'am, subah nikalte hain, wo 8 baje, aap 15 minutes se baat kar lijiye. As you can see, he's not even given me a place to sit. I'm literally talking to them while they're all standing. And this was barely, not even 2 months before this donation. And when the donation happened, it was so amazing, the kind of support this police station gave us, the kind of pride they took in being part of this whole system, this whole process. And like I said, sensitization was already done. I was still using the word NOC back then, but like I said, we are not getting an NOC from the police. We are only asking them to do their inquest. And every time I ask them, you want me to come with you to the other thana? He's saying, no, ma'am, this is our work, we'll do it. And I would say, do you want me to come with you to the forensic? No, ma'am, just this is our work. But what becomes important in medico-legal cases is to have your ducks in a row. All your documentation should be very, very pakka. It should be anyway pakka in any kind of a case, but more so in a medico-legal case. The police will be more helpful if you have your documents all properly put up. So you have to go with your first brain death certification, of course, with the promise that the other one will come in some time. You get a death summary along with the second brain death test. Family consent form should be there. Even if they don't ask for it, put a brain death committee certificate so that they can cross-check ki jisne sign kiya as part of the committee. The organ functionality status from what I talked about in the medical legal case. Certificate authorizing the hospital to undertake transplants. So everything is all properly documented. You hand over, you will more likely get more support from the police and the forensic if your documents are not in order compared to that. And we went ahead and had the donation. Young boy, so both the eyes, both the kidneys, liver, heart, and in his case, his small intestines were transplanted to another young boy in another hospital who had not eaten solid food in 3 years because he needed and that's what the father had to say, Mera beta saat zindagiyon mein ji raha hai. That was our first medico-legal case. Great support from police, great support from forensic. This is Praveen Dhankar ji, 51 years. This was when we were working with Medanta. Okay, fairly complex case because ये बहुत ही rural family से आए थे, rural Haryana. It was a huge family. At any given point of time, waiting room में 25-30 लोग बैठे होते थे. पता नहीं चलता था कौन relatives हैं, कौन है, कौन friends हैं, कौन गांव वाले हैं. Just to identify the key decision maker was such a challenge. Wife जिसकी consent चाहिए थी वो तो आती ही नहीं थी कभी hospital. And हमें बार बार ट्रीटिंग फिजिशियंस बोले जाए, मैम अपना एनर्जी मत वेस्ट करो, ये फैमिली हाँ नहीं बोलने वाली. बट वी गो विद वन सिंपल रूल, इट्स अ येस टिल यू गेट अ नो. डोंट अज्यूम अ नो. Counsel families, give them the opportunity. It is your responsibility to give them this opportunity. Ask them, नहीं होगा तो नहीं होगा, at least पूछा ना आपने उनसे. And what quality? Lage raho. Till you know the chapter is closed. You have to be very, very, very resilient as a transplant coordinator. I think Rajinder will agree with me. So many times you feel like giving up. भैया नहीं करना है, नहीं करें, अब बहुत थकावट हो रही है. But like I said, it's a yes till you get a no. It took me 26 hours for this family to finally agree to donation. There were issues of distrust. One chacha said, क्या बात कर रहे हैं आप, क्या करेंगे उन organs का, आप बेचेंगे, कहाँ जाएंगे ये organs, you know? क्यों नहीं बताएंगे किसको नहीं मिल रहा, हमारा हक क्या पता लगाने का, आप नहीं बता रहे, that means कुछ गलत हो रहा है, हमें पता लगाना है किसको मिलना है. Then somebody else came up, some other, I don't even know relative था कि कौन था, ठीक है करेंगे, हमें क्या मिलेगा इसमें. So bringing up money issues. Then suddenly one bua, emerged, who was a nurse, do the apnea in front of me. So we took permission from the hospital and did the second apnea in front of that bua. Wife है ही नहीं जिससे मुझे बात करनी है, मेरी पूरी एनर्जी दुनिया भर के लोगों चाचा मामा ताऊ से निकल रही है. Again somebody came at 2 o'clock. I actually showed the brain death film in the middle of the night on my phone, to explain. So we had to give a lot of time to this family, and I knew that I will not give up till I had spoken to the wife. And somehow with the son's help, I went to their house and I spoke to the wife, and he's saying, this is I think what she said. She's saying, आप पहले इंसान आए हो जो कुछ अच्छी बात कर रहे हैं, तो हर जगह मुझे अंधेरा ही दिख रहा था. आप पहले कुछ बात कर रहे हो जिससे मुझे कुछ आशा की किरण दिख रही है और मैं करना चाहूँगी. तो ऐसे बाकी लोग आपकी सुनेंगे. He's saying, मैं अपने बेटे का साथ लेके, so both the sons and they agreed to donation, and this is what she had to say when I went to meet her 5-6 days later. जो मेरे पास था वो नहीं रहा, कम से कम कहीं और किसी और में चमक रहे होंगे. Her whole thing was about light. Even when I spoke to her first, she said, in all this darkness is the only, and this is what she said even later. So you have to be very, very resilient. That's Reena Behel, very young death again, 45. Case of chronic depression, and it was an overdose of drug. Again, Medanta, the Medicity. So I was called into the hospital saying the family is agreeable to organ donation, known to some of the senior doctors in the hospital. And they have been brought from some other hospital just for the purpose of organ donation. So no need to convince the family, but since it's such a complex case, suicide and all, medico-legal formalities aap handle kariye. So when I'm sorry, there's a word misspelled there, mind. When I walked into the hospital, into the counseling center, I heard this family saying, नहीं, अब हम नहीं करना चाहेंगे organs donate, and we would like the body to be handed back to us, and हम काफ़ी हमारे को stress हो गया, अब हम और नहीं झेल पाएंगे, अब हमें body. So I was very surprised with this whole conversation, because I was told here was a very motivated family who had only shifted for donation, and काफ़ी परेशान सी लग रही थी family, medico-legal formalities को लेके भी. So then I asked, anyway, the doctor went away. He said, okay, आपको नहीं करना है तो फिर हम अपना कोई भी treatment नहीं करेंगे. आपको जब when the time comes, we'll hand over the body to you. Then I started talking to the family, and I said, so the deceased sister and brother-in-law, they were the main people. They said, नहीं हम कल से आए हुए हैं, 24 घंटे होने को आए हैं, कोई donation की बात नहीं हो रही, कोई हमें कुछ बताता नहीं है. And my mother is so traumatized, and she's gone back home, and she's saying, Reena already went through so much discomfort. Usko aur mat pareshani mein dalo. She's talking about her deceased daughter, but in that sense. So I went inside to the ICU and I asked the doctor's team, ki why is this delay when the family had come the previous night? We could have done the testing overnight, and why did we not proceed? He's saying, nahi, jab first test kiya tha, to there were some reflexes, so we obviously put it on hold. But that was not communicated to the family. And of course, then they again did the test, there were no reflexes, they repeated, they declared death, but nobody is telling anything to the family. Family is just waiting outside. I came out, I spoke to the family, and I said it was very nice of them to have caused this delay, because they want to be absolutely sure that the person is not showing any reflexes, that there is no life. And I said that's why, to be extra cautious, they waited. And in all that conversation, I got the sister and the son-in-law to again be enthused about organ donation. Anyway, they were a motivated family. And they said, okay, we'll talk to the mother. They went and spoke to the mother on the phone, and they came back. She's saying she's not agreeing. She's saying, no, I don't want to discuss this chapter anymore. Selflessness. Selflessness का मतलब कि आप अपने जो आपका objective है उससे हट के आप कुछ किसी के लिए करें. At that point, my discussion on organ donation, my expectation of this family for organ donation closed. It was a closed chapter for organ donation. बट चूंकि फैमिली इतनी परेशान लग रही थी, अगले दिन संडे था, पुलिस बड़े बर्ली पुलिस इंस्पेक्टर्स वर स्टैंडिंग आउटसाइड, दिस फैमिली वाज वेरी वेरी टेंस्ड. So I told them, I said, don't worry, I will be here. It was almost 9:30 in the night. I could have simply gone back home and slept. But I just didn't feel like. I know the forensic officer very well. I went and spoke to the police guys and I called up the forensic person. I said, kal Sunday. He's saying, don't worry, ma'am, aap 8 baje bhejiyega. My junior officer will do the autopsy. All this help and conversation was beyond organ donation. For me, this was not an organ donation family. And by about 10 o'clock, I took their leave. I said, these are the numbers. This is my number. I have spoken to the forensic person. Let me know if there's any problem. When I came out, the transplant coordinator from the liver team, she's saying, ma'am, I wish family ne haan bola tha, because one of the recipients was a 10-year-old girl who required a combined liver-kidney transplant. Normally, I'm not pushy when it comes to, when a family has said yes, I respect those families' wishes and I withdraw. But chunki ye family ne pehle haan bola tha, or because of some other factors, the decision had changed, and this child's picture in front of me, something told me I want to have this conversation again. And I went back in, and I asked the daughter, can I just speak to your mother once? Just take permission from her for me to speak to her once. So she went and spoke something on the phone, and the phone was given to me, and I started the conversation again. And I brought up this child. I said, ek bari soch lijiye, auntie. And she broke down on the phone. And she's saying, aapne mujhe sahi time pe galat kaam karne se bacha liya. Please, aap bacche jo karna hai, aap karo, and we will go ahead with the donation. And family agreed, and we convinced the mother. We went ahead with donation. And at the prayer meeting, when I went to hand over the certificate and all, and like she said, thank you for helping me see the larger picture. It was a very rich family, very elite family. And she said, thank you for the certificate. So just some of the, I wanted to show you this. I used to be a very avid trekker when I was young, and then life happened, and family happened, and children happened, and I gave it up. But the desire to climb mountains was always there. फिर मुझे लगा क्या करूँगी 45 के बाद इतने बुढ़ापे में आके. And I wanted to tell you that I did the Mount Kilimanjaro on my 50th year, which is 19,000 feet. So if you put your mind to it, if you put your heart to it, nothing is impossible is what I want to say. Thank you so much.
Thank you so much, Pallavi. Only one word, wow. Such an inspiring journey, and I could see walk through your life. Lovely description, lovely emotions, simply wow, there's no other word, and I think the audience should stand up and give a standing oration to her. Beautiful real life stories, I must say, so heart touching, so valiant efforts, lot of other qualities, thousands of other qualities other than what you've shown there. And I would request our Director of Pulmonary Medicine, Dr. Amit Mandal sir, to kindly felicitate Pallavi with the plaque of honor. It has been a privilege to host you here, and it was really wonderful listening to all your stories. So with that, we'll take a short break, tea break, and for 15 minutes, and then we assemble again here at say 10 past 4. Okay? Thank you so much.
पेशेंट की परिवार से अंगदान की बातचीत एक बहुत ही नाजुक विषय है और अगर इसकी प्लानिंग सही तरीके से नहीं हुई तो उचित परिणाम मिलना मुश्किल है। इस फिल्म का उद्देश्य यह दिखाना है कि पेशेंट के परिवार से सही तरीके से बातचीत कैसे होती है। इस बातचीत की प्रक्रिया को हम 3 अलग स्टेजेस में बांट सकते हैं। सबसे पहले परिवार से क्या चर्चा की जाएगी उसकी प्लानिंग करना। उसके बाद अंगदान पे किसी भी चर्चा से पहले यह बहुत ज़रूरी है कि पूरा समय देते हुए पेशेंट के परिवार को उनकी क्लिनिकल सिचुएशन के बारे में अच्छी तरह से समझाना। अंत में परिवार को किसी भी निर्णय पे पहुंचने से पहले उनको अंगदान की पूरी जानकारी दें। अब हम गलत और सही तरीकों के उदाहरण देखेंगे।
कमेंट मैडम, बेड नंबर 5 के पेशेंट की फैमिली आपसे बात करना चाहते हैं। वो कई घंटों से वेट कर रहे हैं। क्या मैंने बुला लूं?
हाँ, अभी थोड़ी देर में बात करती हूँ। अच्छा, बुलाओ।
ओके मैम।
इस तरह जल्दबाजी और बिना प्लानिंग की अप्रोच से परिवार को एक सोचे समझे निर्णय लेने का मौका नहीं मिलता। इस उदाहरण में डॉक्टर और नर्स के बीच में ऐसी कोई बातचीत नहीं दिखी कि वो परिवार के साथ क्या बात करेंगे। उनके पास ऐसा कोई मीनिंगफुल प्रस्ताव नहीं था जो वे परिवार के सामने रख सकते थे। ट्रांसप्लांट कोऑर्डिनेटर या सोशल वर्कर मौजूद नहीं था। क्लिनिकल या पारिवारिक स्थिति पर कोई चर्चा नहीं की गई और ना ही कोई अंगदान की बात हुई।
मैडम, वो पेशेंट की फैमिली से मिलना चाहते हैं। पेशेंट कंडीशन के बारे में कुछ जानना चाहते हैं। क्या मैं उनको बुला लूं?
हाँ, मैं उनसे अभी मिलती हूँ। ज्योति को तुम जानती होगी, हमारी ट्रांसप्लांट कोऑर्डिनेटर, जो पेशेंट से, फैमिली से ऑर्गन डोनेशन की बात करती है। तो ज़रा हम पहले डिस्कस कर लें कि हमने फैमिली से कैसे बात करनी है। तो फॉर आवर अंडरस्टैंडिंग, राजीव इज़ अ 44-year-old मेल जो 2 दिन पहले हमारे आईसीयू में सबअरेक्नोइड हेमरेज के बाद एडमिट हुआ है। उसके सारे टेस्ट हो चुके हैं और ये कंफर्म है कि वो ब्रेन स्टेम डेड है। जैसी, थोड़ा फैमिली के बारे में बताओ।
पिछले 2 दिनों से फैमिली आईसीयू के बाहर ही खड़ी है। उसकी वाइफ काफ़ी अपसेट है। उनके 2 बच्चे हैं, एक 12 साल का लड़का और एक 15 साल की लड़की। पेशेंट के पिताजी और उनके बड़े भाई यहीं पर हैं और पेशेंट की माँ बच्चे को लेकर घर गई हुई है। फैमिली काफ़ी परेशान है और अभी जानना चाहते हैं कि पेशेंट के साथ क्या हो रहा है।
ज्योति, तुमने पेशेंट के नोट्स पढ़ लिए होंगे। पेशेंट ऑर्गन डोनेशन के लिए सूटेबल है और अब हम उनकी फैमिली से बात कर सकते हैं। हमें ये सोचना होगा कि उनसे बात कैसे की जाए। मुझे लगता है कि हमें कुछ समय बिताना होगा उनको ये समझाने के लिए कि हमने सारे टेस्ट कर लिए हैं, उन टेस्ट का मतलब क्या है और वाकई में राजीव मर चुका है। जब मैं फैमिली से बात कर रही होंगी, अगर तुम्हें लगा कि कुछ मिस हो रहा है तो तुम ऐड कर सकती हो। हम दोनों एक साथ ये समझ पाएंगे कि उन्होंने पेशेंट की डेथ को एक्सेप्ट कर लिया है कि नहीं और उस हिसाब से हम लोग आगे बढ़ेंगे। अगर मुझे लगता है कि उन्होंने सब कुछ ठीक ठाक एक्सेप्ट कर लिया है, दे अंडरस्टैंड एवरीथिंग, तो मैं ऑर्गन डोनेशन की बात को शुरू करूँगी और तुम फिर उसको आगे ले चलना।
और अगर मुझे लगा कि फैमिली काफ़ी परेशान लग रही है और शायद पेशेंट की कंडीशन को ठीक से नहीं समझ पा रही है, तो क्या ये ठीक रहेगा कि हम उस समय एक ब्रेक ले लें और फैमिली से थोड़ी समय के बाद बातचीत करें?
हाँ, मुझे लगता है यही सही रहेगा।
एंड डिपेंडिंग अपॉन द सिचुएशन एट दैट टाइम हम डिसाइड कर सकते हैं कि ऑर्गन डोनेशन की बात उठाएं या नहीं।
मैम, मुझे लगता है कि फैमिली को अभी ब्रेन स्टेम डेथ के बारे में समझने में थोड़ी मुश्किल होगी।
आइए हम इस गुड प्रैक्टिस के कुछ महत्वपूर्ण पहलुओं के बारे में बात करें। जैसे कि हमने इस उदाहरण में देखा, कौन कौन मौजूद था। ये पूरी प्रक्रिया ट्रीटिंग डॉक्टर के नेतृत्व में होनी चाहिए और शुरू से ही नर्स और ट्रांसप्लांट कोऑर्डिनेटर इस चर्चा में शामिल होने चाहिए। इस तरह की प्लानिंग का मेन उद्देश्य क्या है? ये प्रक्रिया एक टीम वर्क है और हमारे बीच ये स्पष्ट हो कि हम फैमिली से कैसे चर्चा करेंगे, बातचीत के प्रमुख तत्वों को कौन किस समय उठाएगा और परिवार और पेशेंट से संबंधित मुद्दों के लिए कौन रिस्पॉन्सिबल होगा। इस उदाहरण के की एलिमेंट्स क्या हैं? डॉक्टर द्वारा क्लिनिकल स्थिति का स्पष्टीकरण करना, नर्स का परिवार के बारे में बताना, ट्रांसप्लांट कोऑर्डिनेटर का ये स्पष्ट करना कि अंगदान की बातचीत कैसे की जाए, परिवार के साथ अंगदान पर चर्चा करने से पहले उन्हें ब्रेन स्टेम डेथ की अच्छी समझ देना।
हाँ, नमस्ते, बैठिए बैठिए। नमस्ते मिस्टर अरोरा, राहुल, मिसेस अरोरा। मुझे आने में थोड़ी देर हो गई, आई एम सॉरी। मुझे पता है आप काफ़ी समय से मेरा इंतज़ार कर रहे हैं। एनीवे, नर्स जैसी को तो आप जानते ही हैं, ये ज्योति हैं। तो जैसे मैंने सुबह आपसे बात की थी कि हम राजीव पे कुछ टेस्ट करेंगे उनका बचा कुचा ब्रेन फंक्शन को असेस करने के लिए, तो वो जांच हो गए हैं और मैंने उनके परिणाम देख लिए हैं, मैंने डिस्कस कर लिए हैं अपने सीनियर से, अपने कोलीग से, और मुझे आपसे कहना है कि उनके ब्रेन ने काम करना बंद कर दिया है। आई एम वेरी सॉरी।
ब्रेन ने काम करना बंद कर दिया? ये आप क्या कह रही हैं डॉक्टर साहब? मुझे तो कुछ समझ में नहीं आ रहा।
इसका मतलब है वो ब्रेन डेड है।
मुझे तो विश्वास ही नहीं हो रहा।
एक मिनट रुको बेटा, मुझे नहीं लगता कि वो किसी भी दर्द में है। ऐसा लगता है कि जैसे वो भी सो रहा है।
You're right पापा, यहाँ तक कि नर्स ने कहा सब कुछ ठीक है और अब आप हमें कह रहे हैं कि वो नहीं रहा। और इस ब्रेन डेड से आपका क्या मतलब है?
मुझे पता है ये समझना मुश्किल है। राजीव का दिल धड़क रहा है, वो वेंटिलेटर पे है, पर कानूनी तौर से वो ब्रेन डेड है और वो बच नहीं सकता है।
मैं इसके बारे में कुछ नहीं जानता और मुझे कुछ समझ में नहीं आ रहा।
इस सिचुएशन में मुझे एक बात और आपसे करनी पड़ेगी। हमारे हॉस्पिटल की पॉलिसी है कि ब्रेन डेड पेशेंट की स्थिति में हम फैमिली से अंगदान की बात उठाएं।
अंगदान?
मैं अब वो नहीं सुन सकता, बस बहुत हुआ।
इस उदाहरण में आपको क्या गलतियां होती हुई दिखाई दी? क्या आप अपने स्वयं के एक्सपीरियंस से इनमें से किसी भी गलती को पहचानते हैं? सबसे पहले रूम की सेटिंग पर ध्यान नहीं दिया गया। चेयर कम है और दरवाज़ा खुला हुआ है। ट्रांसप्लांट कोऑर्डिनेटर को नाम से इंट्रोड्यूस तो किया, पर एक नए व्यक्ति के वहां
whose son's organs were donated, and she later on said, the doctor came and she's saying he kept standing, he didn't even sit down. In her mind, it was so disrespectful that usko itna bhi nahi laga ki main aake baith ke baat karu. He was in such a hurry. So that is a very significant message that you give to the families कि आप बैठे तक नहीं उठ के उसको. That's why they
उपस्थित होने के कारण को फैमिली को एक्सप्लेन नहीं किया गया। डॉक्टर परिवार की अभी की स्थिति को समझाने में असफल रहती हैं और ब्रेन स्टेम डेथ के टेस्ट के रिजल्ट्स में सीधा आ जाती हैं, लेकिन जल्दबाजी में और एक गलत तरीके से ऐसा करती हैं। इससे परिवार के दिमाग में संदेह पैदा हो जाता है। ये ज़रूरी है कि डॉक्टर सही शब्दों का इस्तेमाल करें, जैसे कि राजीव मर चुका है या राजीव की मृत्यु हो गई है। ब्रेन डेड या कानूनी रूप से मृत आदि शब्द सही स्थिति को नहीं दर्शाते और फैमिली को और कंफ्यूज करते हैं। अंगदान की बात बहुत ही जल्दी उठाई गई, इससे कहीं पहले कि परिवार पूरी तरह से समझ पाए कि उनके रिश्तेदार की मृत्यु हो गई है। इस वजह से फैमिली काफ़ी शॉक्ड दिखाई देती हैं और नेगेटिवली रिस्पॉन्ड करती हैं। आखिरकार अंगदान ही बहुत जल्दी नहीं उठाया गया, लेकिन ऐसा करने में डॉक्टर ने नकारात्मक और एपोलॉजेटिक भाषा का प्रयोग किया। तो आइए देखते हैं हम इसे कैसे बेहतर कर सकते हैं।
नमस्ते मिसेस अरोड़ा, राहुल, मिस्टर अरोड़ा। आप सब मुझे जानते हैं, जैसी से भी मिले हुए हैं। मैं आपको ज्योति से मिलवाना चाहती हूँ।
हेलो मिसेस अरोड़ा। हेलो।
ज्योति हमारे डिपार्टमेंट में काम करती हैं और ऐसे समय में परिवारों की सहायता करती हैं। सुबह मैंने आपसे कहा था कि हम कुछ टेस्ट करेंगे, वो हो चुके हैं। मैं ये जानना चाहती हूँ कि अभी तक की स्थिति को आप कितना समझते हैं। मुझे पता
He spoke about open-ended questions. Try to get out of the family कितना समझा
है कि आपने कई लोगों से डिस्कशन की हुई है।
मुझे पता है डॉक्टर कि राजीव के ब्रेन में बहुत ब्लीडिंग हुई है और आप कुछ टेस्ट भी करने जा रहे थे ये देखने के लिए कि उसका दिमाग अभी भी काम कर रहा है या नहीं। क्या ये सही है?
हाँ, ये बिल्कुल सही है।
तो क्या हो रहा है डॉक्टर? टेस्ट कैसे हुए? वो ठीक तो हो जाएगा ना?
तो मैं आपको इन टेस्ट के बारे में थोड़ा बताती हूँ। असल में इसका मतलब क्या है। दरअसल हमने बहुत ध्यान से राजीव के दिमाग की हरकतों की जांच की है, लेकिन अनफॉर्चुनेटली हमें कोई भी प्रतिक्रिया नहीं मिल रही है उनकी तरफ से, यहाँ तक कि गहरी स्टिमुलस देने पर भी नहीं। हमने 10 मिनट के लिए वेंटिलेटर को डिस्कनेक्ट किया, लेकिन इस दौरान उन्होंने सांस लेने का बिल्कुल भी प्रयास नहीं किया। आखिर में हमें ये पता चलता है कि उनके ब्रेन के फंक्शंस हमेशा के लिए चले गए हैं। वो कभी सांस नहीं लेंगे, वो कभी कॉन्शियस नहीं होंगे। मुझे बहुत दुख है, लेकिन राजीव की मृत्यु हो चुकी है। He has died.
उनकी मृत्यु हो गई है? मैं इस बात पे विश्वास नहीं करती।
मुझे समझ में नहीं आ रहा, इसका कोई मतलब नहीं।
What is that? Which stage of grief?
बनता।
सही कहा पापा। यहाँ तक कि नर्स ने कहा सब कुछ ठीक लग रहा है और अब आप हमें कह रहे हैं वो नहीं रहे, वो मर गए।
I am so sorry. राजीव मर चुके हैं। There is no brain function. इस स्थिति को पलटाया नहीं जा सकता। वो कभी वापस नहीं आएंगे।
ये आप क्या कह रही हैं डॉक्टर साहब? उन्हें कभी होश नहीं आएगा और आप कुछ भी नहीं कर सकती।
कुछ तो तरीका होगा आपके पास, आप कुछ तो कर सकते हैं। उसको आप ऐसे नहीं छोड़ सकते।
What's happening? Good.
देखिए, हम जानते हैं कि जब दिमाग में खून का बहाव नहीं होता है, इवन फॉर अ फ्यू मिनट्स, तो इंसान बहुत जल्दी मर जाता है। ऐसे में राजीव के दिमाग में भी खून का बहाव नहीं है, और वो भी कुछ घंटों से। उनका दिमाग मर चुका है, राजीव मर चुके हैं। वो सिर्फ वेंटिलेटर से कनेक्टेड हैं, और इसीलिए समझना और मानना बहुत मुश्किल है, क्योंकि उनका शरीर अभी भी गर्म है, उनका दिल धड़क रहा है। बट इट इज़ वेरी क्लियर कि राजीव मर चुके हैं।
ये क्या कह रहे हैं डॉक्टर साहब? मैं नहीं मान सकता कि आप कुछ नहीं कर सकते।
हे भगवान, मैं बच्चों को क्या बोलूंगी?
मुझे समझ आ रहा है कि ये सभी के लिए बहुत ही मुश्किल है और मुझे लगता है कि आप सबको आपस में कुछ समय साथ बिताना चाहिए और हम कुछ समय बाद फिर मिलते हैं।
परिवार के सभी सदस्यों को डॉक्टर शुरू में ही सबका परिचय देती हैं। ट्रांसप्लांट कोऑर्डिनेटर को एक फैमिली काउंसलर के रूप में इंट्रोड्यूस किया जाता है जो टीम के साथ काम करती हैं। फैमिली को इस समय उसके असली रोल के बारे में ना बताना उनको धोखा देना नहीं है, परंतु ये स्वीकार करना है कि फैमिली अभी तक अंगदान की बात करने के लिए तैयार नहीं है। उसकी ये भूमिका तब स्पष्ट की जाएगी जब फैमिली को ये समझ आ जाएगा कि उनके प्रियजन की मृत्यु हो गई है और वे अंगदान के बारे में जानकारी लेने के लिए तैयार हैं। डॉक्टर परिवार की वर्तमान स्थिति की समझ का असेसमेंट करती हैं और उसके आधार पर ब्रेन स्टेम डेथ की बातचीत शुरू करती हैं। उनकी बातचीत में कोई जल्दबाजी नहीं है और वो सरल और स्पष्ट भाषा का प्रयोग करती हैं। ऐसा करते हुए वे सुनिश्चित करती हैं कि परिवार को भरोसा हो गया है कि अब उनके प्रियजन ना ही ब्रेन डैमेज्ड है और ना ही कोमा में है, पर उनकी मृत्यु हो चुकी है और अंगदान की बात तब तक नहीं होनी चाहिए जब तक परिवार को पूरी तरह से इस बात का भरोसा नहीं हो जाए। हमारे उदाहरण में हालांकि हमें लगता है कि मृतक की पत्नी ये समझ चुकी है, पर परिवार के दूसरे सदस्यों
So the different family members are going through different stages of grief. If you notice, the wife said, "मैं बच्चों को क्या बताऊंगी?" So now she's thinking of future. She's accepted death, and now she's thinking, "How will I convey it to the children?" Whereas the brother is still angry. What is this? You told me. The nurse has also said everything is fine. So it's possible that different family members will be at different stages
में
of grief.
इस बात की पूरी समझ और स्वीकृति नहीं है। ट्रांसप्लांट कोऑर्डिनेटर इस सिचुएशन को समझती हैं और ये सुझाव देती हैं कि परिवार के साथ और समय बिताया जाए ताकि उन्हें अपने प्रियजन की स्थिति को समझने और स्वीकार करने के लिए और समय मिले। इस उदाहरण में अंगदान की चर्चा शुरुआत में नहीं की जाएगी। कुछ परिवार इस स्थिति को ज़्यादा आसानी से समझ लेते हैं और उनके साथ अंगदान की बातचीत एक स्वाभाविक रूप से उठाई जा सकती है। सबसे ज़रूरी बात यह है कि जब तक परिवार स्थिति को समझ ना लें और अपने प्रियजन की मृत्यु को स्वीकार ना कर लें, तब तक अंगदान की बातचीत शुरू नहीं की जानी चाहिए।
और डॉक्टर हम सब काफ़ी देर से बातचीत कर रहे हैं और मिसेस अरोड़ा, राहुल और उनके पापा अब आपके द्वारा किए हुए जो टेस्ट थे उनको काफ़ी अच्छी तरीके से समझ गए हैं और ये भी समझ गए हैं कि अब राजीव नहीं रहे।
आई एम सो सॉरी। मैं समझती हूँ कि ये आपकी फैमिली के लिए बहुत ही मुश्किल समय है, स्पेशली इन अ सिचुएशन जहाँ राजीव का दिल धड़क रहा है पर वास्तव में उसकी डेथ हो चुकी है। ये एक्सेप्ट करना बहुत ही मुश्किल है, पर मुझे विश्वास है कि आप लोगों को पूरा एहसास है कि राजीव की मृत्यु हो चुकी है। अब आगे क्या करना है हमें इस पर विचार करना होगा। मैं आपसे कुछ बात करना चाहती हूँ, शायद आप एक्सपेक्ट नहीं कर रहे होंगे, और वो है अंगदान। ज्योति इसके बारे में आपको और जानकारी देंगी।
अंगदान? बस बहुत हो गया।
हम जानते हैं और हम समझते हैं कि आप सब एक बहुत ही मुश्किल समय से गुजर रहे हैं, पर आपको ये याद रखना है कि राजीव अब कुछ भी महसूस नहीं कर सकते, वो कोई दर्द महसूस नहीं कर सकते क्योंकि अब उनकी मृत्यु हो चुकी है।
नहीं, मुझे लगता है हम सब वैसे ही बहुत मुश्किल दौर से गुजर रहे हैं।
मैं समझ सकती हूँ राहुल, एंड आई एम रियली वेरी सॉरी, पर राजीव एक ऐसी स्थिति में है जहाँ वो कई लोगों की जानें बचा सकते हैं और कई परिवारों की जिंदगियाँ बदल सकते हैं। मैं आप लोगों को कुछ जानकारी देना चाहती हूँ और आपकी मदद करना चाहती हूँ एक ऐसा डिसीजन लेने के लिए जो आप सबके लिए सही है।
हमने देखा कि ट्रांसप्लांट कोऑर्डिनेटर फैमिली के साथ कुछ समय बिता चुकी है, जहां वो फैमिली को पेशेंट की स्थिति के बारे में समझाती है। डॉक्टर परिवार से एक बार फिर बात करती हैं और जब पूरी तरह से संतुष्ट होती हैं तब अंगदान का टॉपिक उठाती हैं और बहुत ही स्वाभाविक रूप से ट्रांसप्लांट कोऑर्डिनेटर को डिस्कशन में इन्वॉल्व करती हैं। ट्रांसप्लांट कोऑर्डिनेटर पेशेंट के पिता के नेगेटिव रिएक्शन के साथ बहुत ही संवेदनशीलता से पेश आती हुई दिखाई देती हैं। वो एक पॉजिटिव भाषा में अंगदान की चर्चा करती हैं। ऐसा करने की अच्छाई पर सोचने के लिए फैमिली को प्रेरित करती हैं। वो ये बताती हैं कि उसका रोल इन्फॉर्मेशन देना है और डिसीजन लेने के लिए परिवार की सहायता करना है। ट्रांसप्लांट कोऑर्डिनेटर्स को परिवारों की इच्छाओं का पता लगाने के लिए ओपन क्वेश्चंस के प्रयोग की स्पेशल ट्रेनिंग दी जाती है। इस तरह की फैमिलीज के ग्रीफ को समझने और हैंडल करने की भी ट्रेनिंग मिलती है। ऐसा देखा गया है कि कई परिवार शुरुआत में ही मना कर देते हैं। एक ट्रेन ट्रांसप्लांट कोऑर्डिनेटर इस सिचुएशन को भी संवेदनशीलता और धीरज से हैंडल करती है। महत्वपूर्ण बात यह है कि ऐसे मामलों में जहां पेशेंट की इच्छा नहीं पता होती है, कानून करीबी रिश्तेदारों को निर्णय लेने की जिम्मेदारी सौंपता है और ऐसे ही परिवारों को इस तरह के समर्थन और जानकारी की जरूरत है। जो अप्रोच हमने देखी उससे दो उद्देश्य पूरे होते हैं। सबसे पहले ये अप्रोच परिवार को एक ऐसे समय समर्थन और देखभाल प्रदान करता है जो कि शायद उनके जीवन का सबसे कठिन समय है। दूसरा, इस अप्रोच में फैमिली को पर्याप्त समय दिया जा रहा है, पूरी जानकारी दी जा रही है और इस बात की पुष्टि की जा रही है कि फैमिली ने सिचुएशन को पूरी तरह से एक्सेप्ट कर लिया है। ऐसा करने से हम अंगदान की स्वीकृति के चांसेस को बढ़ा रहे हैं। शुरुआत से ही ट्रांसप्लांट कोऑर्डिनेटर की भागीदारी प्रस्ताव विधि के सभी स्टेप्स में होना काफ़ी लाभदायक साबित होता है। इन कार्यों के लिए उनकी ट्रेनिंग और परिवारों के साथ उनका रोज़ाना संपर्क उनका कौशल और अनुभव बढ़ाता है, जो कि डॉक्टर से कहीं ज़्यादा है, क्योंकि डॉक्टर बहुत कम परिवारों को रिक्वेस्ट करने में शामिल होते हैं। अंगदान के लिए हमारे परिवारों के इनकार के करंट हाई रेट्स में सुधार लाना यकीनन ही सबसे बड़ा योगदान होगा, जो भारत में ट्रांसप्लांट की संख्या को और बढ़ाएगा। ऐसा करने से कम लोगों की ट्रांसप्लांट की प्रतीक्षा में मृत्यु होगी या ट्रांसप्लांट वेटिंग लिस्ट में प्रतिबंधित या सीमित जीवन व्यतीत करना पड़ेगा। हमें यकीन है कि आप इस बात से सहमत होंगे कि ये ऐसा लक्ष्य है जिसके लिए प्रयास करना महत्वपूर्ण ही नहीं, सार्थक है।
Anybody here from Artemis? I thought somebody was supposed to come from Artemis. There is one person from Artemis? Probably left. Okay. That's the doctor is actually Dr. Reshma Tiwari, whom I've worked very closely with in Artemis. She's an excellent counselor, excellent partner to do this work with. Any comments? Bolo? You. अभी तुम्हें शायद ये एहसास नहीं हुआ है कि तुम आर्टेमिस में हो। सो डॉक्टर रेशमा के साथ मैंने बहुत काउंसलिंग करी है और बहुत ही मज़ा आता है उनके साथ। अब ऑफ कोर्स दिस वाज अर्लियर, नाउ देयर इज अ सेपरेट न्यूरो डिपार्टमेंट, सो मोस्ट द ट्रॉमा के yes, that is Artemis Hospital. We are very thankful to Artemis Hospital for letting it do there. And any comments, any quick comments on the movie, any questions? Okay. So, keeping the movie in mind, keeping the right and the wrong approaches, let's try to enact organ donation counseling case here. I need 5 volunteers, and it's not easy to do something like this, but I would request that people should not laugh and twitter because it takes away from the whole process. It's meant to make you learn, so let's treat it as such. Any 5 counselors quickly come. Aja, you're only a friend, I will not be there. Aja. 3 more, come.
नमस्ते। कैसे हैं आप सब?
हम तो ठीक है डॉक्टर साहब, ये बताओ हमारा बेटा कैसा है?
आपके बेटे के बारे में ही मैं बात करने आई हूँ कि अभी वो नहीं रहा है।
नहीं रहा?
मतलब? जी, वो उनकी मृत्यु हो चुकी है।
मृत्यु? अब सुबह तो ठीक था, अभी तो ठीक है।
जरा सी चोट लगी है सिर पे,
सिर पे
कुछ
चोट।
नहीं बताया गया इस बारे में?
नहीं, वो एक तरह का ब्रेन डेड हमने डिक्लेयर करते हैं हमारी
वो
जो
क्या होता है ब्रेन डेड?
उसमें हमारे दिल की धड़कन चल रही होती है, बिल्कुल नॉर्मल तरीके से होता है सब कुछ, पर जो भी हमारी नॉर्मल एक्टिविटीज़ होती हैं, हमारे ब्रेन की तरफ से जो भी रिफ्लेक्सेस मिलते हैं वो ख़त्म हो चुके होते हैं।
पर आप कह रहे हैं कि धड़कन चलती है तो मतलब इंसान मर नहीं सकता?
मर नहीं सकता, पर उनका ब्रेन ख़त्म हो चुका है। जो नॉर्मल एक्टिविटीज़ होती हैं वो नहीं काम कर रही हैं, जो अपने तरीके से काम करना होता है वो शरीर अब नहीं काम कर रहा है।
मैम आप देख लो, कुछ भी कर लो, हम कहीं रेफर कर दो, कुछ भी कर लो, प्लीज़ बचा लो प्लीज़।
देखो उसमें तो कुछ अब किया नहीं जा सकता, बट हम ये ज्योति हैं मेरे साथ काम करती हैं, आप थोड़ा सा समय लीजिए, इनके साथ थोड़ी सी बात कीजिए, ये आपको और ज़्यादा बेहतर समझा सकेंगी।
मगर डॉक्टर साहब हम तो आपके भरोसे आए थे, इतना बड़ा हॉस्पिटल, आप कुछ तो करिए। जब धड़कन चल रही है तो कुछ तो हो सकता है।
आप थोड़ा सा हमें समय दीजिए, आप एक बार इनसे ज्योति से भी बात कीजिए, मैं आपको थोड़ी देर में फिर आके मिलती हूँ।
ब्रेन डेड स्टार्टिंग में बता दिया, हमें बताना चाहिए था कि इनकी ऐसी कंडीशन है, पहले ये हुआ था, हम उसको यहाँ पे लेके आए, टेस्ट किए, तो कुछ हमें पता होना चाहिए।
What did the audience feel about the doctor's approach? Very true fact. It's very true. Doctor is the one person in this whole situation that has to come with authority. He knows his job. He knows what he's done. Authority does not mean that you can't show sensitivity. आते ही तुम बताओगे फैमिली को मर गया. You know, think of them as parents of an 18-year-old boy. And your coming did not show that you had a relationship with this family. Did you have a relationship with this family or you're coming for the first time? बोलिए मिसेस अरोड़ा, आपको पता है मैं आपसे 2-3 दिन से मिल रहा हूँ, रोज़ आपको बता रही हूँ मैं इनकी हालत के बारे में, और काफ़ी गंभीर हालत में वो आया था. That is how you begin. How did the doctor start in that film? Huh? One person, sorry? No, apart from the introduction. Okay, what else? That's very important. She said, the doctor asked an open-ended question. She said कि मैं आपको 2-3 दिन से बता रही हूँ कि कुछ टेस्ट करने वाले हैं, आप क्या समझे उस टेस्ट से? She left it to this thing. So this was too abrupt a start. Should we try to do it again? Let's try to do it again.
ठीक, मैं इधर से। गुड आफ्टरनून मिसेस अरोड़ा, मिस्टर अरोड़ा।
नमस्कार मैडम।
और अभी मैं आपसे काफ़ी दिनों से बात कर रही थी, तो अभी उसकी हालत काफ़ी गंभीर ही है। मैंने आपको बोला था कि हम कुछ टेस्ट करेंगे।
मैम हम आपके भरोसे बैठे हुए हैं।
मैं आपसे वही बात कर रही हूँ कि हमने आपसे 2-3 दिनों से वही बात कर रहे हैं कि हम कुछ टेस्ट करेंगे जो हमें बताएंगे कि उसकी कंडीशन कैसे चल रही है। तो अभी मैं बस यही बोलूँगी आपको कि आपके बेटे की मृत्यु हो चुकी है।
मैडम अच्छा।
What did we do wrong again here? In the same sentence, you said अभी हालत गंभीर है.
And then you said
you can decide, even if you know that the boy is brain dead, you may decide that this first conversation is just to prepare them. Maybe you don't want to give the news. That is a strategy that as a doctor you will follow. But you can't say in the same breath, हालत गंभीर है, मृत्यु हो गई है. ठीक है? But what I did like the fact is that unlike the first time you came and said, Mr. Arora, आप कैसे हो? It's not a social gathering here. आप कैसे हो सकते हैं जिनका बच्चा 18 साल का हो. So we do away with those niceties. We're not here to do this, which is fine. You didn't do it next time. But you have to decide very strategically कि ये वाली जो मेरी मीटिंग है इस फैमिली के साथ वो किस लिए है. वो न्यूज़ देने के लिए है कि उनको बैड न्यूज़ प्रिपेयर करने के लिए. Maybe you want to come again after half an hour to give the bad news. But right now you want to understand where are they. ठीक है? Anybody else wants to try the doctor's role? Some more volunteers? Let everybody get chance. Aaja. Nothing is wrong and right here. This is a very awkward situation for anyone to do. It's not easy. In fact, great thing for the volunteer. Actually, you will all do better in the actual situation. This is more complicated. Very well.
Hello, Mr. Arora. Hello, Mr. Arora. Myself, you know, myself, Dr. Pathak. I am treating your patient, and I am here to explain about something. जैसे कि मैंने आपको बताया पहले भी कि आपके जो बच्चे की तबीयत है वो काफ़ी ख़राब है, जैसे कि आप लेके आए थे। आप भी 2-3 दिन से आप देख ही रहे हैं कि आपकी तबीयत थोड़ी बच्चे की ख़राब है, तो आप अभी तक क्या जान पाए उनके बारे में? आपको क्या लगता है कि क्या हो रहा है आपके बच्चे के साथ में, कैसा उसका ट्रीटमेंट हो रहा है, क्या प्रोग्रेस होना चाहिए, कैसा आपको लग रहा है अभी तक?
डॉक्टर साहब आपने बताया था कि उसका कोई ब्रेन टेस्ट होगा, हम तो उसी का वेट कर रहे हैं अभी, जो आपने बताया था कि ब्रेन टेस्ट होगा उनका कोई।
जी, और इसके अलावा
2-4 दिन से बताया जा रहा है कि हालत गंभीर है, उसके अलावा हमें कुछ नहीं बताया गया। डॉक्टर साहब कुछ बताइए क्या
आपके मन में क्या चल रहा है अभी कि यहाँ पे क्या आपको ट्रीटमेंट सही मिल पा रहा है, नहीं मिल पा रहा है, या आपके बच्चे के साथ जो हो रहा है वो सही हो रहा है?
अब डॉक्टर साहब हम तो आपके भरोसे आ रहे कि इतना बड़ा
जी
अस्पताल है,
बिल्कुल, आप सही कह रहे हैं, आप मेरे भरोसे आए हैं, तो मैं उसी के बारे में आपसे बिल्कुल सही कह रहे हैं आप, उसी के लिए मैं आपसे थोड़ा बात करने के लिए आया हूँ कि जो भी हमने टेस्ट किए हैं अभी, जैसे हमने सुबह आपको डिस्कस किया था कि हमें थोड़ा ब्रेन टेस्ट करना है उनका, और कुछ इन्वेस्टिगेशन थोड़ी पेंडिंग थी, वो सारी हमने अभी कलेक्ट की हैं और मैंने चेक की हैं और मेरे सीनियर्स ने और कोलीग्स ने सबसे चेक करके हम इस निष्कर्ष पे पहुँचे हैं कि जो आपका बच्चा है उसका दिमाग अभी पूर्ण रूप से समाप्त हो चुका है और वो भी काम नहीं कर रहा है। एक मिनट में पूरा कर लूँ, फिर आपके क्वेश्चन भी मैं एक करके ले लूँगा। ब्रेन उनका काम नहीं कर पा रहा है, लेकिन उनका हार्ट अभी बीट कर रहा है, वो वेंटिलेटर पे है, आपको पता है कि वेंटिलेटर पर डाला हुआ है हमने उनको, वो सांस ले रहे हैं वेंटिलेटर के कारण, दिल धड़क रहा है, शरीर में गर्मी है, तो ये सारे फैक्ट हैं उनके साथ में, लेकिन दिमाग नहीं काम कर रहा है, जिस कंडीशन को हम मेडिकल साइंस के रूप में अगर बोलें तो उनकी ब्रेन डेथ इनको हम बोलते हैं मेडिकल साइंस की लैंग्वेज में, कि वो दिमागी रूप से आपके जो हैं वो नहीं रहे अब।
मतलब आपके कहने का मतलब कि वो कोमा में? नहीं,
ये कोमा नहीं कह सकते इसको हम, ये ब्रेन डेड होता है मेडिकल साइंस में अगर इसको बोलेंगे, तो दिमागी रूप से आपका जो पेशेंट है अभी नहीं रहा, वो उनकी मृत्यु हो चुकी है। मुझे बहुत दुख के साथ मैं कह रहा हूँ कि अभी उनकी मृत्यु हो चुकी है। सारे एफर्ट हमने किए हैं, बेस्ट से बेस्ट जो हम कर सकते थे हमने किया है, बट फिर भी हमारे हाथ में बहुत कुछ नहीं होता है, उसके कारण मैं आपसे बोलना चाहूँगा।
डॉक्टर साहब एक बार प्लीज आप चेक कर लो, क्या वो कोमा में हो? मैंने कोमा तो सुना है, पर दिमागी ब्रेन डेड ये क्या होता है हमें नहीं पता।
हाँ सर, आप नहीं समझ पाएंगे इस बात को, इसी के लिए मैं दोबारा से बताऊँगा आपको कि सारा कुछ चेक करने के बाद ही मैं आपको एक्सप्लेन कर रहा हूँ सर चीज़ें।
और डॉक्टर साहब आपने तो कहा दिल धड़क रहा है।
हाँ, दिल धड़कता है, एक्चुअली क्या 2 सिचुएशन होती हैं पेशेंट की, एक हार्ट डेड होता है, एक ब्रेन डेड होता है। तो अभी जो आपका पेशेंट है वो ब्रेन डेड हो चुका है, हार्ट उसका काम कर रहा है बिकॉज ऑफ वेंटिलेशन।
What are you understanding as parents?
Ma'am, actually, I understand that there is still hope. Like if heart is beating.
And where is that hope coming? What did he say that hope came?
Ma'am, सांस ले रहे हैं और दिल काम कर रहा है. So, ma'am,
they are in confusion. How could he have done it better? The family is still confused. कि brain dead. He did a good job of brain death, and then he himself confused them by saying, तुमने वो वेंटिलेटर की बात बोली भी तो बोलो, जैसे ही वेंटिलेटर निकालेंगे ये सब काम होना बंद हो जाएगा, क्योंकि वो हर तरीके से अब वो नहीं रहे, क्योंकि हमने मरने से पहले, क्योंकि ब्रेन डेथ से पहले उनको वेंटिलेटर पे डाला था। वेंटिलेटर अभी भी हार्ट को पंप कर रहा है, बट वो आर्टिफिशियल सपोर्ट है बिकॉज पेशेंट अब नहीं रहा। हाँ, यू वांट टू से क्या?
नमस्कार मिस्टर अरोड़ा,
मिसेस अरोड़ा। फैमिली के पास बिकॉज दे आर होपिंग अगेंस्ट होप। इनको तो डूबते को तिनके का सहारा होता है। दे विल होल्ड ऑन टू दैट सेंटेंस ऑफ योर्स, बट गुड बॉडी लैंग्वेज देयर।
जैसा कि सुबह मैंने आपसे कहा था और हम 2 दिन से इस बारे में बात कर रहे हैं, तो सुबह मैंने आपसे कहा था कि हम एक टेस्ट करेंगे, तो मैं उसके बारे में आपसे डिस्कस करती हूँ। पर मैं अभी जानना चाहती हूँ कि आप इन सब सिचुएशन के बारे में क्या समझे हैं, कि अभी क्या आपके पेशेंट के साथ हो रहा है, और जैसा कि नर्स के द्वारा या हमारे द्वारा जो चीज़ आपको बताई गई है, वहाँ तक आपको अभी तक क्या समझ आया?
हमें तो डॉक्टर इतना ही समझ में आया कि हमारे बेटे की हालत काफ़ी ख़राब है, और बाकी आप ही बताएंगे। आपने कहा था टेस्ट के बाद सब कुछ देखेंगे ठीक होगा या और भी ख़राब होगा।
जी, तो अभी जो हमने टेस्ट किया है उसमें जो आपके बेटे का दिमाग है वो काम करना पूरी तरीके से बंद हो चुका है और वो डेड हैं अभी। और अभी उनकी कंडीशन ये है कि वो अभी
डेड, अभी तो सांसें चली है उसकी।
जी, सांसें जो चल रही हैं वो मैं आपको बता देती हूँ कि जो टेस्ट में ब्रेन डेड हो चुके हैं और जो सांसें हैं वो वेंटिलेटर पे हैं, इसलिए वो चल रही हैं और वो भी कुछ ही घंटों तक संभव है। जैसे ही वेंटिलेटर से हम उन्हें हटाएंगे तो वो दिल भी धड़कना बंद हो जाएगा, जो बॉडी टेम्परेचर है वो भी नहीं रहेगा और वो दैट विल बी कम्प्लीटली डेड। तो अभी जो ब्रेन डेड की जो कंडीशन है वो उसमें वो दोबारा ज़िंदा नहीं हो सकते, ऐसा कुछ हम नहीं कर सकते अभी कि वो ज़िंदा हो सके।
नहीं डॉक्टर, ऐसे आप नहीं कह सकते, कुछ तो करना होगा आपको।
मैं समझ सकती हूँ आपका दर्द और मैं जानती हूँ अभी, पर अभी ही इज़ डेड अभी।
What do you feel about the doctor? Very sure, which is good. Great verbal skills, Simran. Poor body language skill. This crossed leg. Utho. This is your stance was this, and you are looking back. You are away from the family. The ideal situation is I always sit down like this. I'm interested in you. I'm concerned about you. I'm hopeful. You have to have a combination of both. So what the words that you used were far effective. There was confidence. There was firmness. Yes, but it shows a stance that is very removed from the family. You have to create that. This family should know that you are also equally sad about giving this news, and it's not just another case for you. मर गया बता रहे हैं, you know. So it has to be a combination of both. So yes, clarity. तो इससे समझ में आई तुम्हें डेथ की बात, इससे ज़्यादा समझ में आई, but that connection has to be established. All right, let's assume the family has accepted brain death. Now we have to start the organ donation conversation. Anybody wants to volunteer for that? Organ donation की बात उठाने के लिए कोई volunteer करना चाहता है? I know. मेरे पास enough roles नहीं है यहाँ पे देने के लिए. चलो सिमरन, you start pick up the conversation of organ donation.
तो अभी हमारे साथ मिस्टर संदीप हैं जो ट्रांसप्लांट कोऑर्डिनेटर हैं इस हॉस्पिटल में, जो कि आपकी आगे की चीज़ों को समझने के लिए और आगे की जो सिचुएशन चल रही है उसको समझने के लिए आपकी मदद करेंगे।
Okay, once again, there was something about how Jyoti was introduced in the film. Anybody remembers? Huh? It's too much for family to take transplant coordinator. I have a problem with that terminology, Dr. Shroff. I really have a problem. Why did the law write it? But that's okay. It's up to the hospital's jurisdiction to decide. So use softer terms. My family counselor है, हमारे social worker हैं जो आप ऐसे. So don't use the word transplant coordinator either. It's very scary for families. I find it scary the word.
मिस्टर संदीप हमारे साथ हैं जो एक काउंसलर है यहाँ पे, सोशल वर्कर है जो आगे की सिचुएशन को आपको समझने के लिए मदद करेंगे। तो आप कुछ देर इनके साथ बातचीत कीजिए, तो मैं मिलती हूँ आपसे।
जी अरोड़ा जी, जैसा कि डॉक्टर साहब ने आपको बताया कि अब आपके बच्चे की मृत्यु हो चुकी है, तो इस समय आपका ये जो समय है आपके लिए, मैं समझ सकता हूँ आपका समय बहुत कष्टों भरा है, बहुत दुख है, बहुत टफ टाइम है आपके लिए। लेकिन इसमें ये बात करना सही रहेगा नहीं सही रहेगा मुझे नहीं लगता, लेकिन एक छोटी सी होप है किसी और के लिए जो मिस्टर अरोड़ा भी नहीं रहे, लेकिन उनके कारण किसी को नया जीवन मिल सकता है, जिसके बारे में आपसे बात करना चाहता हूँ, या मैं बात कर रहा हूँ आपसे। आपको पता चल गया कि वो उनकी मृत्यु हो गई है, लेकिन उनके कुछ ऑर्गन्स हैं जिनके बारे में थोड़ा बहुत आपने सुना ही होगा कि अगर हम किसी को अन्नदान देते हैं तो किसी मरते हुए आदमी को हम नया जीवन दे सकते हैं। तो मैं यही आपसे डिस्कस करना चाहूँगा और बताना चाहूँगा कि
डॉक्टर साहब उसका फ़ायदा क्या होगा? हमारा बच्चा तो वापस नहीं आएगा।
नहीं, देखिए इसमें फ़ायदा और नुकसान
तो हमारा धर्म नहीं मानता है
जी। ऐसा धर्म में, देखिए धर्म की अगर बात करें तो धर्म में ऐसा कहीं नहीं लिखा हुआ है कि अंगदान नहीं कर सकते हैं, या कि ऐसा फ़ायदे वाली बात आपने बोली, इसमें फ़ायदा और नुकसान की बात नहीं है। आपका बच्चा तो देखो अभी रहा नहीं, लेकिन उसके कारण अगर किसी की ज़िंदगी में नई रोशनी आ सकती है और नया जीवन उसको मिल सकता है, तो इससे अच्छा शायद उसके जीवन में और उसके लिए कुछ और नहीं हो सकता। और आपके लिए भी एक बहुत अच्छा एक नोबल काम रहेगा कि आपने किसी मरते हुए आदमी को नया जीवन दिया है। तो थोड़ा इसके बारे में आप सोचिए और डिस्कस कीजिए, उसके बारे में आपसे हम दोबारा से बात कर लेंगे। अगर आपकी नो है तो नो रहेगी, अगर आप चाहते हैं कि हम एक अच्छा काम करें और इसमें एक थोड़ा सा आपकी किसी मरते हुए आदमी को नया जीवन दें तो एक आपकी अच्छी पहल रहेगी सर।
पर ये हमें कैसे पता होगा कि आप किसी मरते हुए इंसान की मदद करेंगे? क्या पता आपने वो ऑर्गन किसी और को दे दिए या फिर बेच दिए? आजकल तो बहुत चल रहा है ये सब चीज़ें।
जी मैम, आप बिल्कुल सही कह रहे हैं, आप बिल्कुल अपनी जगह पे सही हैं। ऐसे काफ़ी सारे काम हो रहे हैं, लेकिन जो ये संस्था है हमारी, जो हमारा हॉस्पिटल है, ये गवर्नमेंट के द्वारा सर्टिफाइड है। वहीं से ये सारी इन्फॉर्मेशन, आप एक साइट है नोटा, जहाँ पे हम आपको उसकी इन्फॉर्मेशन अवेलेबल करा देंगे।
क्या हम उन लोगों से मिल सकते हैं जिसके लिए हमारे बच्चे के दान ऑर्गन डोनेट हो गए?
नहीं सर, प्लीज, ये कॉन्फिडेंशियल काम है, इसमें आप उनसे नहीं मिल सकते हैं।
तो फिर हमें कैसे पता चलेगा कि आपने हमारे बच्चे के ऑर्गन बेचे नहीं हैं? और क्या पता आप चाहते ही यूँ शुरू से, इसलिए आपने वेंटिलेटर हटा दिया हो?
जी नहीं मैडम, ये मल्टीपल टेस्ट के बाद हम इसको डिसीजन में पहुंचते हैं कि आपका बच्चा अब नहीं रहा है। ऐसा नहीं है कि एक टेस्ट के बाद हमने आपको बोला है कि नहीं रहा आपका बच्चा है। मल्टीपल टेस्ट होते हैं, मल्टीपल टीम, डॉक्टर्स की टीम होती है जो डिसाइड करती है कि वो है या नहीं है।
सर अब अभी तो हम इस बारे में कोई बात नहीं करना चाहेंगे।
कोई
हम
बात
आपस में
टेक योर, आप थोड़ा सा अपना समय लीजिए। आप
How could he have started the conversation differently? How could he have done something different? These are the parents of an 18-year-old boy. It's a different situation कि इस सिचुएशन में ग्रीफ दिखा नहीं पा रहे। ऐसे कद माँ की क्या हालत होगी कि समझ सकते हो? इसकी अभी नीड क्या है मदर की, स्पेशली मदर की और फादर की, दोनों की क्या नीड है इस वक्त? They want to talk about the child. They want to probably reminisce about the child. You know, तो थोड़ा सा रिलेशनशिप बिल्ड करना बहुत ज़रूरी है before you come to organ donation. You said अनमोल क्या करता था? कॉलेज जा रहा था, you know, कौन से ईयर में था? अच्छा, talk about what is interest. ये कब हुआ? ये कहाँ जा रहा था जब ये हुआ? Because right now their need is to talk about their loved one. You have to address that need. अभी तक तो कोई नॉर्मल सिचुएशन होता तो रो रही होती, तो तुम तो क्या ही ऑर्गन डोनेशन की, तो अब नॉर्मल सिचुएशन है, रोना धोना नहीं हो रहा है, बट give them time to understand that you cared for that person as a person also and not just organs. थोड़ा relationship establish करो and then say, आपने कभी as a family कभी आई डोनेशन के बारे में कोई डिस्कशन हुआ था? कुछ और, you know, इस तरह की बातें निकल के आती हैं। फिर कई बारी families खुद ही बोलते हैं, always wanted to help others, my child always wanted to do something good. वो तो ये ऑटोमेटिकली स्वाभाविक मैंने में वो निकल के आना चाहिए, एकदम से शुरू से ही नहीं कूद पड़ो ऑर्गन डोनेशन, दैट कैन नॉट बी योर फर्स्ट सेंटेंस, ठीक है? बट यू डिड अ गुड जॉब and I think they asked questions and you did a good job of clarifying. I remember one husband था, almost अभी recently आर्टिफिस में 20-25 मिनट तक वो अपनी वाइफ के बारे में बात कर रहा था कि मैम वही सब संभालती थी, जो मेरे सारे जिनको रेंट दिया हुआ था घर में वही करती थी, मदर को कौन सी मेडिसिन मिल रही है नहीं मिल रही है, and all of that. And we talked for so long about the wife, and when I brought up organ donation, he got very upset, and he did exactly what she said कि इससे मेरा क्या फ़ायदा होगा? नहीं, आपका तो आपकी लॉस की तो भरपाई कोई भी नहीं कर सकता, but and then you know and we moved on. He ultimately refused, but you know before going he said, "Ma'am, I'm very sorry, मैं हाथ जोड़ के माफ़ी मांगता हूँ कि मैम से रूडली बात करी." मैंने कहा नहीं, कोई माफ़ी मांगने की ज़रूरत नहीं है, इस तरह की सिचुएशन में जो तुम्हारा रिएक्शन है वो तो बिल्कुल नॉर्मल ही है, you've lost somebody, but at least we spent some time talking about his wife, and then before going he said, "ये मेरा decision alone नहीं है, ये I'll have to ask her parents." But by that time I knew कि उसमें हिम्मत नहीं है करने की, but that's okay. But थोड़ा एक ह्यूमन टच लाना बहुत ज़रूरी है. You can't be just fixated on your goal कि मुझे organs लेने हैं. Of course हमें लेने हैं, वो हमें बात करनी है, but how you arrive at it has to be a softer process is what I'm saying. Anybody wants to take a
नहीं नहीं, एक मिनट मैम, जरा इन्होंने एक लास्ट वो एक काउंटर क्वेश्चन किया था इन्होंने कि आप कैसे वो करेंगे, हमें कैसे श्योरिटी होगी कि हमारा ऑर्गन सेल नहीं हो रहा है, तो उसके लिए क्या बोल सकते हैं?
बोलो, ये बताओगे कि यहाँ इस पूरे हम लोग सब जो काम कर रहे हैं कानून के इन कानून के बारे में भी बताना बहुत ज़रूरी है. व्हेन फैमिली सस्पिशियस कि अपनी मर्जी से नहीं घूम रहे हम दुनिया में, देयर इज़ अ लॉ दैट टेल्स अस व्हाट टू डू. उसमें कोई भी ऑर्गन्स का लेना या बेचना कानूनी जुर्म है. इतना बड़ा हॉस्पिटल बैठा हुआ है, आप रोज़ पढ़ती होंगी देयर शुड बी अ फाइल इन योर रूम ऑफ ऑल द ऑर्गन डोनेशन. ये सब तैयारियां पहले करके रखनी है. जो दुनिया भर के आर्टिकल्स हैं ऑर्गन डोनेशन पे, उनकी कॉपीज़ रखो, देखिए कितने लोगों ने किया है. आप किसी और से बात करना चाहेंगी, मैं किसी और फैमिली से आपकी बात कराऊँ, आप हॉस्पिटल के सुपरिटेंडेंट से बात करना चाहेंगी. लेट देम नो दैट इट्स अ बिगर ऑपरेशन. किसको ऑर्गन मिलेगा हम डिसाइड नहीं करते, इज़ अ गवर्नमेंट एजेंसी. आप उनसे किसी से बात करना चाहेंगी, लेट देम नो दैट यू आर विलिंग टू लेट देम टॉक टू एनीबडी. चाहे करें ना करें वो दूसरी बात है, बट एक फीलिंग ऑफ ट्रस्ट आ जाती है. हाँ, आप
एक चीज़ इसमें डॉक्टर का एक रोल हो सकता है, अगर एक चीज़ ऐड करें इसमें, ये भी हो सकता है कि जैसे पेशेंट आता है, पेशेंट हमसे काफ़ी उम्मीद रखता है कि डॉक्टर आए तो अब एकदम से पेशेंट को एक जादू करके ठीक कर देगा, उम्मीद भी होती है। तो पहले डॉक्टर जो होते हैं, मतलब पेशेंट को सबसे पहले समझाने का तरीका ये होता है कि भाई मैं भी आपकी तरह एक इंसान हूँ, गॉड नहीं हूँ, मैं पूरी जान लगाऊंगा, अपनी तरफ से कोई एफर्ट नहीं छोड़ूंगा, पर करने वाला वो है जो भी है। तो एक इस पर एक ऐड ये भी हो सकता है। दूसरा कि जब पेशेंट आया फिर हमने कोशिश करी पर वो नहीं बच पाया किसी तरह से भी, तो उसके पेशेंट के साथ, अटेंडेंट के साथ बुला के उनको एक सहानुभूति देना, मतलब एक थोड़ा सा कंधे पे हाथ रख के कहना कि हमने कोशिश आपकी तरफ से बहुत करी, मैंने पहले ही कहा था कि गॉड नहीं है हम, मेरी लाइफ कितनी है मुझे नहीं पता।
बोल रहे हैं, जो एंड ऑफ लाइफ की एक डिस्कशन नहीं है, आपने हर समय उस फैमिली को आके बताया कि अब हम ये करने की कोशिश कर रहे हैं। हाँ,
कि मुझे नहीं पता कि मेरी लाइफ कितनी है, अगर मैं डॉक्टर होता और अपनी लाइफ 100 साल कर सकता तो पहले अपने आप करता, तो करने वाला तो गॉड है।
हमने अपनी पूरी कोशिश करी, जो हम कोशिश कर ये भी कराई, सर्जरी भी करी, व्हाटएवर नहीं हो। आपको पता है कि आपका बेटा काफ़ी गंभीर हालत में आया था, बहुत छोटे थी, दिमाग पे बहुत चोटें पड़ी थी। सो लेट द डॉक्टर कन्वे कि इसको पता था मैं क्या कर रहा हूँ, मुझे पूरी जानकारी थी और तुमसे मिलता रहा। एकदम से लास्ट मिनट में आओगे ना डॉक्टर, तो एक ऑकवर्ड कॉन्वर्सेशन होगा बहुत। सो यू हैव टू हैव एस्टैब्लिश अ रिलेशनशिप। सबके नाम पता होने चाहिए, क्या नाम था बच्चे का, नाम आपका पेशेंट नहीं बोलो, जो बच्चे का नाम है उसको यूज़ करो। 18-year-old बॉय आफ्टर ऑल, ठीक है। Should we end here? If anybody has anything to add to this, thank you so much for all the volunteers.
माइक दे दो।
Some celebrations in life in that way, some positivity. He will carry on living in a small portion of his and somebody else, multiple people, and that's what life is about. After all, we come from dust, dirt, and we go back to dirt. So you need to have those kind of kuch ऐसे शब्द, you need to practice those sentences, do some mock drills between yourselves, and get the confidence building. And today you are very nervous. None of you wanted to come in front. I can understand because you haven't practiced. But when you do a longer workshops, we also have 1-year program. So when you do longer workshops, we have more time for these things. तो एक दिन 2 दिन की हमारे एक्चुअली हमने एक फैमिली काउंसलिंग की हमने ना अलग से एक मॉड्यूल बनाई है 2 दिन की, ऑनलाइन ही है। तो उसमें हमने अलग अलग सिनारियोज दिखाए हैं वीडियो से ही, वीडियो सिमुलेशन करके। तो इफ़ यू वांट यू कैन टेक दैट फैमिली कॉन्वर्सेशन कोर्स ऑल्सो। Actually, this course also should be for doctors, क्योंकि as doctors we are very poor communicators, क्योंकि हमको सिखाया नहीं जाता है कैसे बात करना है इस सब के बारे में। जब हम MBBS करते हैं और हम जब पोस्ट ग्रेजुएशन करते हैं तो it is taken for granted that we know how to speak about end of life and how to, we don't. So actually abroad में Australia, England and other places, US, it's compulsory for ICU doctors to do a grief counseling 1-day workshop before they jump into this. Especially the intensivist का बड़ा role is very, very important. And we keep talking about Spain all the time. Spain इसलिए ज़्यादा successful है क्योंकि उनके सब जो डॉक्टर हैं वो कोऑर्डिनेटर हैं, उनको सबको वर्कशॉप के थ्रू लिया जाता है, and they speak to the family, most of them, not the nurses. Whereas England में it is the nurses who do it. So सब country का अलग अलग approach है. So as doctors also, this is required, how to do family conversation. And you saw how Pallavi was saying, आगे बढ़ो, ये करो. And we necessarily don't know those skills, These are soft skills. And we're never trained for soft skills. And this is all about soft skills. And हमारे ऐसे coordinator हैं जिनके success is 95%. They never get a no from the family. All families will say no. Most of families will say no. But the no is not no because they don't understand the process. So, and we have coordinators who don't have any success. So it's all about the body language. It's all about your soft skills, कैसे आप कम्युनिकेट करते हो, कितना आप उसमें पैशन डालते हो अपने कॉन्वर्सेशन में, कितना उसके बारे में सोचते हो. पर these are difficult situation, difficult conversation. And कभी कभी जो grief होती है दूसरे की, वो आप में भी अंदर आ जाती है. Then there is burnout. Coordinators often have burnout, especially the senior coordinator. And then you need to take a break to cleanse yourself, to clean yourself, to come back into the system. And that's why probably Pallavi goes and climbs mountains all the time. That is required. That is required, you know, in life, because we're all human beings after all. So practice kariye jaake, and I'm sure you'll all do well. Okay, thank you.
Thank you, sir. And with that, we come to the end of today's proceedings. So I think we have covered more than 95% of the syllabus we had, and tomorrow would be the last day. So two announcements. Number one, that all of you are invited for the conference dinner tonight. Please carry your ID tags, which have been provided, delegate badges. So it is at Sector 35 JW Marriott Hotel. You will have a one-to-one conversation. All the faculty would be there. So you can have a direct conversation with whatever topics you had learned, whatever doubts you had, you can talk to them directly. Number two, all of you who have registered for the photographs, so tomorrow morning you can collect it from my office. Reena is there in my office. So we had labeled the photographs as A and B. So whosoever wants the picture, kindly register your name and pick it up from my office. All right? So with that, we end the day and see you in the dinner evening. Okay? Bye.